रेकॉर्डिंग चालू कर. रेकॉर्डिंग.
हाँ, ये लाइट बंद करो.
लाइट बंद कर दे. ये नाही.
So pump is not working. Do something.
वो प्रेशर और बढ़ा के दे.
फुसुक 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 आ रहा है.
उधर वॉश करके लिखा होगा ना, वो देखे देखे एक बार. ये हाँ.
Okay, lot of information. I need to do a rotator interval release because this is all inflamed, but I'll do it later.
स्टीव है.
Stiff है, stiff है. So we won't do the interval release, just remind me. But that subscap cuff, everything is good. So इसका problem नहीं. Our main job is to come in the subacromial.
सर लेंगे हाथ से.
Oops.
शिवर का पेडल नहीं दिख रहा है मुझे.
पुढच्या केसला एक मी ट्रॉली ठेवून द्या.
नाही करू शकत ना काय करायला. ग्राफ काढायचा असतो.
पायाच्या वरती ग्राफ केल्यावरती पायाच्या वरती राहील. नाही ते धडपड ते लाईव्ह याच्यात नवीन मंडळी आहे, पडलं बिडलं तर इथे बॅकअप सेट नाहीये.
करतो.
Needle knife, kidney trail.
एकदम अंधेरा मत करो रे.
नींद आ जाएगी. स्टिफ है. एक्सरे है उसका वहां लगाने लायक.
आपलं करून घेतलं.
आता नाही, मग ते सगळं स्वेलिंग होणार. आपल्याला सगळं इथूनच करायचंय सभागृहामध्ये. सोलन सोलन केलं.
क्वेश्चन का ये फुट पेडल का आगे कर दी सर की. नहीं दोनों के आगे ही. वो राइट पैर में रखो ऊपर.
ये हाथ में रखो, वो नीचे रख दो.
हाँ बस. और ये लेफ्ट पैर में कर दो. हाँ बस.
राइट में आ रहा है.
हाँ
लेफ्ट में चल.
ये पकड़. किडनी से हाथ में पकड़ बोला.
ये पार्ट फ्री रखना पकड़ने के लिए। हाँ
ट्रांसमिट हो रहा है? रिकॉर्डिंग कहाँ से होता है? कर दो, कर दो।
चालू से
चालू है? There is no landmark. Everything is inflamed.
एक्चुअली नहीं होता।
Hmm. Yeah. So,
वापस और स्पीड बोलो।
नहीं, वो मेरे प्रेशर पे है, डोंट वरी। Drumil?
Yeah.
Looking at that, I, how can you say it is acute, chronic, subacute? Go ahead. He had a fall in August or thereabouts, somewhere around that time.
Good morning. Am I audible? Hardik? Am I
Yes,
audible?
sir. Yes, sir.
Okay. So it's a case of a 60-year female has pain on her left shoulder since last 1 year, and pain was on and off earlier, and since last 6 months pain is there consistent. She had fall on her left shoulder in August, and pain is there since April. She
Right.
has past history of breast cancer and operated for
Interesting.
modified radical mastectomy on right side.
ते feel होत आहे मला.
And her examination finding forward flexion, passive range of motion. Forward flexion is around 100 degree. Abduction is around 80 degree. And internal and external rotation of around 20 degree. Supraspinatus power is 4/5 and infra is 2/5. Yes. Over to sir, and Drumil is here with me in OR. So he would be discussing many things.
Yeah, we are here in the auditorium. Few of friends have already joined here. Thank you so much.
Hi.
sir. Hello, sir.
I can see about 5 of you. Amazing. I'm impressed. You guys came before me. This is amazing. So this was an early start. So because it's an early start, I might look groggy. I have not been able to examine the patient because we had to start very early. But what I see from the history, And can the camera pan onto the MRI? There's extensive subacromial inflammation, and that's why we're just cleaning up stuff so that we can orient ourselves.
Yeah, MRIs are visible.
Can you see the MRI?
Yeah, it was there. Yeah, now it's again visible.
So just the two films are enough. There's no cuff tear. But if you look closely, there's a large lesion in the infraspinatus. So that's likely to be a lipoma. We don't have stir films, so I'm not able to tell you for sure. But if you had stir films, then you can distinguish a cyst from a lipoma. But by and large, it looks like an intramuscular lipoma. What has happened is it's a massive size, so it is taken up the entire volume of the infraspinatus. So what I was trying to tell my colleagues here was that it's probably dated and it is old. It is not 6 months old because Swagat clearly told me that her symptoms of pain were preceding that, and most of them were medial scapular pain, which is clearly a result of weak external rotators. And when the infraspinatus goes off, either because of a nerve, pump कम कर दो, ज़्यादा एकदम fire होने का चालू हो गया. Infraspinatus goes off, then there's scapular dyskinesia and classic pain there. So, निकाल देना. The entire infraspinatus is replaced by a lipoma. So this one, instead of being a neuropathy, is purely dictated because of the presence of the lipoma. So that infra is dysfunctional. How do I know it's chronic? Is if you look just below on the MRI, below the infraspinatus, there's a massive teres minor hypertrophy. And so the teres minor hypertrophy obviously is compensatory. So the teres minor has been compensating a weak infraspinatus, and it can compensate to some extent, but not completely. So the normal size of a teres minor will be half that of an infraspinatus. Usually here it is double the size, in spite of the fact that the infra is covered and hypertrophied because of the lipoma. So my now job is just going to be decompress the infraspinatus, find the lipoma, if possible, try and bring it out en masse. I've done this before for a teres minor, which was even more difficult. The biggest challenge here is if it was an extramuscular lipoma, it wouldn't have caused so much of grief, number one. Number two, an infraspinatus lipoma is going to be very challenging because it is much, much more lower down. And because it's intramuscular, I will not have access to find where it is exactly. So it's going to be a hit and miss to find out where it is. आता elbow extension में push back करतो तसं. Neutral, prone मध्ये येतो. So
Sir, whether it is compressing the nerve or not, how can we be sure clinically or?
So tough because the manifestation is going to be the same. The situation, location being so far lateral, it is unlikely that it is the nerve. You can't have lightning strike twice. The fatty infiltration would have told us whether it was a nerve. The other thing is the location being so far away. But clinically, if you had got an opportunity, the two tests for the nerves, there are three, but the two tests that I would rely on was the tenderness in the spinogluteal notch, number one, and the cross adduction eliciting pain away from the AC joint at the posterior spinogluteal notch. Those would be. There's a Lafosse test as well. In my hands, it's not a very good test, but Lafosse swears by that test, so it's a good test according to him. So if you can do it correctly, probably I'm not doing it correctly. But that test is also likely to be positive in there.
So here in this case, we had done EMG NCV as well, and that was showing that there is no
neuropathy.
No neuropathy.
So now we are actually, I'll try and orient. I'm in the subacromial joint, but we are trying to drop in as low down as possible posteriorly, not a usual thing on arthroscope. So we are pretty much extra articular and going down. So we usually tend not to go so far down, and that's why we're battling with the space between the infraspinatus and deltoid. ये ऐसे और पीछे ऐसा, करेक्ट? हाँ, ऐसा पकड़ के रखो. एक्सचेंज रॉड दे मतलब.
So the approach to the lipoma would be intra-articular only, or we will go extra-articular?
I'm hoping to do it subacromially, extra articularly. हो. यायचंय मला. I'm struggling to see the space there. Because she's also stiff, it's like a frozen shoulder. It makes this more challenging. Now I've got my Vissinger there. Give me a liberator. So we are right on the infraspinatus now. There's no joint space here, so that's why we are. कौन सा कहीं करते हैं?
पानी थोड़ा बड़ा पहले प्रेशर ना.
Flow is 2 liter per minute.
प्रेशर
2 लीटर बहुत ज्यादा हो गया.
Generally, what pressure and flow you keep for shoulder?
30 pressure, 40 flow. ऐसा और एक है क्या लिबरेटर?
सामने
ये पकड़ो हाथ से. ये देना मेरे को टिकाण. Together. It's creating space. This is the entire infraspinatus that you're looking at, okay?
Okay.
And then if you go below, you're going to start seeing the, beyond this raphe will be teres minor. This is not a high flow scope, I think. That's why we are struggling with the water. दोपहर का केस को उसको बोल के रखना. Upland, right? So, एक एलिस तैयार रखो. नहीं छूट जाओ दोपहर तक. स्वागत प्लाज्मा है.
Yes.
स्टरलाइजर.
Yes.
Yeah.
हमारा वाला स्कोप उधर बैग में है ना.
So having split the infra gently, there's actually no need to do a big split because there's a very thin apology of a membrane covering that fatty mass.
ये पकड़
Almost entire.
इधर push
इधर ऐसा करना है. Almost the entire length and breadth.
एवढा scope.
हो. So very delicately trying not to break the margins. And as long as you don't break any of the borders, so the tragedy is although arthroscopically you expose a tumor and decompress it, when it's time to excise it, you have to make a really big incision because, okay, just bear with me. I'm just going to,
Recording pause करो.
yeah, I'm just going to change the scope. Okay, एक हाथ इस पे रखो,
Brother,
gently. ऐसे ही पकड़ के रखो. Okay, just give me some time. Sure.
But watch लेके देखो focus. हाँ.
Okay. हाँ. In the 2 minutes that we were away, wash चालू है क्या? So we are in the game now. Back again. So the लाल है. पण मग बाहेर कापड घे.
याच्यावर रितेश
Sure.
white balance पण लागलं.
नाही. हम्म. कसं फुसफुस येत आहे. मध्येच येत आहे, मध्येच येत आहे. एक RF दे मला. ते हातात हातात आलं.
Brother, यहाँ तक. हाथ में रखो Ready.
Oh, correct.
So, sir, is there any particular landmark here?
There, unfortunately, there isn't. So my best landmark is Amit. थोड़ा इधर उधर टैल हो जाए, वो गाड़ी का लेन गार्ड सिस्टम में था ना. Unfortunately, there isn't any. They're all soft landmarks. You should know your anatomy. Correct, correct. And the directional fiber. So if you know Sugaya's paper, the infra actually goes posterior from lateral to medial and swings past the supraspinatus and inserts ahead of the supraspinatus. And the teres minor actually goes in a straight direction down at a lower facet, very lower facet. So when I did the teres minor case, we actually went down all the way, identified the triceps at the glenoid, and then came up. So our tumor is much more medial than lateral. Okay, tactile. Good idea. Let's see. इसको पकड़ के रखो ऐसे ही. I'm going to give me a minute. I'm going to try something here. ये ऐसा हाथ में पकड़ो. छोड़. ये नहीं जाना रे चलो.
Working with the content.
अड़क. Curved है ना ये. ये. हे दे. नहीं. हाँ हे जर हे गेलं ते नाही जात. हाँ. Okay. Okay, repositioning my retractors. It's difficult to orient you, but I will do that in a minute once I get a head around this. ये छोड़ दो. थोड़ा पानी सोडा नहीं नहीं उसको चेंज मत करो. चालू आहे पण मी येतच नाही रे
तो पूर्ण आतमध्ये गेला ना.
अरे गेला ना
नाही, नंतर ते लिबरेटर घालण्यावर मागायचं होतं.
ते पकड ब्लॉक कर दिया उसको
तिकडे जरी ठेवलं तरी होऊ शकतं. पकडत नाही.
नाही नाही तिथं जाणं नाही तिथपर्यंत पोचणार केलेलं लिबरेटर तसं फ्लो मध्ये येत नाही पाणी हम्म
पोझिशन चेंज करून बघू.
थोडी तर
एक मिनिट मेरे पास आप इधर आओ.
मागे मागे ये हाथ में पकड़ो आरिफ hopefully that's the sleeve of the infra and that should be the mass because there's only a thin sliver of the infra and that should be the entire mass of the fat laden. Luckily, we should be fairly away from the neurovascular bundle unless we go lower down. And then there's the risk of, so that whole thing should be the tumor. All I'm doing is just elevating the infra. Okay, take this there, and I'll take this again.
शेड डालने को बोलो नीचे.
Yeah, you proceed further.
जिसको मैं डिलीट के करते हैं.
Oh,
इंपोर्ट नहीं करता है.
tactile. But we need an instrumental portal to go medially. Scope has to look from massive, it's just unending. मला स्पायनोक्लिनॉइड आणि रोटेट इंटरवल दोन्ही आठवण कर. So all I'm doing is gently prodding without trying to break the margins. It's like a whole cave that is full of fat. The liberator is like my sixth finger. भाविन को भाविन. So the last one I did, I had a peduncle there, which I had to cut with a radio frequency. The peduncle is when that has the feeder vessel. You have to be very careful about that. This one looks much less organized. I don't see a pseudo capsule. There is, but it's not as rigid. Hele, Swagat. Opportunity. Like a whole cave full of fat. What I don't like is the lack of capsule. So if there was a capsule, then that makes the job very easy. Then it comes out en masse. Where here it's like a cavitation.
We'll remove as much as possible.
Yeah. Either thoda.
And how is the status of rotator cuff?
Thin,
Thinned out,
but intact.
intact.
See, there's a mass effect, right? Because of I think this is the lateralmost border. If Drumil agrees, then we will agree on this.
Looks good. I have to agree.
मैंने बंदूक पकड़ा है ध्रुमिल के सर पे.
But still, he will demand for more. Thoda और जाके.
थोड़ा और Yeah.
You just have to keep sculpting.
It is more like soft tissue endoscopy.
It is entirely soft tissue endoscopy. We are not in the joint. That's why initially you had a poor picture because we couldn't give you a field because there's no pressure maintained there. So joint में pressure fluid का maintain करना आसान है. The challenge is this medial most margin that's pretty far more medial than I'm comfortable.
Yeah.
Lateral was easy, so I just did the easy job first. दुर्मिल तो कॉन्फ्रेंस में जाता है तो फैकल्टी को टेंशन आता होगा ना? ऐसा सुना है मैंने कुछ रिकॉर्डिंग भी सुना है वहां.
He was Drumil was calling me earlier before 2 days कि
हाँ.
सर को थोड़ा बनाते हैं प्रेशर बनाते हैं ओटी में.
मुझे लगा है. अरे मेरे को क्या मेंटल कॉन्स्टिपेशन है कि
Now,
gently scooping out, just defining the borders. I have a limitation. My portal will not allow me to go too much more medially. I'll have to either make another new portal, but
Sir,
let's
Prathamesh
see.
here.
Hi Prathamesh.
Can we have an outside picture, sir?
आउटसाइड है पर वो सारा ध्रुमिल के फोटो निकाल रहा है कब से.
यहाँ से
कैमरा
लेना?
इधर आओ, मेरे पीछे से आ जाओ. For the landmarks you want, Prathamesh? If we have time and if some faculty doesn't appear, I will show you my teres minor case that was much more authentic and high definition. So we'll see how the flow goes through. थोड़ा पीछे से इधर ये मार्किंग दिखाओ इनको.
हाइट बढ़ाओ क्या हमारे हाइट.
The most important thing is what point do you attack the infraspinatus. So take your time, find out the infra, ensure that you are checking the correct muscle because it's very easy to get drift here and go wrong because there are no hard landmarks. My best landmarks are Amit and Drumil.
you punctured it, I think, or not?
I think so.
We have punctured.
I think so. See, there's no I expect a nice thick pseudo capsule. Lipoma doesn't have a true capsule.
Yes.
It's a pseudo capsule, and that depends on the duration of the tumor. If there's a nice pseudo capsule, then you can easily just caress it out, with grace. Just take it out. And I'm trying to do that. But because it's largely fat and lack of the capsule, it's not defined. So, but we are still sticking in the confines of that's your teres spiral. Can you see the angle of attack?
Yeah.
Is coming from inferior to superior lateral, whereas your infra is like this, which is purely medial lateral, and then it will swerve ahead of the supraspinatus laterally. And you want to make every effort to stay away from the tendon because the tendon may not heal. And the other split that we have done is definitely along the fibers of the infra, so that it's like the split that you make for your lethargic. So the healing is pristine, it doesn't contract, and there's no scar or adhesion after that. Oh, there's some more stuff here. Okay, now I'm going to try and change the strategy. I need a grabber.
Possibly small half-life. जो भी है करेक्ट करना.
Yeah. That's for biopsy, right? संभाल के रखना उसको.
Because she has already past history of
CA breast.
CA breast on opposite side.
Although it's the same alveolar tissue, doesn't look like the breast to me. will show you later what I've excised. Looks like pure gold. Proper fat tissue. I think that's the border now. Okay, a little. RF. Just clean up the field so that you will be able to see the lesion better. So I don't use the RF till I have my sample for my biopsy because you don't want the RF treated. This could be the pedicle because this is the vascular part of the tumor. Okay.
Remaining target is.
Oh. So that's the entire tumor cavity. If I go beyond this, it's going to bleed because you can see it's on the margin, and the margins of tumor are always vascular. And then that's the border because that's the muscle tissue starting here, this one, and that's the entire stuff.
Are there any medial landmarks for the dissection that we do?
So actually, if you see the edge of the glenoid, then you are gone too far medially, and then you end up, because there's a circumflex scapular vessel and arterial plexus there. And inferiorly, I told you we went for the teres minor here. The tumor was inside this. So it was enveloping the entire teres minor. So when I went below the teres minor, पाण्याचे. So Panika, when we went on the lower border of the teres minor, then we can go risk very close to the axonal nerve. But we actually saw the triceps on the inferior glenoid coming down vertically. So we knew that was the lowermost border. So, but here you don't need to do that. As such. So you'll hit the quadrangular space there with the long head, medial head, and teres minor. That's what we hit there. So as long as you keep away from that part, then you're safe. Okay. So now what I'm going to do, we are done with this, Nicoldo. I'm just going to go, have a look at the subacromial. I am obliged to do a rotator interval release because she's a little stiff. Liberator again. Yeah. Yes. You can't. Rahul? माझं रिस्ट्रिक्ट होते okay. So now ये निकाल सकते हैं. Very angry and red. Lot of fat here as well. काढून टाक नाही. ये हाथ में पकड़ो, ऐसा उल्टा पकड़ो. Bhavin, can you drop the BP down a little? This baby is pretty angry. Wait, yeah. You just find the guilty party, give it a little French kiss, and then you're on your way. So we are actually on the acromion, just to orient you. Lot of scar tissue here. So that's why just here. Yeah. Liberator now.
Liberator.
Yeah. So with the cyst must have created an muscle imbalance.
Yeah.
And that has led to the overactive internal rotators vis-a-vis the external rotator, and then that leads to a frozen shoulder. But this is pretty chronic. It's not something. Okay. So just showing you the spinoglenoid notch here. And it's like the bow of a ship. It's quite broad on the top. Again, because of the scar and the inflammation, it's difficult to find all the landmarks. We're just grateful that we can. And then very gently, again, very angry. One little push and then there's new bleeding starting there. So the job is just to reach the apex of that spinoglenoid notch. We're almost there, almost there, almost there. That white membrane, it's not a very impressive thick spinoglenoid ligament, but because she has predominant infraspinal weakness, just obligated to do this so that you have not left any stone unturned.
So you do this in almost all cases.
All my rotator cuff cases, or especially patients who have weak predominantly weak infraspinal, I can tell you stories about spinal cord. So that part's done. I'll just quickly go into a glenohumeral joint. So, Swagat, Brumil, I should have done the rotator interval release when I was in the glenohumeral joint, right?
Yes. Or we just open up the entire shoulder then. If you open up the rotator interval, it will just blow out.
Correct.
Fluid pressure.
So that fluid pressure would have blown out and then we would have struggled even more. Correct, correct. So that was the idea. There's always method in the madness. Sometimes. Okay. Right.
So you do that even for frozen shoulder capsular release. Last.
No, frozen shoulder is very predictable surgery. What you have given me, Swagat, today is very unpredictable. So for me, frozen shoulder is a 15-20 minute case. And so it's going to go straight away. So you just do 1, 2, 3, 4, make it less complicated. If you don't want to go in and out of the joint, you have to go subacromial, then come back again glenohumeral. But you agree with me, look at that. That entire rotator interval is so bloody angry that it will put Vladimir Putin to shame.
You do biceps synonomy for such a
All the time, because I don't get along with the biceps.
Yes.
So there's a little bit of French in me.
A little bit of white tissues only.
Yeah, some small semblance just to say that. And she has restricted external rotation. So we would have liked to have a good external rotation to be able to do that subacromial better. But there was that risk of blowing out. And with Durmil watching behind my back, Some of these LaForce actually, because you can find it very difficult to enter the joint because they are true stiff frozen shoulders, there's an extra articular release. And I would do that sometimes because here you cannot see the entire subscap. So I clearly know where my subscap is. I'm just handling my scar tissue only, purely. And the fact is that once I do this, I should actually effectively get a better external rotation. If I do all of this and then I don't get external rotation, then what is the inference, Brumil? In spite of doing a rotator interval release?
Subscap is scarred.
Not, yeah, it could be, but you would know that beforehand, right? This subscap looks really clean. That's your CA. We will protect that. What else could it be? In spite of my diligent release, if I still don't get an effective external rotation increase, it may not go full, but I expect it to go 70 or thereabouts. So I'm now extra articular. All this is scar tissue. No. This is this extra articular. You can see all that. That's a layer. I'm on top. My blunt end of the RF is facing the subscap. These are hard adhesions. So if you're looking at osteoarthritis, then this nothing will work. So whatever release you do is not going to. But if you're looking at an tumor, say fibromatosis of the anterior chest wall, or an extra articular lesion like a Pankos tumor, then all this is futile because nothing will work. Okay, so I'm just freeing up. Look at that scar tissue. That subscap is merged with the conjoint. All these hard adhesions. Forward flexion. Yes. And it's stuck to the glenoid as well. So in tough cases, I would actually put my scope anterolateral subacromial and then approach this area. Correct. Exactly.
It will see in the second surgery.
तो धमकी दे रहा है बता रहा है सबको adhesions between the glenoid and the subscap here. Be careful that the coracoid and the conjoint are on your left, looking down the corner. So we've achieved 95 degrees. Camera, can you see that? 95 degrees external rotation. Yeah? Yeah? Can you see that? Yeah? Height. So then that's enough. Forward flexion. I just need to do a. We can use the same thing. नहीं जरूरत नहीं. Okay, just need to do a bicep stenotomy. So blunt end is towards the cuff all the time. Just one small bit left. Oopsie. Yes. Chalo. Thank you. Just to show you the range of movement. So now she has a full range of movement. Even abduction, 90-degree ER is almost 140 degrees. And so also the, yeah, thank you.
It was not there even before lipoma.
Thank you guys. Thank you. I'll see you soon. Yeah. वो टिश्यू अलग से रखा है उसको भेज देना बाय
Good morning, everyone. So we will thanks first of all thanks a lot to Sir Babulkar sir for coming all the way and taking pain for such a bad live surgery cases, and for I was harassing him since last 2 to 3 weeks, sending 2 or 3 cases daily. Sir, ये चलेगा, ये चलेगा, ये चलेगा. So finally we came to 2 nice cases, and it was such a great demonstration for first live surgery. And now we'll quickly begin with our first session. Because of viral illness, 2 or 3 faculties are not able to come up, but we will try to run their lecture, and we will have more time from sir to have their case presentation. So first I would like to come up call Dr. Pratmesh Jain. Who doesn't know him in Ahmedabad? He is a celebrity surgeon of Ahmedabad.
So, welcome everybody, specifically Babhulkar sir, to be here between us and sharing his knowledge with us. So, we'll just be taking a very basic talk on decision making. So the diagnosis depends on patient symptoms, examination and imaging. There are 4 symptoms that we need to take care. First is the pain, second is weakness, third is instability, and fourth is stiffness. Pain can be because of cuff tears, impingement, AC joint problems, biceps or labral issues, or it can be a radiating from the neurological cause. Weakness can be because of cuff tear, tendinitis, or any neurological issues like brachial plexus injuries. Instability, we all know, and stiffness can be because of tendinitis, can be because of adhesive capsulitis. Now we'll focusing on the examination part. So examination, as we all know, is look, feel, and move. So the first thing is we should look the unexposed patient's shoulder from the front and back, and we should be very careful in examining the fossa, specifically the supraspinatus and infraspinatus fossa from the back, and the trapezius fold and the pectoral fold from the front. The central line back examination is an integral part of shoulder examination, and we should always examine the levels of the shoulder that we are seeing. So both the shoulders should be ideally at the same level. We should be ruling out any inclination of this shoulder, and we should always see the inferior margin of the scapula, so that should also be parallel to the upper margin. And in the front also it is the same. The bilateral nipples you need to see, and you need to see the clavicles, and both these should be symmetrical, so they should be not drooping. Now we can see that these kind of features where there can be scapular dyskinesia. So we always have to look from the patients from the back and look and see if there is any dysplasias. Here you can see there is a sulcus sign. So this is basically, I thank Rohan for these videos. So this is a basic examination. Central from the neck, we need to go back for the spine. Now we need to see the range of motion. The range of motion we need to see in active and passive thing. But this is very important because sometimes the patient will have a very good passive range of motion, but you don't have an active range of motion, and that is usually a sign of rotator cuff pathology. So you should ask the patient to move and see and note the range of motion, and then you should try to move it yourself. So you will assess the active and passive range of motions separately. So you need to see the range of motions separately. So you need to see the extension, forward flexion and external rotation, and external rotation in abduction, and then the internal rotation. And you can see the internal rotation in flexion. Now come to the special test. Special tests are defined for different pathologies, and we'll be coming one by one to them. So subacromial space, we all know, is the space between the acromion and the rotator cuff. And impingement is a phenomenon in which there is a acromial spur which pinches on the tendon beneath it, and thereby causing tendinitis. So the basic test for impingement is the Hawkins test, in which we do an impingement position. That is, we turn the patient's shoulder into internal rotation and flexion and 90 degrees, and then medially rotates, and then we'll just push at the anterior at the edge of the acromion, and then the pain comes up. So this is a positive Hawkins test. Needs test is important because needs test is basic test. It is basically the affected arm is passively and forcibly elevated with the scapular plane and medially rotated, and this is so the supraspinatus, infra, teres minor have a role in external rotation, and subscapularis has a role in internal rotation. So, and they are attached on the greater and lesser tuberosity as at well. So supraspinatus is basically the abductor, and it initiates the abduction. So any problems with the supraspinatus, the patient will have a weakness in abduction. The supraspinatus test is also called as an empty can test, in which we ask the patient to fold the thumb down and lift the shoulder up, thereby checking for the power of the abduction and horizontal flexion. So this is how we do it. And then you can just see the patient's movement, and if it is falling down, this is called as a drop arm test. Infraspinatus and teres minor are the main external rotators, like we saw in today's case. So these are basically the muscles which are responsible for the external rotation, and we have limited external rotators in the shoulder as compared to the internal rotators, which we have multiple internal rotators. As compared to that, the external rotators are infraspinatus and teres minor, and a weakness in or a deficiency in infraspinatus or teres minor will lead to weakness in the external rotation. So infraspinatus, we need to check the external rotation power, and these are usually you have to move them out, and if you have weakness in the external rotation, they are positive for. So this is how we check the external rotation of the patient, and this is usually the sign of a infraspinatus and teres minor. Now, hornblower sign is important because many times while taking the decision making, this is important. So the patient is either in sitting or standing, and the patient passively bring the shoulder to 90-degree abduction and laterally rotate, and ask the patient to hold this position. So if we do like this, and then if we ask the patient to hold, he will not be able to hold. So that is called as a hornblower sign, and that is usually a sign of a massive infraspinatus and teres minor pair. Subscapularis is an internal rotator of the shoulder, and it is one of the most neglected part of the rotator cuff spectrum. So always we need to check for subscapularis, and there are three specific tests which are defined. One is a lift off test. So the patient is we stand behind the patient and ask the patient to lift the arm beyond against our resistance. So if it is not possible, then the lift off test is negative. So you can do like this and ask the patient to pull the shoulder back, and if it is there, then if it is their weakness is there, then it is sign of subscap injury. Now the belly press sign, again it is a sign of it's a test for internal rotation. You ask the patient to press the belly. Now what happens if there is a subscap injury? The patient will flex the wrist and do the movement with the wrist. Whereas if there is a subscap injury, the patient will be, no subscap is intact, the patient will be able to do it with the shoulder power. So belly press or Napoleon signs are also specific signs for the injury of subscap. So if the patient is using the wrist to press the belly, then it is a sign of subscapularis injury. Now slap injury is basically defined by pain in the overhead activity, clicking, popping sensations. And we'll see two tests, O'Brien's test. This is O'Brien's test. This is the and you feel with the Speed's and Yergerson's test are basically two tests which are done for the biceps pathology. So we'll feel in the biceps tendon, and then we'll either do a flexion and we'll do a forceful supination, and if it is painful, it is usually a sign of biceps pathology or biceps tendinitis. A AC joint is usually an adduction test which is positive, a 90-degree adduction if it is painful, and the patient will have pain in right over the AC joint, and cross body adduction will be painful. Now, in massive cuff tear, which is basically the crux of today's discussion, there is an important role of examination. So, subscapularis always you need to examine in all cases of rotator cuff pathologies, because if the subscapularis sign are positive, you should be prepared intra-op to repair for the subscap also. And we need to see during the examination that which muscles are weak. And if there is and we also need to see that pain is the primary sign or weakness is the primary sign. If pain is the primary complaint, we also need to see for the biceps sign. Now, if the weak external rotation is the main complaint, we can do surgeries like tendon transfers. But and also we can if pain and dysfunction are the important function, and the patient has good internal rotation, then superior capsular reconstruction can be performed. So, if there is a posterior superior tear, predominantly you can consider of lower trapezius tendon transfer, and if there is a supraspinatus massive tear, you can consider with the superior capsular reconstruction. If the patient has pain, weakness, and crepitus also, so this can be a sign of a rotator cuff arthropathy, and then reverse shoulder in those circumstances may be required. Thank you.
We are often faced with sudden put the scope in and there's a massive tear. Tell the audience what are the pointers on clinical exams where you can probably predict or anticipate.
So, usually, history-wise, the patient will have a long-standing history. The patient will have weakness, which is much more as compared to pain, and usually these patients may have a strong drop-arm sign, or as if there is a massive cuff tears can be either a anterior superior pattern or a posterior superior pattern. The anterior superior massive tears will be a subscap along with anterior part of the supra, and then you will have weakness in internal rotation and abduction signs. And if you have a posterior superior tears, then you will have basically weakness, specifically in external rotation. The patient will have a strong weakness in the external rotation. And if weakness is the primary symptoms, usually the massive cuff can be predicted. And also you need to correlate with the radiological and clinical findings. That was.
In addition, I would add, apart from massive ACL, lag signs.
Lag signs.
If you get a lag sign, then let's see this.
What would be the inference for subscapularis power?
So if the subscap power is reduced, then you should have a high suspicion of subscap tears, and we need to relate it with the imaging findings and in the arthroscopic examination. So never leave subscap as such. So subscap is basically a strong anterior fold. So as there is a couple concept, so even if you are able to reconstruct or repair the anterior and posterior cables, then even if you are doing a partial repair, it is fine. So anterior cable restoration and the subscap restoration is, I think, a must for a stable shoulder as such.
One more question for Rajmesh and Ashish sir both. There is a concept of true pseudoparalysis and false pseudoparalysis. So most of the patients with a chronic cuff tear or chronic weakness, they have pseudoparalysis, which is loss of forward flexion or less than 90 degrees of forward flexion. So how do you define a true pseudoparalysis? Most of these, they have good passive rotation. So do you have anything that is going to give you a judgment?
So
This is
one
going to
thing-
do good after surgery, true pseudoparalysis and false pseudoparalysis?
Ashish sir.
I'll cover that a little bit in my talk. But you must understand there's a lot of controversy between pseudoparesis, true, false, pseudoparalysis versus pseudoparesis. But what Prathamesh and you are alluding here is chronic pseudoparalysis. So which is the true pseudoparalysis related to a massive cuff tear. So we should restrict our description to that so that then we don't confuse the term.
Thank you.
Good morning, everyone. So, in our general busy practice of high volume OPD, sometimes we ourselves neglect the patients to order certain investigations, and just patient with shoulder pain, particularly those who are elderly patients, they go home with analgesics only. So I will talk regarding the cuff pathologies. I will not talk regarding the instability because this will take longer. So these are the list of common investigations. We will see how and when we should order this. So X-ray is the first and primary investigations in shoulder cases. Sometimes elderly patients come to our OPD with shoulder pain, with trivial trauma, and then they go home with analgesics and assurance. So if we took primary X-ray, sometimes we do not miss the cases like this, the tuberosity, avulsion which is displaced, and then the patient when comes in the next OPD, say after 1 month or so, and you will see the quite detected tuberosity with rounded appearance. So this will create a mishap. So X-rays can be evaluated in terms of calcification that can be seen clearly on X-rays. Certain spurs and hooked acromion are better appreciated on X-rays rather than MRI. Sometimes patients are having mixed picture of shoulder pain and radiculopathy and vague symptoms, so you are not sure whether this is due to rotator cuff pathology or shoulder pathologies, and sometimes you may be able to detect cervical rib on even X-ray of shoulder along with the cervical spine. So that cervical rib will not be detected on the shoulder MRI which we ordered for the shoulder pathologies. Sometimes you may see the os acromial and other findings. The arthritis is something that you can see better on X-rays initially. So it can be primary glenohumeral arthritis, or it can be secondary cuff tear arthropathy or AC joint arthritis. So X-ray, simple AP X-ray is a good diagnostic tool for initial assessment. I have seen many patients that come to our OPD without X-ray and with MRI only. So sometimes you may miss something on MRI also, and that can be easily picked up on X-rays. USG is an effective tool. I think USG will be detailed, explained in detail by Dr. Bhavin Jumkhawala, but it is widely available, easily available in the peripheries also. It gives us a dynamic evaluation, almost accurate like MRI, but it is still observers or radiologists dependent. It has certain therapeutic interventions like injections, blocks, and barbotage for calcific tendinitis. It is clearly indicated in patients who are having MRI incompatible implants or metal anchors around the shoulder in post-op cases particularly, or patients are having claustrophobia and patients with cardiac pacemakers. And it is relatively cheap. Now MRI. So MRI is the most common and gold standard investigation for cuff tear pathologies. It gives us the detailed study of soft tissues. Although interpretation varies, you will find a variety of interpretation in MRI reporting: partial, complete, incomplete, partial, complete, incomplete, full thickness, remnant, so many variations in center to center. So one must learn to read MRI while doing shoulder cases. So these are the common images. I will not go into detail. Now the partial tears, this is the most controversial diagnosis in shoulder pathologies. So you need to decide whether you want to conserve these partial tears or you need to operate this. And how you are going to operate, you're going to put anchors transtendinous in case of articular-sided avulsions, or you are going to make it complete tear and repair it, or you need only a bursal tear repairs. So how MRI helps? If the partial tears are really very small, say less than 50% of footprint involvement, initially you can conserve the patients. If they are very large, more than 50%, and it is not responding to conservative treatment, you need to operate in those cases. Particularly like in this case, you have to decide beforehand whether you want to do a tendon articular kind of repair, because in those cases it is preferable to use small anchors at different sites rather than using a single large 5.5 anchors and over constraining the tendon. Then that leads to more pain in post-operative phase even. This is another case of partial tears which is not clearly visible, but you can see the thinned out tendon which suggests the chronicity of tears. The intratendinous tears again are controversial diagnosis. The diagnosis is thing, but the treatment is again controversial, whether you want to repair this or you will wait and watch. I think the Dr. Ashish sir will throw more lights on this, because I have repaired in some cases the trans tendon sutures and tied it, and sometimes I have conserved, but the results varies in patient to patients. This is the bursal size of tears. So the most important thing in massive cuff tear, we need to evaluate the retraction, the fatty atrophy and fatty infiltration along with the chronicity of tears. See the retraction and the massive cuff involvement is not the single tool to label it irreparable. Sometimes even with the large massive tears which are nearly acute or recent in elderly patient can be repaired very well, and then that gives satisfactory and good results. So this kind of tears with retraction almost up to the glenoid margin with fatty infiltration as well as significant reduction in the volume of muscle, that is fatty atrophy, they are clearly not repairable, and one should think about the other options, like if the patient is young, one can plan superior capsule reconstruction, or if it is involving the infra, and we can plan the trapezius transfer or something like that. If in elderly, say more than 65 years of age group, one should think about the reverse shoulder. Sometimes you may find the tuberosity having cyst on MRI, and then one should plan the site of putting anchors, because this will not allow to have proper hold of anchor, so one can plan double row repair in those cases. Now CT scan in cuff tear is something, it is very valuable tool in planning the reverse shoulder cases. One can plan, one need to see the glenoid wear pattern, whether it is type B2 or C type of glenoid. If required, one can plan graft in glenoid, or there are specific software available with the different companies where you can have patient specific implants and augmented glenoid base plates. Humeral head fracture CT scan is useful in 4-part comminuted fractures in elderly patients, where we can plan primary reverse shoulders, say in 70 plus cases, because in those cases the tuberosity union will be questionable and osteosynthesis is not possible. CT scan is particularly useful in avulsion cases where you will see a lot of bone edema on MRI, and you need to check what amount of displacement is there, whether this patient needs operative intervention or conservative is okay in minimally on undisplaced cases. For fatty infiltration, I think the MRI is the tool that is being used nowadays. So CT can be used and these investigations will make the proper pre-op planning in cases of difficult and wear out glenoid cases. Now, EMG NCV, I have seen many patients, at least 3 to 4 patients, those who are operated for rotator cuff tear, small tears, and they are not recovering, and on examination those patients are having neurological cases like brachial plexus injuries. So this will create a big problem, so patients will have a big dissatisfaction. So EMG NCV is useful in cases of suspicious brachial plexus injury in patients who are having significant weakness in relatively very small size tears, so one should suspect some other cause of weakness. The Parsonage-Turner syndrome or a brachial plexus neuritis, even cervical spine and spinal cord diseases should be ruled out before operating upon those kind of cases. Thank you.
What's the controversy with partial cuff tears? In my practice, there is no controversy. I don't operate.
Okay.
I don't operate small tears as well.
So
if
for
a-
how long you will wait for patients to resolve the symptoms? In conservative treatment,
Oh, I have great patience, and my threshold to operating, the patient has to hold a gun to my head to ask me to operate a partial cuff tear. It's true, because what Chirag has gone through, I have gone through this. Initially, we used to be enthused about, I'm talking of an era when we were 2002, we were dealing with 0.5, 1 Tesla MRIs. The radiologist was recklessly reporting partial cuff tears. Surgeon has this blindsided vision because we are taught to look at things homogeneously, that everything is black and white. Either tear hai, nahi to nahi hai. So we operate. So oftentimes we went in, put the scope, we didn't see the tear. It was the MRI representing a high signal which the radiologist would interpret as a tear. Burnt my hands. You learned very quickly. And fortunately I'm blessed with a rehab team that is very likely to convert them into a pain-free status. So it takes time. You have to lose a lot of hair. Wisdom dawns on you. You will go through that cycle of life. And now my conserved proximal humerus fractures, my conserved partial cuff tears do far better. And their results are far superior to my fixations. Seriously, because what nature cures, we take the credit for that. Repairing partial cuff tears is playing with fire.
correct. I agree.
And even beyond that, let me take this argument to a further extent. I have no hesitation saying that 5 and 7 and 8 tears, I don't operate them. I have almost 4 or 5 fellows here, and true to myself, cross my heart, I don't. So extremely painful near full thickness tear. If that happens in an athlete who's due for a competitive end and he's a national athlete, that is an exception because nothing is 100% in life. But the thumb rule in my practice is that partial cuff tears, you give them rehab, you give them painkillers, you give them steroids, it's okay, not a problem. The steroids, again, we use them as a Bofors gun to solve the problem. It doesn't solve the problem. The steroids in my hands is a means to allow them to comply for the exercise. So if they take a steroid and then they go for rehab, that improves their compliance for rehab, and then the credit is to the rehab. If they don't do the rehab, the steroid is just going to wear off within 3 to 4 weeks, 6 weeks max.
So are there any incidences of after steroid-induced full thickness tears?
100%. So my threshold for giving steroid injections is that high. Very rare. Again, you have to push. I don't like giving steroid injections. I think probably maybe my ego, but it tells me that I have failed to rehabilitate the patient in the natural way that it is.
And is there any role of PRP injections in partial tears?
In my practice, I am the chairman of Society Against PRP.
Okay, that's good. So because lot of pain physicians are using PRP quite a lot.
The day
nowadays.
somebody, anybody proves to me in a type 1 trial, and I have at least
6 studies with me in double-blind randomized trial that PRP works. It's all bullshit. 100% bullshit. I have absolutely no conviction that PRP can work in any which way. And I would love to have a game changer in my hand कि gene therapy दिया है, stem cell किया है और PRP किया जादू हुआ है. There is no magic there. The PRP works brilliantly for the company that sells it.
Good.
You do a rotator cuff repair and you take out your scope and within 2 minutes put your scope in there. There's tons of PRP.
Yeah. Correct.
So you tell me you concentrate that PRP and you're delivering 100% more than that is required, but the body is throwing that PRP for every day for the next 6 weeks till that damn thing heals anyway. Okay. Now, you use a different PRP. He uses a different PRP. They use a different PRP. Which one works? There are at least 6 different models of PRP, and trust me, I have studied a lot of those. I will share with you one report by Patrick Dennard, I think, who was the designer surgeon of the PRP of one particular company, and he's shown that leukocyte-rich PRP may actually aggravate damage in tissues, whereas one company is promoting leukocyte-rich कि हमारे PRP में leukocyte है ना?
Interesting. Yeah.
तो तेरी कमीज मेरे से सफेद कैसे? फिर निरमा वाले ही जाने.
Yeah. It's all marketing.
But show me the science. I'm happy to use it. I have been a skeptic all my life, so I was against reverse shoulders. I was against arthrolatry. I switched. I'm open. I'm not. I don't subscribe to any ism. But till date, all these days, and I get fair amount of PRP failed patients who come in, and so उसको 20,000 का इंजेक्शन बोलता है patient. He doesn't call it PRP. उसको मालूम नहीं है क्या है PRP. बोलता है वो 20,000 वाला इंजेक्शन लिया था.
Right.
Another thing is to avoid multiple cortisone injections.
Yeah.
Yeah, that is true. That's the single if you want to try, the single injection is enough. If it works, then it's okay. Don't try to use multiple injection. That is right.
Okay, let me put you on the spot there.
Yeah.
So you are advocating one injection,
Yeah.
and
Complete.
Kalpesh is saying don't give multiple injections. But say Chirag is the patient, and Chirag has tender Achilles tendinosis,
Okay.
and it's not resolving. Would you take a steroid injection?
No.
So why this dichotomy that tendo Achilles में Chirag नहीं लेगा, लेकिन shoulder में लेगा?
See, tendo Achilles, I don't know the exact pathogenesis, but tendo Achilles is a very strong muscle. It has a very eccentric loading, and steroid
It's
will
the same tendon.
steroid will weaken, and there are high chances of rupture.
High chance of rupture in how many days?
I don't know.
I know patients who've ruptured the tendo Achilles on the 4th day of the steroid injection. So you should read Nicola Maffuli's work. A lot of our understanding of tendon comes from that.
Okay.
And it's no different. Both the similarity between the rotator cuff and the tendo Achilles is they are avascular tendons. And that's why they have a very poor healing capacity, but they are very strong tendons. So it's not that I don't give any steroid injections, but what all little injections that are given in my practice are given ultrasound guided by the radiologist, so that they are sure that it's gone. Don't tell me that I'm 100% sure my needle has not gone into the tendon. If it goes in tendon, then is the end game. It takes a few months, years, and then they come back. And as Kalpesh said, those patients who take 3-4 will come back and tell 3-4 injection लिया अभी बढ़ गया.
Right. Yes.
All the partial tests on one side, but grade 3 partial tests, we see them, they are quite painful and they don't respond to conservative line of test. All other partial tests usually respond, but grade 3 partial tests, they always have empty can also positive and they are very painful, not responding to the medicines or physical.
That is what I asked, sir. How long will you wait?
Keep grade 3 on the side.
Yeah, grade
What
3 is
about near full thickness or full thickness tears, which are 6 mm? 7 mm.
So I don't have threshold to wait for more than 3 months.
No, I
So
don't think it's 3 months.
Full
Anybody who has-
thickness,
yeah.
I always repair.
So I don't,
But-
because what happens is we must understand that. Have you heard of the quadriga effect?
No.
Anybody here? Quadriga effect?
Yes, somebody, yeah, yeah. Go on.
It's like the rath that the one string pulls the other. In hand tendons, the effect is described. I have read
FDP,
it.
right? So you have a
Yes.
scar on a single FDP strand, the rest of the fingers will not function because that is the balance. The partial cuff repair is like that. That's a Cortija effect. Because if you scar one area, because it is impossible to do a tensionless repair of a small cuff tear. Of a small cuff tear, forget partial cuff tear. And so you are ending up bunching it and doing some form of purse string, and that becomes more painful. So you will realize, I've been there and I know this. So those patients are more painful post-op. They take longer. They present like frozen shoulder. So the attitude that the tear is there, so it is inclined for repair. It is not a surgical case. My hands, yes. So having said that, I will end up repairing 1 or 2 or maybe 3 full thickness tears which are 5 to 10 mm. But I make a very concerted effort to push that partial cuff tear patient. When they fail physio, failure of physio in my practice is not an indication for surgery. That patient, the paradox in partial versus full thickness tear is partial cuff tears are more painful, more stiff, more frozen than full thickness. जब वो पूरा हो जाता है, his pain actually goes away, his weakness comes in, and pain goes away, and that's when he goes off for you. So I prevail on him. I said, we'll use any means to reduce your pain, whether it's steroid or whether it's PRP in your hands or whether it's ice packs and cryotherapy, but getting them rehabilitated. I have a series, we are trying to work out now, a series of at least 30, 40 patients that I can remember, and I'm sure that number is double, who are full thickness tears, who are 20, 30 mm, 40 mm, refuse surgery for whichever reason, domestic reasons, cannot do, parents not there, I am alone. And I give that example that you cannot say that every full thickness cuff tear patient needs surgery. I used to be on the philosophy when I was younger, less mature, that every tear will be repaired. But there were several patients who refused and went off. Some of them are friends, some of them are relatives, some of them are known to me. And I gather they are doing well. They have adapted. They cannot do gym, bench press. Some of them are doing bench press. I'm warning them that they will decompensate faster. I said, don't get operated, but don't do bench press. But they are wild. I know my very sister's-in-law side, she's 76 years old, she's alone, children in USA, and husband was invalid. She said, Ashish, you have to understand me. I have full faith in you. I cannot undergo surgery. My husband will heal Alzheimer's and blah, blah. He later passed off, but by the time he passed away, she had rehabilitated herself. Daily swimming. She did her own therapy. I have videos of her full function, even today's days. It's about 10, 11 years since then. She's now almost 79 years old. She's okay. She says, when I swim, I get a little sore, but she has full function. She drives. She's independent, single lady. So when you go back and find out, we are obviated to this. So I go and ask them, what's happening? What are your limitations? Let me understand. So it's the same thing that happens with ACLs also. So long back, Shelbourne wrote a paper and he said 1/3 ACLs don't need surgery, 1/3 need to adapt their lifestyle. The 1/3 who don't need surgery can do sports without ACL, 1/3 need to adapt their life and they'll still do well, and 1/3 genuinely need. So that is the difference between proprioceptive artists and proprioceptive idiots. You understand? So those who can balance the proprioception, get their muscles to compensate without decompensating, will do well. Will do well. So there is no absolute that every cuff tear requires surgery, and you learn this the hard way when you have the practice as extensive mind and you really delve and find out. So partial cuff tears, I burn my hands with them, and I'm very reluctant. And they do exceedingly well. You have just have patience, enough time, and they do well, then that is fine. But if they don't do well, trust me, they don't do well, because I get patients who are so stiff post-op, operated outside, and they come to you. Now I can't do anything because I cannot rehabilitate them. Because every time you do, there's so much pain from that. I cannot create the retear to release that purse string kind of thing.
So it takes time. That's right. But yes. I used to. I stopped. Yes, the frugal needle. Yes, I devised that. It was sexy. It made a nice title, but haven't done it in the last 8-10 years. But when I haven't stopped, let's change the narrative a little. That I am dealing with an athlete who has a slap tear, and he's unable to throw, and because it's a chronic slap tear, they develop a partial cuff tear. So I will go in to repair that slap, and then I will do the frugal needle to repair. Yes, sir. So the articular surface tear, I'll do that. For a bursal surface tear, I will just complete the tear.
Okay, thank you.
No, 1 minute.
Okay, yeah, sure.
You made a very important statement which I love because that goes down my philosophy, that many patients nowadays come with MRIs and that has become the trend, and it just disturbs me so much that I am talking to my fellows ad nauseum that please do an X-ray. That is the basic before doing any exotic investigation. That holds true for knee also, that holds for shoulder also. I tell them, you never do a 2D echo or a stress test without doing an ECG. So I want you to impress on this audience, and I love that first slide of yours, that what are the conditions where an X-ray will give you more information than an MRI. And like you, we have seen so many conditions that they've been going from MRI to MRI and not finding, and we just had to do an X-ray and we found out.
So as I mentioned, for shoulder pathologies, like initially the many MRI radiologists have missed that calcification things that is betterly picked up on X-ray. The acromion morphology and spurs may be not very well seen on MR. It is better evaluated on X-ray, particularly outlet view on this side. Sometimes the cervical rib, which may be mimicking the shoulder pathologies, which is not evaluated on MR of shoulder, which can be seen on X-ray.
Early glenoid wear, osteophytes,
arthritis and osteophytes
will miss out on the MRI. It will never picture, especially the low quality MRIs that you see on that. But apart from this, I have had patients of cancer who had osteosarcoma, MRI done of the shoulder. This is osteosarcoma of the scapula, presenting as a frozen shoulder, and going on and on and on. And then finally, this is a 17-year-old guy, and treated as a frozen shoulder, MRI is normal, and osteosarcoma. He survived for 6 years. He was every year on the anniversary used to come and say thank you very much. So I was the one who picked it, then went to Tata, got treated. Same thing with osteosarcoma upper tibia also, treated as knee pathology. Another fascinating example, I got a reference from a spine surgeon for a lady who had a fall from a scooter and sent to me with an MRI. MRI report was absolutely exotic. It's fascinating. I have the printed report and took a photograph of it. That she has a partial cuff tear, she has a slap tear, she has a rotator cuff tear, and she has adhesive capsulitis. Sent for surgery. And this baby was like this, and she was she was miserable. It was like 3 weeks, 4 weeks from a fall. She says, I'm sleepless and I cannot even lift my arm. So as a practice, if my fellows screen the patients first and then I get to see them. I never get to see the first patient myself. So if a fellow sees the MRI first and then the patient, then he gets wrapped. And nowadays we financially fine them $1,000. So it's the hospital is okay. Hospital gets their money because that's drawn from their salary. But it's very important because there's this urge to pehle diagnosis dekh le fir, then that blinds your mind, and your mind just goes in that one direction. So I examined her as per my, and she was just so painful, and she was so painful that she wouldn't. It's like rock solid. It's not frozen shoulder. Frozen shoulder, you have some movement, poor rotation. You can do supra infra. You couldn't do anything on her. And I said, "Where's your X-ray?" And there was no X-ray. And she was just so tender, and she had tears in her eyes. "La pehle jao X-ray karke aao." You won't believe it. And this is no exaggeration, 100%. She had a proximal humerus fracture.
And this spine surgeon, leading spine surgeon, didn't bother to do an X-ray because front shoulder टाइम किधर है किसको एग्जामिन में करने में, और MRI तो सब मर्ज की दवा है, उसमें तो सब निकलता है. So this was ridiculous. He was sent for surgery, and we did operate her for a proximal humerus fracture, but the MRI, that is the, and so things can go gross, and we are lucky, we are in a country which is litigation free. Abroad, this would have been a mess. It would have been a career finishing trial. Seriously. Thanks, Chirag.
Yeah,
That was useful.
Thank you.
Sanjay bhai could not come due to viral fever. We can start with Kalpesh bhai. साहब नो आएगी lecture present.
My topic is whether the re-tear should be treated by revision cuff repair or by doing reverse shoulder replacement, or one should give conservative trial. The goal of the rotator cuff surgery is tendon to bone healing, and as we all know, it's a real issue. Tendon to bone healing is a real issue. Now, if you go to the basics, the tendon insert into the humeral head by a specialized fibrocartilaginous tissue called anthesis, and it is made up of 4 continuous zones from tendon to fibrocartilage to mineralized fibrocartilage and ultimately bone. But when we repair the tendon, the insertions they heal histologically by mechanical, biomechanical and histological inferior tissue rather than the anthesis. And actually it heals with the disorganized interposed zone of the fibrovascular scar tissue. So what we call healing is also a problem. After we repair, do they heal or not? Isolated, what does the literature say? Isolated supraspinatus tear, it healed by rate of 80% at the 2-year follow-up. When the larger tears are there, 2 or 3 tendon tear, the healing rate reduces drastically. And older female, especially older than 65 years, have been found to be the higher re-tear rates. Now, what are the cause of the rotator cuff repair? One should go in the detail why this cuff repair has failed. According to my understanding, there are technical reasons, biological reasons, anatomical and mechanical. We are thankful to the recent understanding of the biomechanics of the rotator cuff and improvement in the implants and suture materials. The technical reasons are becoming less and less obvious. What is biological failure? When healing potential of the host environment is compromised. If you consider the single most factor for non-healing is old age. Advanced age has a reduce effect on the healing of the rotator cuff. When the patient is smoker, hypovascularity is the issue. Multiple cortisone injections, what we discussed, can adversely affect the healing. So whenever you are planning, please avoid cortisone injections. Diabetes, again, diabetic patients have a poor healing potentials. Poor tendon quality and bone quality. When the tendon quality, the tendon thickness is reduced, the tendon soft tissue is the issue, or when the bone mineral density, osteoporosis is there, it reduces the pull-out strength of the anchor and healing is compromised. And again, fatty infiltration of the muscles, gauterier grade 3 or 4 and above can has an adverse effect. So these are all the patient-related biological factors which can hamper the healing. Anatomical failure, failure to recreate the normal insertional footprint. We have understood that this supraspinatus has a very small, around 8 to 10 millimeter insertion area just posterior to the bicipital groove, and the rest of the footprint is occupied by the infraspinatus. And one must recognize the tear pattern. That is the most important thing to repair the tendon anatomically, whether it is a L-shaped tear or a reverse L-shaped tear, or whether it is a large crescent or a small crescent. But one must recognize the tear pattern to repair it adequately. Again, when the repair that do not restore the normal resting tension is the day 1 failure. Okay, so these are the anatomical causes. And in double row repair, when we repair single row or double row has an upper edge in this context, that the double row repair consistently restore a larger footprint area, so it has a good healing potential. Regarding the mechanical failure, when failure occurs when the repair constructs are not strong enough to overcome the normal forces on the cuff tendon during the healing phase. Suppose there is a large tear of 3 centimeter and only repair with this single anchor, it's a day 1 failure, right? So mechanical failure is a surgeon related mainly, and important thing is a rehab. Now classically rotator cuff repair has a very slow rehab advisable, and one must observe or supervise rehab is the key. When the repair is very fast or accelerated rehab program may cause a mechanical failure in after rotator cuff repair. So the literature has shown that all the re-tears occur in the first 3 months mainly. So first 3 months are the very crucial. Don't start strengthening program before 3 months of the rotator cuff repair. This is a good paper from the Journal of Shoulder and Elbow Surgery from November 21, and these are the risk factors, whether it is a patient related or not patient related. But as I have discussed, age, BMI, obese patients, they need more force to elevate the arm, transmit more forces, diabetes, lower education level. Patients should have adequate IQ to understand your procedure and rehab. Regarding the fatty infiltration, the infraspinatus and subscap fatty infiltration has a more value as a predictive value of the re-tear rather than the supraspinatus fatty infiltration. Duration of the symptom. Patient has a long duration of the symptoms, more wasting, poor quality of the tissue, and more chances of re-tear. Osteoporosis again is a big factor. Regarding the anatomical factor, larger tears have a more tendency to re-tear. More retraction will have a more tendency to re-tear. And these are the two, again, this is the importance of X-ray. Acromiohumeral distance and the critical shoulder angle. When the acromiohumeral distance is less than 5 millimeter, it's a indication that patient will have a re-tear high, and larger critical shoulder angle will also have an adverse effect. In this paper, they have described that operative duration is directly related to the re-tear rate, and biceps procedure is done, again it's a indication. So these are all the factors we should consider before the index surgery to give a prognosis whether this patient have a good healing potential or not. This is our own patient, male 58 years, traumatic injury, and if you see, patient has a supraspinatus almost complete full thickness tear, and it was treated by inverted mattress sutures using the fiber wires and lateral row anchors. In 6 months time,
Sorry. The video is not on. In 6 months' time, patient has a persistent pain, restricted range of motion, and whatever may be the reason, but we got the MRI scan, it was showing the re-tear of the tendon. So again, we went back. This is the revision repair. Look at the tissue. The footprint preparation is done. Healing response is initiated and the anchor was placed. And bite was taken from the normal, relatively normal cuff tissue. And this is a lasso loop type of stitch taken to improve the contact area and give good footprint compression. And double row cuff repair was performed. This is the lateral row anchor. Patient was relatively young, so we could achieve a good repair, and healing went uneventful. So, regarding the yes. So regarding the re-tear management, you have to look for the symptoms. What is the symptom of the patient after the re-tear? Many patients we see, the patients are not very symptomatic or not bothering them much. So don't treat the MRI, treat the symptoms first of all. Whether the pain or weakness, this is the indication of intervention. And always go in the detail what has caused the failure, whether it is the patient-related factor like age, large tear, fatty infiltration, diabetes, or not patient-related. When we have a patient-related factor which is bothered, then again revision fixation is not a good idea. You have to go for either a reverse shoulder replacement or some conservative treatment. And if the tear is because of the not a patient-related factor, because of the surgical technique related faults or a post-op rehab protocol, here you can give chance by revision rotator cuff repair. So I think this is the conclusion of my talk and open for discussion.
Sir, is there any role of double row reversing any factors? If such factors are there, then we should keep in mind that double row repair should be done. Patient-related factors are present, or
Rather than double row or single row, it should be a anatomical tension-free repair. Many times we see that there is a tendon loss, right? When we put the scope in the subacromial space, you find that there is some tendon attached to the insertion site. So in such case, when there is a tendon loss, if you want to do a double row and you want to put the tendon to a lateral edge of the footprint area, you are over tensioning the repair. It's not a good idea. In that case, I think single row repair is a good choice. So rather than going into debate of the single row, double row, it should be anatomical repair, number one, after the recognition of the tear pattern, and it should be a tension-free repair. When there is a note, in large tears, what we have observed that double row repair can restore the footprint better. It can give good compression over the footprint. So theoretically, there is a good chance for the healing rather than the single row. So again, it's just like a fracture fixation, sir. when you do a fracture fixation, you aim for the reduction first of all. So first and foremost thing is the recognition of the tear pattern. You looking from the lateral portal, you manipulate your tear just to give a proper anatomical reduction. So that is the key. And as I told you that means whenever you repair in a tension, these patients have a lot of pain post-operatively and there are very high chance of re-tear also.
Hints regarding placement of the lateral anchor.
Lateral?
I use the knotless lateral row suture anchors. Any hint or any suggestions on that? I think that causes a lot in my patients. It causes a lot of tension.
So
It's hard for me to determine the exact.
So in initial implants, when there was a instrument which was giving tension in lateral row anchor, it was the issue. But nowadays, when we give a tension by hand, pulling the threads by hand, I think it's not a big issue, sir. Initially, it was a mechanical tensioner sort of device by the first lateral row anchors from, I think, from Mytech or with a wheel on that. It was giving lot of tension during repair. But now all the lateral row anchors, you pull the threads just by hand. So there is no question of over tensioning while putting lateral row, sir.
When to suspect re-tear in post-operative?
So
When to investigate the patient?
yeah. So if during rehab, the pain is the most common thing. When the patient have persistent pain, especially night pain, and which is not bothering, again you have to suspect two things: infection, number one, and second thing is a re-tear. So in first 3 to 4 months, if the pain is persistent, then you should suspect. And if patient is not progressing to a proper rehab, that is also an indication. Ashish, what is
Actually, it could be anything. And so oftentimes, if you look at results between failed cuff repair and those who have healed cuff repairs, they are both happy. Their post-op ASCS scores are much better than their pre-op ones. So they can present to you with neck pain because they're using too much of trapezius loading. And the reflex action is just keep doing cervical spine MRIs and traction and such stuff. Whereas we fail to realize that he has not picked up. Lack of strength to me is a sure sign of, because even if a cuff repair fails, they may still have full movement. They may still have pain mitigation, but they cannot have strength ever. And that relies entirely on your diagnostic skills. So let me relate to you. I'm battling with a surgeon, 58, crazy gym guy. Crazy gym guy means he has 20-inch biceps. He's a bachelor. All his Facebook friends are young females. He has no worries in life. And he pushes 120 kg easily on the bench and shoulder, and he's targeting 200 kg. And a year back, he noticed he had pain, had taken a steroid injection, 2016 by the way, and then 2018 in the opposite shoulder, and that shoulder gave. He developed a tear, he couldn't do his gym, and if he can't do his gym, then he goes crazy. So his surgeon went ahead and did a cuff repair, double row cuff repair. He told him that, 58-year guy, he told the young guy, I don't have faith in physios, I'm going to do my own thing. Surgeon also relented, gave him some photographs, ye kar le photo dekh ke physio kiya to fir that's disruption of the highest order. He tells this to me, he said, I am a XYZ, I am like that. I lifted 100 kg weights on my 9th week, and 10th or 11th week I was lifting 115 kg weights, proud about it. And then it tore, it would, because physiologically it can't load
and then it tore, and then he didn't tear just like that. He went to Dehradun for some function and then came back and realized he was struggling with putting the bag on the top, and then came back home, and the week following Dehradun he developed pseudo paralysis, just dropped. Repeat MRI. The first tear was 14 mm, repeat MRI, second tear within 4 months of surgery was 20 mm now. Realized, truth dawned upon him, became sane, got his re-revised, again the same surgeon did a arthroscopic double row cuff repair. This time he said, I will follow the gospel word, I would do everything. Went to a physiotherapist who was another orthopedic surgeon's wife, followed her to the T for 4 months. But his concept of follow everything was that he did not do physio of his left shoulder. I mean, he did not do gym on his left shoulder. He kept it in a sling and did all the gym with the right shoulder, along with the leg work and blah blah and everything with usual Facebook photos, videos, all those self-aggrandization stuff. And then his physiotherapist pushed him, coaxed him, MRI करो ना, देखते ना क्या हुआ है. So November, 4 months after his re-revision, he just casually went in and चलो देखते क्या हुआ है. And there's a re-tear on the left side, which is now 22.5 mm, 27 mm. समझ गए? And he still hasn't got it.
Many patients are asymptomatic also. Means
He was asymptomatic, he was happy. And he was begging them to start surgery. I have followed, I've been a good boy 4 months. I don't have pain, I have full movement. And he said, I just started doing 8 kgs of dumbbells, biceps and triceps. Not yet started any advanced stuff. And he sat down. I saw him 2 days back for the first time. He actually has weakness on both his infra. He has O'Brien positive on the opposite right as well. He's taken steroid on both sides. And we have not realized that his right is unaddressed. So when he is effectively doing a bench, he is actually loading the left more than the right, or vice versa. Create problems. So unless we restore the force couples, and so the patient is desperate to get rid of pain. The physiotherapist attitude is to restore the function in the sense of movement, because that is reflecting her job कि मेरा पेशेंट इधर भेजा और तुमने अभी इधर तक नहीं किया. My inclination is to restore the strength. I care a damn about what's happening to the movement and the pain. If the strength is restored, you have restored biomechanics. Otherwise, you've done nothing to that patient. And if the strength is not restored, then that is a re-tear. That is very important.
Another thing what we have observed in rehab, that when patients are little stiff, they are more happy rather than the full range. You suspect re-tear. If they are gaining full range in a very early phase, it's a possibility of re-tear. That's what I have observed.
So you are blessed with patients. My patients are very demanding. And my worst problem is they sit outside and they exchange notes. So I, just last Friday, there were 2 patients. One we had discussed in the Delhi case scenario, some of whom you were there. Both were revision cuff repairs. And 6 months they were from Surat, and we were calling them कि अरे क्या हुआ है, कैसा हुआ है, कुछ हुआ है, हाँ आने का है. And the local surgeons who were looking after them said कुछ नहीं, मस्त है, बाबुलकर ने क्या मस्त हो गया. And I'm like, अरे टेंशन है, ये revision cuff repair है. Both landed up on the same day, and then they were operated by the same surgeon. I realized that later. So when the second one came in, I said क्या है, इतना महीने से बुला रहा हूँ और दोनों एक दिन में ही आ जाते हैं. अरे वो भी ऐसी चैलेंजिंग थी, वो आप भी बाहर बैठ मिल लिए सर, बात हो गई, हमारा दोनों का सर्जन एक ही है. सो दे एक्सचेंज नोट्स. सो द फिजियोथेरेपी में जो पेशेंट है ना 10-12, अपने को मालूम नहीं है, बट तेरा कौन सा ऑपरेशन हुआ है, तेरा कितना दिन हो गया, सब दे आर असेसिंग एवरीथिंग. सो व्हेन वन ऑफ देम गोज अप देयर, द फर्स्ट थिंग दे विल कम एंड टेल यू इज कि उसका तो 3 महीने पहले हुआ, उसका कि जल्दी कैसे हो गया, ऐसा है. सो आई नो वन सर्जन who calls all his operative patients on one day and all his non-operative patients on the other day. Seriously, not exaggerating. ये concept मेरे को strike भी नहीं हुआ था, but it's very valid. I think youngsters should do that.
Sir, I also want to throw some light on Sanjay Dwivedi sir could not come, but the topic was very interesting. Post-operative cuff is intact, but clinically patient is not progressing. And now what to do? So if re-tear is not there, cough is intact, but patient is not progressing.
Send him to a very good physiotherapist or send him to a very senior accomplished surgeon. We face these patients. I don't think I have an answer for you at all, because I'll tell you, instability is reasonably easy to handle. Frozen shoulder nowadays in my hands is much easier to handle. But cough has its own mind. You do the same surgery for the same number of patients and all rotator cuff repairs. Each one will behave differently. There are so many factors that we don't understand. And we are delving into that. We understand. Now, Kalpesh put up so many list of factors there for re-tear. What are the risks? There was a time when I started practice, there were articles in JCS that obese patients with BMI more than 30 have a high re-tear. I actually refused a few patients. And now, obesity is not a factor. It's not a factor.
Second or third patient is obese.
Yeah, totally. You can't just send them back.
Yeah,
So we've done obese patients, crazy, but they've done well. Smoking was a big thing. There is no evidence that smoking patients will have a worse outcome than non-smokers. Absolutely not. I still read the Riot Act and tell the smoker patient that for the 6-8 weeks, don't smoke. But that is usually because the wife comes to me, Sahab, inka smoking band karao. So I'm pleasing her rather than science. There is no science in what I tell them. I know it's not going to make a damn difference. They will still do well. I have inveterate smokers who have come and got their cough repair done. And the other thing is, I'm very fascinated by when you put up that slide about cuff healing and the fibrocartilage and the mineralized cartilage and all that work from Nicola Maffuli and Lisa Gallett's. They have amazing work. Lisa Gallett's paper about early rehab and late rehab. So some people call it aggressive rehab. It's a stupid word. I don't like. You could call it accelerated rehab. There's no aggression in rehab. It's early or late. And I have been a disciple of early rehab right from day one. Very early. So all my patients start early. I don't like the sling. My patients don't wear the sling. Sling is my biggest enemy. 6 weeks our band starts, strengthening starts. So doesn't mean that when you start strengthening at 3 months and I start 6 weeks that we are right or wrong. These are different philosophies. There are different paths. You can go to Delhi via Rajasthan. You can go via Kota. You can go via Bhopal. Doesn't matter. He's going to reach there. But where does my logic, science of starting early rehab come from? We must understand the nature of tendon healing and ligament healing as well. Both are viscoelastic structures. If I take you deep down into biomechanics, strengthening or healing will happen along the lines of stress. And we fail to learn from history. If Nirbhay remembers, the first ACLs that were done back in 80s and 90s, they used to put a cast. And it was miserable. And that recovery used to be a prolonged, tedious 8-9 months. It's horrible. But that was, you tell me, you show me one surgeon from 90 who would start early mobilization. He had the fear of God in him. अरे इसको मूवमेंट नहीं करने का, गारंटीड वेस्टिंग.
अभी भी है ना, एसीएल इंजरी का वो ब्रेस दे देंगे, पैर मत हिलाना 1.5 महीना. अरे भाई एसीएल इंजरी हुआ है, उसको रिहैब तो करो. क्वाड्रिसेप्स का क्या, ब्रेस हिलाने का नहीं 1.5 महीना.
स्टार्ट सेकंड डे.
Yeah, and patient comes with an ACL tear, not operated, but with stiff knee, wasted quadriceps. We have to give him 1 month to rehabilitate and then operate. Even today.
So we fail. Ankle injuries.
Same.
You put them in a cast. Who puts them in a cast? It changed everything. You look at the standard pro forma for the last 15-20 years. I have not put a cast for ankle injury.
Same here. No
you
cast.
Put them on an ankle immobilizer. Encourage movement because that ligament will strengthen along the lines of stress if you avoid bad movements.
But that's how the concept of strapping with compression bandage has come. You do that, you are giving a stabilization force and you are allowing them to walk.
Because the pain inhibits the muscle.
Yeah.
You do a TKR and you put the patient bedded and the wasting is rapid within weeks.
Absolutely. You start walking.
Just quadriceps setting start kiya to wasting prevent hota hai. So this is my contention that we ask them to start early. All the papers that are written about this failure of cuff tear, early mobilization, threat, they were written up in the 80s and 90s. The kind of quality, the type of surgery, the implant, the suture material, pathetic. I have done cuff repairs with Ethebond. And when we put in 4 rankers,
दो एंकर तो वैसे ही टूट जाते हैं, एथिबॉन्ड वहीं टूट जाता था. The kind of sutures now, even the scissors cannot cut those sutures. So we have changed our technique. We are improved our implants. Then we must flow by that. अभी ACL को कोई immobilize नहीं करता because क्या rigid repair है. You start walking, mobilizing, everything is fine. So that is, we have to move with time and have the gumption. So my sling is a deterrent. I tell them that at home and office, no sling. I'm not exaggerating. Second day post-op, not exaggerating. There are 4 or 5 fellows here. They will all confirm it. If they tell me I'm lying, then I leave this hall ASAP. I tell them to wear the sling moment they are in the public domain, because we are in a country which has zero emotive this thing. We have our emotional quotient is so pathetic that somebody will come and bump into them. Our roads and things are crazy. So no driving. But at home and in office, they can live without the sling 100%. I allow them to start drinking a cup of tea, using a mobile, read a newspaper from day 2. Some will do it on day 5, some will do it on day 6. We start our table washes from day 1 post-op, So some of them can go up to here. I'm still okay with that. No exaggeration. And the biggest indicator, red flag, is the body. If they are doing something wrong, it will pain. So I said, respect your pain. And every week, if it exceeds, then go. I want them to go slow. I don't like a patient who's recovering too fast. You know, the guy who's driving his car at 3 weeks and doing the, see, you did my operation, I did well. I don't like that. I'm not claiming fast recovery. I don't like the patient who's too slow, because then it's pain, inhibiting, and that cuff is not healing well.
One last question on this, if it is okay,
Sir.
Any change in the use of suture anchors with regard to osteoporosis on faculty or senior people?
With the current technology, I don't see a problem. I have operated a fair number of 80 to 87-year-old patients. We might switch to a 6.5 anchor in those. And very rarely we've done a transosseous equivalent without anchors for some patients. I have given up metal. I think the metal is a problem, because in the glenohumeral joint instability, never ever use metal. Zero advantage. And our peak anchors are almost same price, so there's no price advantage. It creates problems. I have had to do reverse shoulder replacements for Bankart patients. No, the cuff also. I don't see any need for metal anchors at all. You should be out.
Newer anchors, they are 2 millimeters in diameter by drilling, and they are all suture anchors.
Ah.
Some 5.5 millimeter ball inside. Is there any added advantage?
I know the added advantage is if they come in for surgery, revision surgery, amazing advantage with anchors inside. Now this surgeon that I'm talking about has 4 and 4, 8 anchors from 2 surgeries. That real estate is gone. Where am I going to put my next level of anchors? It's a challenge. It's a big challenge. So from that point of view, yes, there's a huge plus in using all sutures. I don't have the testosterone to use them for the rotator cuff yet, but I have started using them. I have used the the striker all suture anchors, quite good for younger patients who have a good bone quality. I know that going to do well, and it makes sense, because if they go and have a problem, the 70-year-old is less likely to come in for a revision repair. So there is no advantage using the all suture anchors there. Yes, sir.
Sir, your take on hypothyroid females and rotator cuff?
Dangerous. My
Nowadays
amongst
we see so many hypothyroid females having cuff.
I have a very small retear rate, and we evaluate them, but amongst my retears, almost 60% will be hypothyroid patients, and the disastrous retears are all hypothyroid patients. 15 years back, we used to see hypothyroid females. We are seeing 6:4 ratio of male and females now. Male never had hypothyroid. Hypothyroid was predominantly a feminine disease. There are too many male hypothyroid patients. Too many. It's changing. So it's not nice. So it's not the hypothyroidism that affects it, but hypothyroidism directly relates to the calcium metabolism, which is a big player in tendon, bone, ligament, and of course cardiac. So there are cardiac risks as well. Because the cardiac muscle cannot perform with calcium, and calcium metabolism will count for a toss. So to be very careful about them.
So what is the investigation of choice if we are suspecting a re-tear? Is it a dynamic USG or an MRI or both?
It's a very, very good pertinent question. So that depends on the timeline. So I know at least 3 VIPs who fell in the bathroom 3rd week post-op, 4th week post-op, complete drop arm. One of them was bilateral repair, fell on one side and came back. I was like, oh, this is torn completely. Got an MRI said the house was on fire, everything is torn, re-tear, big report. Clinically his cuff was good. I said, we'll sit on this and check, and clinically it was strong. I mean, it was grade 4. You can't have grade 4 with a re-tear. And then we did ultrasound and everything was okay. So if you're doing early post-op, then you should do ultrasounds, 100% for revision cuff repairs. If you're 1 year down the line and you want to see them, then you do MRI. But if your MRI is showing a 50 mm tear, then it cannot be a false positive. You know, it's those borderline 10, 15 mm, the signal interpretation is a problem.
So regarding Swaga's question, on MR or ultrasonography, the repair is intact, but patient is still symptomatic or pain. I think infection is not uncommon, means we should always suspect and investigate thoroughly to rule out the infection. And second, I want to ask one question that what is the indication of suprascapular nerve decompression in while repairing the large massive cuff tears? So, again, pertaining to this issue.
So, okay, we'll start differently. I know that there are many seniors who don't believe that the suprascapular nerve is a problem and they don't treat
Come here.
Right. It's rude to turn your back to them. No, I think I'll stand. It's much better. Before I answer Kalpesh's question, let's imagine a scenario, and correct me if I'm wrong, that there is somebody who has a suprascapular neuropathy which is coexistent right now, no other issues. And we must first accept the fact and register to the fact that there is a condition called a suprascapular neuropathy because it's a very short nerve. Every nerve has compliance. And it's very clear that 20% of nerve stretch can be tolerated. Beyond that, neuropathy occurs. We're not talking about neurotmesis, we are talking about progressive compression neuropathy. The two shortest nerves in the shoulder are the axillary and the suprascapular. Suprascapular more so, where it has a zigzag course. So it goes laterally, posteriorly through the transverse notch, then goes posteriorly again, and then winds around the spinoglyph notch, and then proceeds to supply the infra and the supra. Which means that the effective distance has been reduced. It has 2 points of tether, one at the transverse notch and one at the spine. So its functional length is not. So one little stretch, go off. There's a nice JP Warner paper that massive cuff tears, because there's a massive retraction of 40-50 mm, the nerve alters its course and is tethered at the transverse notch. So a lot of the European and JP Warner and myself will compulsively, obligatory do a transverse notch release and then proceed to a massive cuff repair. Is very important. So that way you are obviating that. Now coming to my case scenario, that somebody has a suprascapular neuropathy, maybe 50 years old. There is progressive wasting of the infraspinatus, leads to weakening of the infra, loading of the supra, and then there's a trivial fall. So that fall on a wasted muscle will create the tear. Once the tear happens, your signs for suprascapular neuropathy clinically are very poor anyway. You're not going to detect them. In the presence of a muscle tear, all the attention will go to the muscle. We are very good at diagnosing full thickness cuff tears. The MRI will reiterate that. Reflexly, you'll go in, do a cuff repair, and that won't work because there is pre-existing neuropathy which has not been detected. And those are a chance of failure. Now, doesn't mean that all the cuff failures are because of that, doesn't mean that all the cuff tears are because of that. But if there is, then that is a major problem, that is an unhappy patient. We have many, all of us, I'm sure, have many unhappy rotator cuff repair patients, not unhappy instability patients. And that's one of the key issues. So, I'll tell you 2 examples. One is a radiologist, husband wife, and the husband did the radio sonography and said partial cuff tear, and then I said no, we do an MRI because clinically this looks much more than what it is, and she had a full thickness tear. It was about 20 tear. I said this requires surgery. They came in for surgery. Now she's a colleague and female, and then you don't strip them in your clinic. So we went in theatre. This gentleman, her husband, was in theatre before me. I went in and she was about to be painted, and I saw gross atrophy of the suprainfra. She had a 3-month history. So you can't have a wasting in 3 months, but in a neuropathy, within 6 weeks you'll see wasting. So I immediately told the husband, boss, this is probably a pre-existing neuropathy which has gone into cuff tear. I'm going to do a nerve decompression. Mentally we were not planned, it was not an agenda. I said, we just go ahead and do that. He said, whatever you say, I'm okay with that. He's in theatre. So we went first, went to the transverse notch. The artery was below the ligament. It had an aneurysm on it, and the nerve and the artery were tight, and the artery was pressing against the tight transverse ligament. The moment I cut, and I have a brilliant video of that, moment I cut that transverse ligament, the artery started pumping, big time. Suddenly it was just free of pressure. And because there's an aneurysm, it means that it was under pressure for a long time. The scary thing is, if she was draped and I had not seen the wasting, I would have missed that and she would have been a miserable result. Not only that, she did an MRI after say 6 months, the whole wasting had reversed completely. Guttler from 3 became 0. That's a fascinating stuff. So it might be 1 in 20 patients is my guess based on my practice. It could be 1 in 50. But when it is there, it's a disaster. I have another fellow, severe shoulder pain, came to me twice. He came to me first for a 2-week observership. At that time he said, sir, I've seen your patients and I see I have a lot of shoulder pain. And it's been there for 10 years. So I said, go checked him, blah, blah, no injury. And that time he was just like, it's been there, I'm not happy. And so I said, go do the rehab. 2 weeks he did rehab. While he was there, he did better, he was good. I said, please continue. And he said, I'm feeling fine. Then later he had similar aggravation again elsewhere, and he had another surgery. And then he came back as a 3-month fellow. Sharp pain, he couldn't assist me. And he used to give up on holding the hand, and he used to avoid coming for bankart, which required a lot of traction. And he had tears in his eyes, and there were painful days when he should switch off, and he'd come back again. And he said, see, sir, I didn't want to tell you, but I had surgery and it didn't work and some decompression, but I have tremendous pain now. And I examined him thoroughly. There's nothing. He has had 5 MRIs in last 10, 15 years. Cervical spine, shoulder, CT, everything normal, bang normal. I told him that you did rehab, you did well. So why did you stop rehab? He said, it's not that. When I do rehab, I'm okay. The moment I stop rehab, I got pain and they're episodic. I said, then I did the test. I looked at him much more thoroughly and I said, this is probably suprascapular neuropathy. So I said, EMG is normal. Some vague changes, delayed sensory, this thing on infraspinatus. So I said, okay, must be right. So how do I decide whether to offer him surgery or not? Because there's nothing convincing on this. So what we do is for our non-tear patient, we take them for ultrasound and we inject the suprascapular notch with 2 cc of lignocaine, no steroid. 2 cc. You'll not believe it. I should have taken a video. I was there and the needle was there. And when the first drop went in, he shouted, sir, pain is gone. He just shouted. He was so relieved. So we gave him the full 2 cc. Make the move around. The result has to be within a minute. You can't have an injection today and recovery tomorrow. He says, yes, sir, this is fine. I'm feeling good. Came back the next day. Sir, first time I slept well. Is gone, 0. Second night, bang, pain is bang again. Back again. So that is how is the best diagnostic test. If it remains pain-free, then it was a minor inflammation. If it comes, relief is after next day, then it is not true neuropathy. So we convinced him, then he was not ready because alone and family and mother was away. And took him a good 6 to 8 years, he kept having pain.
and we did his surgery. Because of the delay, we did a pec minor release with the transverse scapula. It was a very tight notch. And within the month, 60% of his pain had gone. He was so grateful. So these are occult cases. And if you ask me, there is no one test. The EMG is not going to be positive and will not do. And in the presence of a cuff tear, your EMG is not valid. The tests are not valid. So just go ahead and do it. Now comes the question, should we treat all our patients with that? Impractical. So young patients, rapid onset wasting, somebody who has a positive cross abduction, and most importantly on the MRI. A lot of MRIs don't have T1 Sages. So touch wood, not a single patient will I operate without a T1 Sag film for one of these reasons. Your sense of repairability, your sense of so if you have Goutelier 2, 3 isolated in infraspinatus, that's your suprascapular neuropathy. You can't have Goutelier 3 in supra and none in infra. That cannot be, because the distal muscle has to be affected first and most. So if you have infraspinatus with Goutelier 2 or 3 and wasting of sweat, and you must distinguish infiltration from atrophy. So if you have loss of muscle mass and the rest of the fossa full of fat is not neuropathy, that is disuse wasting. But if you have fat within the muscle, it's a distinct sign. You'll pick that up earlier on ultrasound. Before we have picked up patients on early neuropathy, MRI normal, but the sonography told us that the muscle is atrophic, it is not recruiting, and there's fatty infiltration. So those are the ones you want to really address. Thank you. Right, big one. I told you that I started as a skeptic of SCR, very inspired by Teru Mihata. I actually took my time off, went into his OR, spent time with him, understood the nuances. I've seen him operate, amazing. He does it in 45 minutes flat, very disciplined, very systematic. And I've seen his patients in OPD as well. Having said that, why I'm nonplussed is that those same results haven't been replicated by other centers. So it's like Sujaka's osteotomy, that in Sujaka's hands the results are top class and nobody can replicate them. There is a sentiment here that you need to be warned, this is not the answer to global warming. And so every year I post almost 15 to 18 patients for repair SOS SCR. I end up repairing almost all of them. I do end up doing 2 or 3 SCRs in a year. So if they're repairable, I am of the philosophy that we must repair them. Nothing beats anatomical repair as such. So lot of options, because lot of options means that it is like hallux valgus surgery, that we don't know the true solution. If there was one good surgery, then it would have overtaken everybody straight away as well. So coming to Drumil's question about pseudo-paralysis, there's a nice paper by John Tokish. Please go through that, extensively debated. They did a consensus study, Delphi consensus. They couldn't find a consensus amongst surgeons on what is true pseudo-paralysis, but they came up with this collective definition that number one, it has to be chronic. Because you can have acute pseudoparalysis from calcific tendinopathy. You have pain, you have trauma, you have GT contusion, is going to be acute. So number one, it has to be chronic, it has to be irreversible. So basically, when we talk about pseudoparalysis, then we are talking about anterior superior escape. The inability to actively lift the arm above 90, but passively be able to do this. So frozen shoulder, you will still be able to do only this much, but passively also it will be the same. So you need to distinguish that. And in the absence of neuropathy. So you can have neuropathy, you can have brachial plexus, you can have C-spine, and then not being able to do that is not pseudoparalysis. So that is the collective definition. So that's why this has been explained long back from Burks and Tashian also, that it has to be chronic, less than 90, full passive range of movement,
And then we need to distinguish pseudoparesis, pseudoparalysis. Pseudoparesis is large cuff tear but able to go beyond and then recoverable, or rehab, calcific tendinopathy and all those things. So basically, when we know that you could have an associated struck shine also, and when pseudoparalysis is associated with the ERLS lag, just drops back, then that's absolutely true pseudoparalysis, no doubt about that. The drop arm and the Hornblower's test are also other collateral signs of a pseudoparalysis. Nobody knows why SCR works. It's just conjecture that it is connecting the two vertical pillars, the anterior and the posterior, and stabilizing them. Or perhaps it is reducing the proximal migration, allowing the force couples to take over and behave as the true abductors. Which means also that if I reinterpret this, that you have to have a subscap intact. You have to have a teres minor intact, if not an infra. If an infra and subscap both are intact, then that's cherry on the cake for you. So it probably just facilitates the force couple. It's probably the same thing that the balloon is doing, the same thing that the partial cuff repair is doing at the same time. So obviously, if you want young patients, we have subscap intact and teres minor intact, no OA, and a much younger population as such. Now, if you have what more than indications, we should know what are the contraindications. Irreparable subscap is a contraindication. If you have a reparable subscap, then you repair the subscap and then do your SCR, which is a little tedious. Steep proximal migration, contraindication, but Mihata does it. Pseudoparalysis, contraindication, Mihata does it. OA changes, we will share some reports. He's done it for a type 3 Hamada also. But those are probably exceptions around the rule, and in your and my hands, we don't want to do these kind of patients, and certainly not in a weak deltoid patient, because that will drive it. Yeah. Now, America got fascinated. They always come in late. They started doing SCRs, and they just could not replicate the same results as Mihata. Because America has a thing, it is a litigation-friendly society, so they are reluctant to take autographs. So even if you see for latages, they are very reluctant to do arthrolatages, and what all they do, they will usually use allograft tibia and iliacus from another patient rather than use the patient. Same thing with ACLs also. So that's a mindset, which means that we are not talking of SCRs. When I speak about SCR, we are talking about IT band, doubled, Teru-Mihata SCR, whereas the Americans will use synthetic grafts. So may not be the same. They're probably talking chalk and cheese on this. So the synthetic SCR is less than 4 mm. Mihata's doubled IT band is almost 8 mm thick, between 6 to 8 mm thick as such. The graft tear rates are always going to be higher with the synthetic grafts. Look at the publications from USA. Tokish started with a 2 mm arthoflex. Then Peter Millett went on to the 3 mm arthoflex, and then Hirahara came up with a 3.5. So the industry is trying to build up the graphs, thinking that the only reason an industry will change their graph is because the earlier ones are not working. That's very important for us to understand. So these are much thinner ones. They cannot work dynamically. The infection rates and the failure rates with a synthetic graft are much higher than the IT band grafts as such. So this was Mihata's first 2013 paper. Now look at this study. Although he had 24 shoulders, 20 of them were available for study. 11 of them, almost 40% of them, were large tears, which you and me would actually go and repair, which I'm sure is the right thing to do. So Mihata's threshold for doing SCRs are reasonably tear. So even a 35 mm tear, you would do it. But he has the results, that's for sure. So that's important. But you have to go back and understand why Mihata did an SCR in the first place. Japan received the FDA approval for a reverse shoulder last amongst all the countries. Even India achieved an reverse shoulder in 2010. Japan got there in 2012 or 2013. So these were patients who were begging for relief, and they were massive tears, and you couldn't do a reverse shoulder for them. So he devised a strategy, improvised on it. Initial ones were IT bands, then he did well, didn't do well, and realized they were all 3 mm, 4 mm. Then he started doubling them. and then refine the technique. And so the current technique is a doubled IT band. He's achieved an active elation from 84 to 148, ER from 26 to 40, ASC scores predominantly from 23.5 to 92.9, and also the acromial human resistance from 4.6 to 8.7. So that's a big plus. And honestly, I don't know of a reverse shoulder study that can restore ASCS scores to 93 consistently across the board. So I think that's been a game changer from Mihata's side. All of them IT band. There's a technique that is described, and now he's doing them through mini invasive technique. So it's nice to sell a mini invasive without a big incision, but I'm not there yet because our numbers are not that high. We're doing like 3 and 2 SCRs a year. So once the numbers go up, then we'll start doing that. The other thing we have to understand is there's a big challenge on here. Mihata uses a 10 mm cannula there. I don't like to use a cannula, so I just use this finger technique. So that what you're doing here simultaneously is, watch this again. So my assistant on the left is actually pulling on the glenoid sutures and I'm pushing. So there's a combined push and pull technique to get the graft delivered inside the shoulder joint. So that works best in my hand. So that way I don't have a cannula, I am not damaging the skin. This is the pre-op video and this is the post-op video. It's amazing. You can see a complete restoration of the roof, almost like the rotator cuff is there. Although it's not dynamic, it is pretty much static. But for a young patient, look at here, you can see the entire acromion on the left side from the glenohumeral scopy. It's all gone down to the glenoid level. So it has definitely the potential. So whatever I've done and seen is very impressive. But I'm still very guarded on doing SCRs because you're burning all the bridges here. So this is one of the patients who has a re-tear arthroscopic cuff repair done in Rajasthan. He's the head of a hospital, and what is impressive is this is day 1 X-ray. The entire proximal migration has been corrected. When I see that on day 1, that means that SCR has worked. That means the sandwich graph is there. It is doing its job. If the SCR is showing proximal migration even on second day or the 1 week, it's not going to improve, and that is very clearly mentioned in John Tokish's paper that his results are good, the ACS scores have improved, but they have not been able to correct proximal migration with the same consistency as Mihata, which means that they are not doing an SCR, in short. Because unless the proximal migration is corrected, then the force couple cannot perform as such. I have stretched this big time and I have actually taken a big bite, more than what I can chew, in this patient who's 37 years old, and the surgeon went and did an arthroscopic GT fixation on that. It's a challenging surgery because if you look at the initial post-op X-rays, those screws look brilliant, but all of them were AP X-rays. Nobody bothered doing lateral X-ray. You can see there are screws here and the GT is here. So the screws were never in the GT because you fail to look at the humerus as a sphere. And so what you see when you're putting your screws on an AP C-arm is actually the screw is going in its own place, the graft is the fracture somewhere else. So very clearly you can see that it's failed day 1. And this is a young 37-year-old guy. He's a mechanic. And he comes to me almost a year later, and what do you do for him? There's nothing. It's gone. So that is a challenge. So I'd rather that youngsters do an open GT fixation because you can see the GT for yourself, you can fix it there, and at the most you will have a frozen shoulder, but you won't have this situation. And the ideal treatment for him is a reverse shoulder, but you can't. At 37, even the wildest person cannot. So what we've done is the metal screws here. This is an SCR, and whatever real estate we had here, we've put in 4 anchors for the SCR, and we've left the GT where it was. Just shaved off the bit to ensure that. So we've got a decent acromihumeral distance, and this is the post-op sonography that you had 2 months to see that your graft is still intact, and you can see it's a very nice thick graft there, is still intact, working well. And this is his pre-op, and this is just 7 weeks. He's about 8-9 weeks now, but I think if this works, this is a blessing to him. Even if it works for 8-10 years, we've pulled him up, and then we can eventually consider doing a reverse, and especially for a mechanic. So I think for 7 weeks, this much progress is reasonably okay. He's completely pain-free. The movement, strengthening and all takes a long time. So I tell them 6 months as such, but it could be 5 months, it could be 8 months as such. But what is important is ranges are restored, his pain is gone. Massive tear here. And so these are my portals for my SCR, and I would use this Nevisor portal for my anchor insertion. I've modified the technique a little. I hopefully will be able to show you today, and so I won't discuss the technique right now. But this is the post-op where you can see that everything, the graft there, it's intact, and arthroscopically when you go back in, you will see that that's a graft. It doesn't have the quality as the tendon, but you can see it's completely anatomically closed the roof, and it's right there at the anatomical junction. You can't see the greater tuberosity. It's moving isometrically, and we've got a double row. So it's absolutely mandatory to do a double row with 2 anchors medially, 2 anchors laterally, because you want the widest area of contact in these patients as such. If you can restore their proximal migration on day 1, day 2, it's fine. So post-op protocol is pretty similar like a cuff. There's no change at all, but I tell them that you might take about 6 to 8 weeks to repair. There are some other articles published of using the semi-T as a cable graft crisscross along there to achieve the same function of preventing proximal migration. But I don't think the nature of the IT band is that it is a nice thick sandwich doubled. I don't think the semi-T can replicate that as such. Word of caution about the synthetic grafts, they are not the same, they are different. I don't have any experience on using the synthetic grafts. Some of my colleagues in South Korea are using patch augmentation, not SCR, patch augmentation for large cuff tears to reinforce, and they're scaffolds and they're human dermal scaffolds. We don't have a single human dermal graft at yet. All of our grafts are porcine, and with a vegetarian Hindu Muslim population, they're not going to be very happy using porcine grafts. So be sure that you have explained to your patients what you're doing on them. The only human dermal grafts that are available are from Wright and Graft Jacket from Wright Medical and Allopatch. Retail rates with the synthetic grafts are much higher. Mihata series about 11%, which is reasonable, but it is there. And before I close up, all of you must go and read this Alex Leatherman article, very recently published in Arthroscopy as a letter. It talks about the S-shaped curve, and all these lower, middle and upper curve means that there are maturation points of understanding the procedure. This is where inflection point, surgeon comes with a disrupting surgery, throws it at you, everybody is fascinated, and there's a technological challenge of effectively doing this, and we were very anxious about doing, thought difficult, and so then here you get the technological breakthrough, everybody gets the devices, everybody starts doing that, and so there's a plateau and everything is acceptable. And then here there's maturation of the whole cycle, and then what happens is innovation becomes incremental, and here then they start understanding as the failures are coming in, there's a limitation of technology of solving problems, unindicated things are doing there, you're laterally using too many different conditions for the same, and then finally it plateaus completely because the 10-year results come through, and then it starts failing, and then the interest goes down. And that happens with lot of newer techniques. It could be the balloon, it could be the fancy techniques. Lat dorsi, I went through that, and then lower trapezius has become fashionable. That will be fashionable for a while. Then same thing with SCR. So whether SCR is enduring and will stand the test of robust scientific interpretation, we will know 10 years later. That's important. So don't get flown. This is amazing. Recent, last year's publication, 154 patients, at least 6 mm thick graft, and you can see retail rate of 11.7%. 14 of them failed within 6 months. 2 failed at 1 year and 2 failed at 2 years. These are honest response. But look at the ACA scores. From 75, they've gone to 93 consistently for this population. He's used it for patients who are 49 years to 87 years. So I need to counsel and bring some sanity in this argument that I don't see any role for SCR in somebody who's 70 plus. I'm sure Prathamesh, me and Kalpesh would advise a reverse shoulder, much more consistent, reliable, and it's done and dusted. Much more expensive, but SCR is not cheap anyway. That's why. So in conclusion, younger patients, I would do it for anybody less than 60. The patients I've done them are 37 and 50, 55. You have to choose the graft correctly for sure and understand the technique and the logic of doing an SCR. I don't think synthetics are substitute. Our follow-ups are about 3 years, not more than that. So far, touch wood, everything gone well, but we are handpicking our patients. We are not recklessly doing this for anybody else. So far, healing rates have been good. We have had no infections, but infection is a worry. Mihata uses vancomycin on his graft, like many of you use it for ACLs. I don't use vancomycin for my ACLs or my ACRs. So maybe once the infection hits, then I might change. But that's the whole thing. Thank you.
Patient has already taken to work, so all the questions
Yeah,
will.
from the theatre, yeah.
Any
Sure.
particular thing you want to highlight about the patient we are taking, or we'll discuss in OR?
We'll discuss in OR.
Okay.
Yeah, just give me a lot of rope. It's not your usual surgery, so bear patience with me. It's not my, it's not an easy work. Yeah, very well.
I just brief about it.
તમારું ડેસ્કટોપનું ફોલ્ડર હું ત્યાં લઈ લઉં આ વિડીયો છે આ લિંક છે આને પ્લે કરવાની છે આપણે પછી હાઇપર લિંક પહેલાં પેલો વિડીયો પછી પહેલાં તો
पहला एक्सरे ले लिया बताई दिए शेयर करना स्क्रीन पे पहला एक्सरे मूकी दे हाँ रोक मूवमेंट बताइए चल પછી एक्सरे बताइए हाँ ये हाँ बताइए पहले चल कनेक्ट कर देना हाँ बराबर लिंक पहले कनेक्ट करी देखे ओके મારો તો લાઈવ સર્જરી ખાલી મારે એ કરવું જોઈએ સ્વાગત મને આપીને જતો રહે એટલે તેનો જ લાઈવ સર્જરી જે કરવાની એનું ફ્રી ઓફ ફ્રી જો ક્વેશ્ચન ને ખાલી બતાવ્યો ને કે શેનું કરી રહ્યા છે આપણે મારું પ્રેઝન્ટેશન કર્યા પછી
રોબોટ આવી ગયો આપણે સ્ટેશન
ब्रीफ कर दो हमने મને એ તો બતાય All right, so the case that Dr. Babhulkar is going to operate today is a 60-year farmer. He has history of right shoulder pain and weakness with difficulty in moving the shoulder since 3 months, just a trivial injury. So that's the passive range of motion of the right shoulder that the patient has.
Hello, Dumil?
Yeah, Swagat.
Yes.
So we are showing them the pre-op range of motion right now. That is the external rotation.
So pre-op passive range is full.
Full,
but
yes.
Active is having shoulder paralysis.
Yeah, we are just showing them. So this is the active range of motion. Inability to lift the shoulder actively beyond 90 degrees.
Patient had history of trivial trauma before 3 months, but he was having pain earlier as well. Pain and weakness. He is also having supraspinatus tear on opposite side as well.
Yes. So that's the pre-op X-ray on the right side, right shoulder. Swagat, can you see the X-ray or no?
Yes, X-ray most likely normal. There is no gross superior migration or no osteoarthritis. Preoperative supraspinatus power is 2 and infraspinatus power is 2.
So we will just show them the MRI pictures.
Yes. We won't be able to see the MRI. Please show the all images in MRI there.
Yes, we will.
ब्लू वाला शीट हाँ
Okay, share karo. So that's the axial cuts on the MRI. Not a good image that we have. So there is biceps tendinitis anteriorly. There is fraying of the subscap anteriorly, upper third portion of the subscap. There is a massive posterior infraspinatus tear that you see. That's the coronal image from anterior to posterior showing massive supraspinatus tear and also infraspinatus tear. Teres minor looks okay. That's a sagittal image from lateral to medial showing a massive tear in the anterior aspect of the rotator cuff, which is supraspinatus. Again, coronal image showing a massive supraspinatus tear along with an infraspinatus tear. Swagat? Swagat, are you there?
Sir, joining in 2 minutes.
Yes.
Looks like a repairable tear.
Repairable tear. I agree. I agree. Because the quality of the cuff is also good.
So this is, I have
3 months old, post-traumatic, pseudoparalysis.
I have thoroughly observed Thiru Miyata's work and he picks up the cases like this.
Yes, which are repairable.
Which are repairable. So rather than, he augments the repair instead of straight away SCR.
Deltoid axillary nerve sensation okay, deltoid function is also okay. Yeah, power wise okay. Yes, yes. So what they do is they put a superior capsular reconstruction graft on the GT, and over that they can repair the cuff back on it, augmenting a repair. Smoke was for it, not
Another, my question is, subscapularis deficiency is a contraindication, but external rotation lag sign.
Yes.
Is the contraindication or?
So in my practice, yes, it is a contraindication for SCR. What I prefer for external rotation lag sign is usually a lower trapezius tendon transfer, because it clearly tells us that it is actually a posterior superior massive irreparable cuff, ER lag sign. When most of these patients, they present to us with pseudoparalysis, and when they have a good external rotation, it actually means it is an anterior-superior massive irreparable cuff. So when you have massive anterior superior irreparable cuff, for most of my patients, if I have a good biceps, I read out the biceps, and over that I do a partial cuff repair. Like, it improves the strength and stability of the cuff repair. But if it is a posterior superior cuff tear, I would refrain from doing an SCR or a biceps transfer. I would in fact do a lower trapezius tendon transfer. The graft comes from posterior and fixes on the anterior aspect of the GT.
So whatever, what case Dr. Babhulkar sir has shown 1 year old GT fracture. Now greater tuberosity, it takes lot of, most of the infraspinatus tendon. So it was a challenging case, and with the SCR he got a good result. So I was still on MI. Because
What about the refixing of that retractor tuberosity?
It was only immediate post of GS.
It was 7 weeks.
yeah. So
I got my finger by.
Yes, Drumil.
Yes, sir.
Immediate post, right? You have to sew 6 months or 12 months at this point.
Hello.
Yes, sir. Yes.
Yes, we are in OT and getting scrubbed and about to start, but it will take at least 15 to 20 minutes.
Swagat.
Yes.
Can I show my biceps rerouting meanwhile, so that we can finish off that lecture?
Yes, perfect.
Okay.
Start that lecture. Yes.
Right, so meanwhile we have 10 minutes to discuss massive cuff tears, biceps rerouting in massive cuff tears. For most of the patients that we have in our practice, we end up doing a partial repair, and most of the sports medicine surgeons here, they do know that the partial repairs are also successful in most of our low demand patients with massive cuff tears. So the anatomy is that the superior capsule that we have in the shoulder is actually a static stabilizer. It provides an inferior vector force on the humeral head, and the rotator cuff is a dynamic stabilizer. So you need a confluence of both. They both work in tandem to give you a good overhead movement. And that is one thing that we really need to understand in the massive cuff tear, because when the patient is a chronic massive irreparable cuff tear, the tissue that we have is very weak, it is very thin, it is friable. It might not have a confluence of the capsule and the cuff both that we have in a normal shoulder. Arthroscopic superior capsular reconstruction with biceps is a technique described in literature since 2017, and this is a group in Korea who does a snake technique for biceps. What they do is they put an axillary incision, infra-axillary incision, they fish out the biceps, do a subpectoral biceps stenodesis, and the 10 centimeter long proximal biceps tendon that they have is what they fix on the greater tuberosity, like this, that you can see over here. So one anchor goes here, one anchor here, and the other knotless anchor goes in the glenoid. So this anterior and posterior limb of the bicep that you have is going to act like a superior capsule. It is an autograft that is readily available in most of our patients. In some patients, when you have a big humeral head and we are not able to cover the entire defect from anterior to posterior, you can also add a third limb of the biceps, bring it back on the GT like this. So you have 3 limbs of the biceps covering the proximal aspect of the humerus. So that is the snake technique that Korean surgeons follow. There is another technique described in literature, is a biceps loop technique, which is drilling a tunnel from anterior to posterior in the humeral head and then getting the biceps through the tunnel from anterior to posterior and fixing it on the glenoid with a knotless anchor. So that is another technique of biceps loop. And the most common technique that we follow in our practice is in situ SCR of the biceps. Do not detach the biceps from anywhere, just keep the supraglenoid insertion as it is and just reroute the biceps from the groove back on the GT with an anchor like this, and that is going to provide you a static inferior vector force on the humeral head, and that may, unstress the repair that you already do for massive cuff repair. So it can relieve the stress on the cuff repair, and that is the technique that we do for most of our patients in today's practice. When do you want to do a bicep rerouting? A lot of patients are relatively young when they present to us with massive cuffs. So when you are not sure that reverse is going to do well at a young age, patients 55 years, 60 years, then we do a biceps rerouting. For massive irreparable antero-superior cuff tears, I again stress, I have burnt my fingers for posterior superior cuff tears. We don't do biceps or SCR in posterior superior cuff tears. We would want to do it only for antero-superior massive cuff tears. How does it help? It improves your strength and stability of the partial cuff repairs that we do for these patients. So that's the first case, 62-year female. She is diabetic, she is hypertensive, on blood thinners. Most of our patients, 7 out of 10 have hypothyroid, diabetes or hypertension, one or the other. She is in severe pain and weakness since 8 months. She presented to us in 2021. On examination, she is true pseudoparalytic, where passive range of motion is only terminally restricted and the forward flexion is less than 90. She has weak supra, infra, teres minor and good strength in the subscap. So that's the X-ray. 62-year female, proximal migration of the humeral head, tuberization of the greater tuberosity. I think one of our faculties mentioned that if there is tuberization, if there is rounding off of the tuberosity like this, it is one of the signs of irreparability of the cuff. So we need to consider that on a pre-op X-ray. And critical shoulder angle. Any critical shoulder angle is an angle that is subtended between the glenoid margin and the angle from the inferior aspect of the glenoid to the acromion. So any angle which is more than 40, again is a sign of irreparable cuff tear. That's the MRI. Pre-op, when you're doing a biceps rerouting, or when, if at all you're planning biceps rerouting, you need to check whether the patient has good quality biceps. So she has good biceps, there is tendinitis, and there is this massive retracted anterior supraspinatus cuff tear. She also has a massive infraspinatus cuff tear with lot of effusion in the bursa. There is wasting in the supraspinatus and there is also fatty infiltration. So that's the arthroscopic image where we do a formal subacromial decompression first and try to look for where the tendon is. Try to understand the anatomy of the cuff tear, mobility of the cuff tear. And we know that this is a chronically retracted tear anteriorly, and at least the posterior leaf, the posterior aspect of the cuff, the infraspinatus, is coming back to the tuberosity with some difficulty. So here we are sure either we go for SCR with a tensor fascial lata or with the biceps. I do check for biceps in every case. I don't try to cut the biceps first. Try to preserve it if at all it is needed for a massive cuff repair. Try to medialize the footprint at least by 5 millimeters so that it reduces the tension on the cuff repair. And try to release the under surface of the cuff as well, because that is going to improve the mobility of the cuff when you bring it back. Again, it is difficult to bring it back without tension. So finally, we opted for doing a bicep rerouting in this case, where we thought let us try to create a new groove on the greater tuberosity for the biceps. Clean up the flimsy bursa that you have around the groove. And then try to see the mobility of the biceps from the groove. If it is mobile, it's well and good. If not, if there is excessive tension, you might have to do a release of the inferior aspect of the biceps and do a tenodesis, subpectoral tenodesis for the patient. What we do is we put a triple loaded anchor in the new groove. So we have at least 3 bites of sutures growing to the biceps. So it holds the biceps well in the new groove. Most of the stitches, they go through the substance of the biceps. That's the first stitch that goes in. And then another stitch goes from the central aspect of the biceps. One is a circumferential pass and the other one is a transtendinous pass. So that's the second stitch, and then again the third stitch. So what happens is with 3 stitches going through the biceps, it holds it there. ચાલુ છે બંધ છે મારું oh sorry દેખાય તમને. So with 3 stitches going there, it holds it there. And then we also try to do a partial repair as much as possible for the posterior cuff, because that is really important. That is going to determine the function that the patient has post-operatively. So pass various mattress stitches through the posterior cuff, try to bring it back on the tuberosity as much as possible. I do tie my medial knots and then bring it to the lateral row fixation. And then when you go from the lateral portal, that is what you see. In the front is the biceps, where we could not bring the supraspinatus. Then the posterior aspect is the infraspinatus, the teres minor, covering the tuberosity. And when I know that I'm not able to get supraspinatus back to where it is, I try to suture that remnant collagen with the biceps. So because biceps here is going to act like a static stabilizer for the shoulder. And we all know that the dynamic stability of the shoulder is provided by the muscle that is there. So we pass various sutures from the cuff through the biceps and tie it anteriorly. Also 1 or 2 bites from the posterior cuff, because that is really important for both biceps and the cuff to act in synchrony. And the last bite goes from the biceps through the posterior leaf of the infraspinatus, and it just covers up the defect that was there on the biceps. It just provides that healing environment for the biceps with the natural cuff that is there. So they both need to act in synchrony when you are doing a biceps rerouting. And this is what I end up doing for most of my massive cuff patients. And surprisingly, when we see their post-op x-rays, they have good acrohumeral distance, because the biceps does act as a depressing effect on the humerus, and that really gives them good healing environment for the massive cuff. They do well. Most of them do well when we try to repair a partial cuff. That is really important. They do have good muscle strength also. At least they are able to get strength 4, which is good for their daily activities. That is really important. They have good external rotation, internal rotation strength, which is what we want to have in most of our patients at 60 or 55. That's the second case. 59-year male, post-traumatic right shoulder pain and weakness since 6 months. He's a little bit stiff. So I was reluctant to do a cuff repair, but he had massive subscap, massive supraspinatus here. So there you can see it is a dislocated biceps tendon over here medially, and there is a massive cuff subscap. That's the comma tissue that you see anteriorly. This patient also had a massive supraspinatus here that you can see. So when there is subscap with a supra which is massive, again it is an antero-superior massive cuff here, high chances of failure when we do a primary repair. So I try to decrease the stress on my repair with the biceps. So that's the medial dislocation of the biceps because of the massive subscap. And when you see here, and when I try to hold on to the comma tissue and bring it back to the lesser tuberosity, it is just not coming back. So it is a retracted adhered tissue, massive supraspinatus, and coming back to the greater tuberosity with difficulty. So this is the case when I try to unload the excessive stress on the cuff just by adding a biceps on the inferior aspect of the cuff. So biceps here is going to act like a superior static capsule, and the cuff is going to provide the dynamic stability the shoulder needs. So the first thing is create a groove and get the biceps out, because it is already dislocated medially. It really hampers your subscap repair when your biceps is in the way. So the best thing in a massive subscap is to get the biceps out. and again pass various stitches. You can also pass a lasso stitch with a direct passing device, create a loop, and then pass the suture through the same loop. That's a lasso stitch that has a better hold on the biceps. Tie it back to the new groove, at least 3 stitches, and then you see that the biceps is there. And then try to act anteriorly beneath the coracoid, try to release the subscap as much as possible, and then with a triple loaded anchor, get a subscap back to the lesser tuberosity. Pass various sutures through the substance of the subscap because it is very, very important. And then bring it back. So that's the anterior biceps. And now try to do a partial repair of the cuff over the biceps, because biceps on itself does not have any dynamic stability on the humerus. It is a static restraint for the humerus. So I try to pass like a primary cuff repair that we do. Because it was a massively retracted tear, we have to use sometimes thicker sutures, sometimes suture tapes. In this case, because it was not coming back, I had to use a 2 mm fiber tape to have good hold on the cuff tissue. So those are the sutures which pass through the cuff. The biceps is down, there you can see it is going to act like a static restraint, and it will unload the pressure that you have on the cuff repair. That is what it does. During the first 3 months or 6 months, that's the subscap repair that you have anteriorly. And that's the entire cuff. But beneath the cuff, to reduce the stress on the repair, you have the biceps, which is augmenting your repair. So most of my patients, when they have a massive irreparable cuff tear, I try to augment my repairs with biceps. At least short-term results for our patients have been good. They are able to, so he's a farmer. His main job is to do strong activities. We have clearly refused him from doing any strong activity, but at least they are able to get their basic daily activities back. So the advantages of using a biceps are that biceps is readily available when you go in. It is always there. Try to look for it. It's an autograft, so you decrease your chances of infection when you're using an autograft. It is locally available, so you avoid the donor site morbidity that the patient has with the tensor fascial lata. And the operative time is reduced. For the first SCRs that we used to do for our patients, we used to do around 2.5 hours. With biceps SCR, most of our patients are done within 1.5 hour. So it reduces your operative time, less technically demanding, lesser anchors, so lesser cost. And the biceps has an intact blood supply because you are not using it as a free tendon graft. You are keeping it attached inferiorly and superiorly. So it has intact blood supply, intact tenocytes and fibrocytes, which may have a role in improved healing. Disadvantages with biceps: if there is a biceps rupture, you need to take an autograft from the other side. Or if there is any biceps with a partial tear more than 20 or 30%, it might not have the same stabilization effect on the cuff. So then you have to think of options. These patients may end up with initial pain of biceps because of the stretch pain that they have, but most of our patients have been comfortable post 3 months of surgery. So take home message with biceps SCR: we routinely augment our cuffs. It is not the standalone procedure. We just augment our cuffs with biceps. It is safe, it is effective, it is less time consuming, and it has good effect on the pain scores of the patients and the shoulder function. Thank you. સ્વાગત છે. હા, એટલે એનું થઈ ગયું હોય તો આપણું કે બીજું લેક્ચર લેવું છે? હા, એટલે ડિસ્કશન કરવું છે. ઓકે ઓકે. Yes, so then that is the main point, that I try to assess initially on the MRI whether the patient has a good biceps, a rounded biceps. If there is a split in the biceps on the MRI axial image, then maybe it is not a good quality biceps. It is not going to have a good hold on the sutures that we pass through it. So then the only option is a tensor fascial autograph for the patient. But it has to be an anterior-superior cuff tear. I have ended up doing a SCR for a posterior-superior cuff tear. Those patients just don't do well because it doesn't have the same vector effect. Posterior cuff is still there, absent. So they will still be external rotation lag, horn blowers positive, pseudoparalysis. I was reluctant to, yes. So the only reason to fix it in the groove is that we actually want a depressor effect of the biceps. That has to be a negative or inferior vector force on the humeral head to keep it down. Because the fear that we have with massive repairs is that the quality of tissue is so poor, even if you pass sutures through the cuff, it might not have the depressor effect. So putting it in a new groove on the posterior aspect of the GT, I just try to be within 10 millimeters of the anterior groove, not too posterior, because I always try to repair the posterior cuff with another anchor. I don't use the same anchor that I use for biceps also for the posterior cuff. Those two are different insertions, those two are different footprints. Yes, yes. Yes. So just 10 millimeters behind the biceps groove that is already there, natural biceps groove, just 10 millimeters behind it. We want to be in front of the insertion of the infraspinatus as much as possible. I don't do the tenotomide of the distal biceps. I have seen a lot of surgeons who do it, but most of the studies, they suggest that it is not required. Lot of people who harvest peroneus longus for ACL, they do a tenodesis of the peroneus longus and the brevis, and lot of surgeons don't do tenodesis, and the effect is the same. So we don't need to tenotomize the biceps in all patients, and I haven't done in all my cases. No, it is the only good thing about biceps is it is very stretchable, and we are just going 10 millimeters behind the groove. We're not far behind, so it just reroutes your biceps just behind where it actually is. We are not putting undue stress by putting it posterior. We don't want to put it on the posterior as of the GT, only on the center of the GT where the supraspinatus should be actually. So it will just unload the repair. It is not a standalone procedure. It is not going to act like a cuff. That is the main thing.
Hi.
It's better than facial art also.
Yes.
Because again, kind of already pre-tensile graft.
Yes. And when we do a facial ATA, we always suture it to the posterior cuff with all the remnant tissue that you have, because you want to have that synchrony between the original cuff and the superior capsular reconstruction. So biceps is always readily available. It is cheaper definitely for most of the patients, and it is technically easier for most of us. I mean, Dr. Ashish Babhulkar doing an SCR, it is okay for him because he has been doing so many shoulders. And whatever technical challenges that we have faced while doing an SCR are all overcome with the biceps SCR. And both act, yes. Cost is an issue also sometimes if it is not the cost. If it is not technically challenging, most of us will be able to reproduce our results.
Correct,
that is the main thing.
correct, yes.
Yes.
Why not to do posterior cuff first, posterior cuff repair first, then do SCR, like rerouting of biceps?
I
Does it make
agree.
sense?
Most of the time, I try to check the mobility of the posterior cuff first, and then my first anchor invariably goes in the new groove that I put, because sometimes I'm afraid a lot of thin females, they have small humeral head, we end up with, fracture થઈ જાય sir. બે anchor નજીક નાખીએ તો. So first anchor goes in the biceps, and then I see if there is good bone stock available. I put another anchor, or else I just push tapes through the cuff and do a lateral fixation for the posterior cuff.
Any reason for metal anchors in the biceps and peak or bi anchors for the other?
The company that I use has a triple loaded anchor only is metal, and most of the time, a lot of old patients, I have a better pull out strength experience with titanium anchors somehow.
Even myself.
Yes.
Above 60, I always go for
Metal,
titanium.
because when you do a peak anchor, suppose, or a bioabsorbable, you actually put a pilot hole and then you put an anchor. I don't want to put any pilot hole first in those osteoporotic patients. That is the only thing that I do. It is a personal experience, nothing else. Nothing against those companies who make peak anchors. And nowadays, I only use all suture anchors, and they are really good. They have good hold in the GT.
Even Iconics 3 you can use for
Yes,
cuff, yeah.
yes.
Metallic suture anchors do have advantages in osteoporotic.
Yes.
Tremendous.
Fear of
Peak, ne? Peak કહે છે તું? કેટી?
Metal.
No, metal is, I am always using above 60, always metal.
Metal has a better pull out strength in our
Like,
experience.
subconsciously we are confident.
We don't want to drill a pilot hole. That's the main
Exactly.
thing in those patients.
Just pushing ankle.
Yes,
That's it. Yeah.
yes. Lot of all suture anchors have an advantage because they have a smaller diameter. So you have better points of fixation for the rotator cuff. Means you can put 3 medial rows also if you want to. And when you are doing a case like this where you have multiple anchors in the medial row, I now routinely use all suture anchors which are just 2.8 millimeters, thinner than these 5.5.
Now, I had seen in Korea
Yeah.
when in 2017 they were using all suture for medial row.
Yes.
but I have seen pull out also.
I agree,
So,
but
so for them it's okay. For
even
us,
if
it's a big thing.
even if the all suture pulls out, the advantage is it is not metal, it is
Yeah,
not
yeah,
plastic,
yeah.
it is not going to impinge on the cuff, it is not going to have an inverse outcome on the
Only
patient.
thing is cost.
It costs maybe, but if it is an all suture anchor, if it comes out, no radiological problems, maybe the patient doesn't even feel that anchor, but the sutures are there through the cuff. You have fixed it to the lateral row, so you have 2 points of fixation for all suture anchor. Loaded anchor, loaded soft ears, but otherwise most of them are double row.
How many of us are doing single row only? Karnav? Yeah. Any difference? Or you were using double row earlier?
You find better results with single row? Yes.
Not better, but there is no
Equal results, yes.
Yeah, that's
I
what
agree.
for 1 decade I did double row, then single row, no difference.
So the problem was one patient when I operated with a single row, just 2 anchors medially, and somehow during rehab that ankle just the anchor came off, and then I had to revise that. The only advantage of putting a double row is that it just reduces the stress on the medial row. Those sutures that you're passing through the cuff, they have an additional fixation on the lateral row. So the best
And
thing
there are
is,
chances of over tensioning the cuff also.
so the most of the anchors that we have, the lateral row that Kalpesh sir mentioned, are tensioned with your tactile feedback with your hand. So when
There
we are
is no
trying to put an
criteria
anchor-
for it. No? Just we are just feeling that this is okay.
There is no criteria, but you don't want too much tension. That I agree.
Again, I am stressing on the, rather than going into debate of the single or double, it should be a anatomical repair, tension-free repair, right? So if you feel that your double row can over-constrain then you go for a single row repair. But double row has an advantage over a better footprint coverage and good footprint tendon to bone compression. That is
Like
for sure.
transosseous. It is the closest to transosseous that we have.
Agree, 100% agree.
Double row.
Any questions?
So that is the reason of using all suture anchor. That helps. If it comes out, all suture is just suture.
Medial row, you've done medial row repair first, and before you are doing lateral row, the medial row comes off, the medial row suture anchor. And you just used one, there is no space for more, or maybe you don't want to use. And the suture anchor, which was good to start with, good pull out strength, before you do the lateral row, now it has started coming off. Maybe the angle of insertion was bad, or maybe it was a tight repair, whatever. But now what do you do?
So I try to usually reinsert the anchor with a thick K wire. I use a thicker K wire. Blunt and ST pin also can be used. 4mm ST pin. And try to reinsert the anchor little bit down and try to again check for the hold. But the only reason for switching over to all suture anchors was this: sometimes if it comes out, if it is an all suture anchor, it is just a suture. It is not an anchor.
Best thing would be to do a transosseous.
Yes.
Remove the anchor.
Remove the anchor and do a transosseous.
So one of the ways that can be managed is, sorry. So take a transosseous suture and take the cuff along with introduce it or make it a part of the transosseous repair. That will take care of the by and large.
If I may ask the senior faculties, do you open transosseous or do an arthroscopic jig that you have for it? Open, you do open, okay. I think we don't have any commercial available jig in India for transosseous. There are only 1 or 2 companies who make it in USA, Tornier, and they are not available here. मैं हमारा सगा ने पण एक बार फैक्ट्री में मोकल्यो अमेरिका में कि भाई आओ तो लई आए. But they don't give. They just don't give. Even if you want to buy in Tornier company in USA, they don't give it free hand.
Trauma surgeon, they are doing tension wiring without any jig.
Yes.
No, transosseous.
Yes. Arthroscopically is little bit tricky when you have poor bone stock.
Even when Dr. Ashish showed, it was a big hole. There was no IOBAN. The graft was touching the skin and going inside.
So-
was already there. So there are lots of other
I agree. So that is the reason why we try to use a cannula, big cannula. We can use a 20 millimeter syringe, sometimes thick, that we use for anterior bone graft, arthroscopic, that we frequently use for iliac crest bone grafting arthroscopic with a 20 millimeter syringe. So that is a thick syringe, anterior. Passport is good, but 20 ml syringe is the ideal one. You cut it open, make it short, and just put it just for shuttling the graft, and then just bring it out. Almost. એટલે તમારું તમારે લેક્ચર આપવાનું હતું મિની ઉપર એટલે અમને શીખવા મળે કારણ કે all of us should know open technique first. The sad thing is most of us are young surgeons are trained in arthroscopy first and then they do learn open bankard or open cuff repair. That is the sad thing. The world is so techno savvy that you want to learn arthroscopy first. That is the main thing.
That will be for fellowships or open surgeries now.
Yes. So surprisingly we have fellows for trauma now. Scopy na 2 હોય પણ trauma na 4 હોય. We have 2 of our fellows here from our hospital. They want to do trauma only. મારું જોયું બધું કામ પણ પછી કે trauma જ કરવાનું આપણે.
Excuse me. Can you elaborate more on graft harvesting technique for the SCR?
Tensor facial atta. So lateral position is easier for most of us because what happens is a lot of bulky females, they have fat in the thigh. So when you do a lateral position, the fat just goes away and it is easier to approach the tensor facial atta like you do for your hip replacements. And I try to be within 5 centimeters of the greater trochanter on both sides. That is where you have the maximum thick tensor facial atta that you want it for your patient. And try to harvest at least 20 centimeters in length because and approximately 25 or 30 millimeters in thick in the width. Why 20 centimeters in length? Because you want to double fold it twice. So there is a 4 layer of TFL that is there. They are going to show you maybe. And that is at least 8 or 10 millimeters thick. That is what you really want your SCR to be. If it is 8 or 10 millimeters, it is going to survive well in most of your patients. And then just do routine suturing. I have also done beach chair SCRs where I have done a minimally invasive harvest of the TFL. You put 3 vertical incisions. You strip off the fat subcutaneous tissue from the TFL. You do a minimally invasive knife and then you have a long scissor with which you can harvest a 20 centimeters long TFL, but always easier to have a TFL in lateral position because you get the thickest graft. You can always feel for that, have a bigger incision to start off. Minimally invasive to start off, you might end up pre-cutting the graft or you have a thin graft harvest, which is not good for your SCR. So mostly lateral position. In my practice, I just do biceps now. I have switched over from SCRs in TFL here. I just try to unload the cuff repair, but I want the cuff there. Otherwise, I explain my patient reverse shoulder.
So what was your main gut feeling for switching over?
I think the main gut feeling was I have been used to doing cuffs in beach chairs for a long time. I don't want to again switch over to lateral because passing the sutures in lateral.
Switching over from facial
Because the results were the same.
पर वो
At 3
ग्राफ
months
को
to
भी
6
बंद
months,
करना है
results
बीच
were the
में से
same in both the patients.
ग्राफ के बीच में हाँ
There is a catch here. There will be some pain and biceps will be absent.
That is when you want to have it. Yes, sir.
Yes, we are ready in OR.
Yes, okay, go ahead.
Yes, चालू कर दे जो. हाँ.
नंबर 1
Is
नंबर
video there? Yes, sir. It's on.
चालू.
Yes,
Hi
yes.
guys, can you hear me?
Yes, I am Dr. Pritesh, moderating the session.
Hi, Pritesh. So we are just preparing, just to give you a heads up. You guys have seen the clinical picture, 61-year-old guy. I need to share some background with you. The original patient that was planned for today was fantastic. It was just ideal. That patient had a cardiac event. So I thought we are off the cover and we will do something very simple. But you guys know the reputation of Swagat Shah. In 3 weeks, he has got 2 more patients of SCR. Ideal. Absolutely ideal. I can't fault him on that. That is my whole year's work because as I said, I do 2 or 3 SCRs in a year. तो 3 हफ्ते में 3 आइडियल SCR कहाँ से मिलते हैं मेरे को जरा देखने का ही है. So what I meant was that this is 61 is the right age. I don't want to do a reverse for 61. My threshold is 70. I physiologically 65. But somebody who's had a pseudoparalysis for 6 months, if it was repairable, he would have improved, the force couples would have taken over and please, and things would have been reasonably okay. But at 6 months with atrophy and the quality of this cuff and that cartilage is absolutely that his active range is pseudo-paralytic, but his passive range is full. So that's ideal. And there's no proximal migration on X-ray, no H changes, Hamada, nil, subscap is like a grade 1 tear, perfect. You can see how much pressure the biceps has been taking. So the biceps is completely atrophic. It's useless. It's not worthy of doing anything on this. But I'll keep it and I'll decide what to do about that later at the end of the case. So that's your thick MGHL. And if I take it aside, what you see here is a complete subscap just here. See? So that's his subscap. It's good. There's a small hole in there. It's a type 1 tear. I'm not going to repair that. That's going to become much more tighter later. So we don't want to make him stiff. The entire shoulder joint is open. And this is all retracted here. Very poor quality tendon here. And it's going all the way here. Okay? So posterior cuff looks okay, but the supraspinatus has no pressure in it. That's my footprint preparation. That's my anchor insertion preparation here, and we'll go down. I have measured on this front, so that is where my anchor will come in. So that's about, let's say 15, no, let's say here, just about, 15 at the cuff end here. That's another 15 to the insertion, that's 30, and then I need 10 more here. So that's about 40 mm in this direction, medial lateral, and then we also need to measure the AP direction to plan our graph.
So how much beyond glenoid margin you will be inserting the glenoid anchor?
5 mm extra, including the footprint, the entire footprint and 5 mm extra. So we are taking a 35 length graph, and the front to back is about, let's say it's 20 till here, and it's another 20, 40, so about 35. I'm not interested in this part. I'm not going to repair it. I will be repairing it here to the posterior cuff. So about 35, 40 I have asked for the medial lateral, and about 35, 40 for the anterior posterior. So we can go now, start. What we are doing now is the first is the anchor placement from here. Now, this is where I've innovated and done something new. So we'll share that with you. So that is my first anchor in the anterior glenoid.
So you are using Navier portal?
Anchor. Come again?
You are using Navier portal?
Yes, I'm using Navier portal.
And 2 o'clock,
So-
2 o'clock will be your marking?
Yeah.
Okay.
So just here 1 o'clock and just here 11 o'clock. Okay. But we'll probably use different portals for insertion here because my needle is getting angulated. Unless I take a central route, I'll take this route. Yeah, this is better. So now I can go here and here to that same portal. Simultaneously, my fellow Manish has already taken the IT band. So we work in sync. He knows my technique. So we have imported him from Pune, and he is going to prepare the graph side by side on our record. We'll show you that as well soon. So that's my portal. I'll just use the shaver to clean up the area a little. Mind you, this is area that can be really vascular.
So here the graft is taken from
Lot of fat here.
from the right thigh on the lateral part TFL, and the total length of TFL complete length is 15 mm. So
Doubled 50 चाहिए था ना मेरे को.
So single
Double 40.
So this is the actual graft. It is around 15 mm by
triple
around
15
They need
centimeter.
100
Length,
centimeter.
final कितना length है
10 centimeters, so double would be 50 centimeter. 5 centimeter.
So 15 centimeter length.
Okay.
Around 4.5 width.
4.5 centimeter width.
They become around 5 centimeter in length and 4 centimeter in width.
Okay, so in double we need 5 by 4 centimeter.
5 by 4. Tripled.
Tripled. Okay.
So how much would be the thickness?
Thickness, I'll tell you, it's a very thin graph. So once it's tripled, I'll let you know. I'm hoping it should be between 6 and 8.
He's saying that because this fascia is thin, that's why the tripling is done. Otherwise, if it is good quality, then double is enough. But we need final 5 by 4 centimeter for this case.
No, cannula nahi, without cannula. So my technique is without cannula here. I started with the cannula and just there. I'll tell you why I don't need the cannula. Chalo. Artery first, artery. So we are using peak anchors here. Peak interline 5.5. First one going, one sec. Yeah, going here. Yeah, looks good. Footprint there which has been prepared for it to heal onto. Okay. Ready? So this is the tricky bit without the cannula. Okay.
Intraline striker નું 13 પડે including GST.
એક
ટોટલ માર્યા કરજો પતે ત્યારે RSA જેટલું થઈ જશે.
बस परफेक्ट परफेक्ट लव दैट. गॉस्पीस देगा मेरे को कोई. थैंक यू.
What is the purpose of using 5 mm instead of 3 mm?
Come again?
You are opting for 5 mm anchor, correct? Any specific reason?
5 mm for here?
Yeah.
Yes, yes. Glenoid is 5 mm always. Next. Because if you look at Mihata's study, his maximum failures have been on the glenoid side. Hardly any cuff side failures.
Could be because of the Asian glenoids?
It is osteoporotic, yes. So double loaded 5 mm.
You always go perpendicular to the surface or
Always.
90 degree?
Always. So my effort is perpendicular. It might go 70, which is okay. But always perpendicular.
And parallel?
Yeah, yeah. Okay. One sec. RF. Regular. So switch on. Very fragile tendon. Go. Now these are special anchors which we ordered for this case. These are 5.5 mm anchors, peak, loaded needles. Now you will understand the logic why I didn't use a cannula, which makes the job difficult, tricky, and so you can get everything mixing up because there are 8 sutures there, but there's a huge advantage here. Oh dear. So we've got one needle wala. Mayo needle डालो इधर.
Audience wants to see the glenoid, if you can show us.
Glenoid?
Yeah, yeah, yeah.
Here
okay.
you go.
Yeah, yeah, okay.
Is that okay?
Yeah, yeah.
Okay. Now I need eye stones. Mayo needle है क्या? Okay. So watch what I'm doing here now. So this is again the tricky part. Oh. Oh, green. Don't green. Coming out. Watch what happens here. Yeah? Did you see it? They came out with the needle. That saved me some time. Watch this now. Oh. No, you know, sorry. One sec. Let me show you. Do that gently. And then it snags on the needle. Hello. Happen in a flash. Yeah, did you see the needle coming along? There you go. There's the needle. And one more. Yes. Chalo. Graph ko kitna time hai? Okay. We'll wait here. Our preparation here is full. So the plan is Nanta. I'll have one interline here, maybe one speed iconics here, and then those will be double loaded through the graft. The trick is when the graft comes in, everything becomes crowded, busy, and then I need 2 more omega here. So that will be the thing right up there. So that omega will come around there so that I get a complete coverage of this footprint.
That's right.
So on the graph also show the camera here. Bloody. What you're seeing here on the graph preparation is he's folded the graph. This should be about 6 mm thick. But he's taking intermittent sutures in the body as well so that they work uniformly because you don't want them to slide as top and bottom layer. So there are sutures on the margins and sutures in the center as well. That's a new modification that Nihata has proposed.
Swagat, you have some like signboard or something in OR so we can see on the board how he's designing it.
Come again, I didn't hear you.
Any diagram showing on the board if it's available? Sketchboard.
Can you use another mic because voice is not clear here?
स्वागत, हमने स्केच बोर्ड पर तो डायग्राम दो बताइए, हाउ ही इज प्लानिंग फॉर इट.
Diagram, okay, but I'm sterile right now.
No,
I'll show the
Swagat,
diagram.
can Swagat help him?
Swagat, your drawing skills are required. Okay, here's a graph. Okay, there Amit है. हाँ, हाँ, ठीक है. Good.
मार्कर आप बॉटनी मार्कर बॉटनी मार्कर I think
3.8. 3.8.
ये ना
ठीक है. Okay. Okay, मुझे धक्का मत देना. हाँ, thickness 7. 8 mm thickness on the medial side and about 5 to 6 mm on the lateral side, which
Great.
was good for me.
Great.
Chalo. Needle holder.
You are keeping margin of 5 mm on medial anteroposterior. That's it.
Yeah.
5 mm more.
So, needle holder. So no, thickness is 8 mm on the medial side
Yeah.
and 5 to 6 mm on the lateral side.
Great, great.
Either light though, please.
लाइट आप
Needle holder. Okay.
This will go middle.
Thick wala, thick wala. Of course.
आयोबन अप्लाई करियो.
हाँ, करेक्ट. ऐसा पकड़ के रखो.
ये दिखा रहा है अभी?
If cameraman zoom in and show us on the facial ata things.
डाला था ना कितने ट्रे में?
कैमरा जूम कर दो.
So these are medial sutures.
These are medial sutures, and because I got them on the needle, it just saves me the task of sewing the needle and speeds up the surgery. Unfortunately, second set of anchor is without, so I haven't saved that much time that I should have. Your needle next. So these are in sequence. So we got. We'll have to cut those needles off. High strong, please. ये हाथ में रखो तुम्हारे.
Knife.
Artery लाऊं तक तला mosquito. Ice tongs.
These are anterior anchor sutures.
वो बाद में करना. हाँ, तुम लोग अरे ice tongs देना मेरे को. मैं 3 बार मांग रहा हूँ ice tongs. वो कट कर और उसको मस्कीटो लगा दो. Then I come here and then I get all these.
Wait.
Okay, artery card तिकड़ जी. Coming out like this. Okay.
If we can little bit zoom out and show us what you are tying, for sliding and all.
हाँ, sliding को time है. I'll show that. अभी time है.
Okay.
दे पकड़. I'll show you. First I have to suture लगाओ. Needle holder. इसको artery लगाओ. 4 को. Mayo needle and उसमें mayo needle लगा के दे दो. इधर अमित. हाँ. Yeah. So you go green, white. See, this challenges my vision also and my hand-eye coordination also. इसको रितेश को जुर्माना भरना पड़ेगा. और यार नहीं इसको काट नहीं सकते. वो काटेगा तो और मुश्किल हो जाए. तो शादीशुदा है. तेरे को इतना आसान लगता है. नहीं है. मेरे को दूसरा नीडल है क्या? इतनी बड़ा होल चाहिए उसको नीडल को. लगेगा.
फर्स्ट पास आप ही दो ना साहब ने. फर्स्ट पास आपो न भाई.
नहीं फर्स्ट पास है. वी हैव अ फर्स्ट पास. वन मस्कीटो दे. वी आर गोइंग टू शो द फर्स्ट पास डेफिनेटली. स्वागत का असिस्टेंट है. उसका स्केल कैसे दिखाएंगे? छोटा नीडल होल्डर चाहिए भाई.
वापस डालो चल छोटा नीडल होल्डर दे ये ले डाल mosquito किधर गया
Any some criteria for keeping the distance between the sutures, Dr. Ashish?
1 centimeter for the medial side because that is the amount of that and 2 centimeters for the lateral side.
No, that's okay. I'm asking the suture placement. You are just now passing.
Same 1 centimeter so that you have an overlap there.
No, no, on the graft I am asking, you are passing just now, so keeping 3 mm or 4 mm distance between the sutures?
No. It depends. It has to be equidistant.
Okay, okay.
Because sometimes I take a 40 mm graft, today it's a 36 mm graft. So ensure, चलेगा मैं manage कर लेगा. Don't worry. ये लो.
5 to 8 mm lying over the cow, over the glanard.
About 8 mm today because it's a smaller graft.
Okay.
But to ensure that you don't crowd your sutures too close. चलो वापस लो. मस्कीटो तैयार रखो. ये पतला है. हाँ चलेगा. ओमेगा का होगा ना. ओमेगा खोल दो. ओमेगा के अंदर आ जाएगा लूप. नहीं ये ऐसा नहीं. ओमेगा का लूप दे दो. ओमेगा खोल वो देगा. बहुत मेहनत है. हाँ 1 मिनट. मस्कीटो किधर गया मेरा मस्कीटो? बाहर आ गया.
Dr. Ashish, do you do any pre-tensile things like what we do in ACL?
Oh, no. निकल. No.
Do you think in future people may go for it?
Maybe if knee surgeons start doing SCR. Okay.
Or more technical people?
Maybe.
Yeah, because the logic is same, no?
Yes.
We are putting it as a graft.
Yes.
We are not sure of the stretchability in vivo.
So the difference in the ACL and SCR is that the ACL is loading all the time forever till it fails. The SCR is meant to last for 6 weeks or maximum 2 months till the force couple manages. So SCR doesn't do magic. It's a force couple that does magic. Do you get the point?
Yeah,
so if the graft or the balloon fails after 3 months, it doesn't matter because the balancing has been done. It's the subscap and the infrateres which do the trick. Forceps, please. The SCR is just facilitating, so it is never going to be loaded.
So vector is going to be different after 3 months. That's what you mean to say?
The SCR is not loaded like the ACL.
Vector in this case will be changing after 3 months?
If the head of humerus centralizes well, then it will be. Okay, eye stones. So I'm now pushing the sutures back inside. अरे बाबा छोड़ो. पुली करून टाकू हाँ ओके ठीक है पहले पहले नॉट लगाओ चलो हाँ
If you can
Watch
just
this.
explain to
Watch
audience
closely
what,
हे व्हाइट एंड ग्रीन हे सोड हे दोन नाइफ रेडी रखो वी आर गोइंग टू रिड्यूस आवर सूचर्स वॉच व्हाट वी आर डूइंग दिस इज द पुली टेक्निक we
simple
are
knots
trying two dissimilar sutures so the green
from the same anchor, correct?
from the same anchor so green and white go together
How many knots you tie to be
just
precise? Three knots. Okay.
no for each three and then total four ठीक है ओके दैट्स टाइट ते सोडून दे दूसरे वो हाँ पुल द अदर टू पुल द अदर टू पुल नहीं गलत पुल कर रहे हाँ पुल चल है ना हाँ So the central two we tie.
Okay.
ये तेरे हाथ में रख.
Peripheral you will tie intra-articular.
No, yeah, well, so the peripheral are the pulley. So this is the pulley technique. नहीं एकत्र कैमरा में दिख रहा है
Not very clean. सेंटर में रखो ना भाई कैमरा.
हाँ कैमरा ये दिखाओ. खींच 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 यस यस ते और ट्रिम कर सकता है ना उसकी. हाँ पुल. आई स्ट्रांगली परफेक्ट परफेक्ट. उसको भी छोड़ दे. So when he is pulling the, yeah, perfect. Do you see this? Yeah?
Yes.
Nice.
Yes.
It's taken it. Now, give me all these four. These four are not tight. These come. Hither. I've got my wrong hand. Yeah. That makes it easier. All four out. हे पकड़. हाँ. आता correct कौन से थे बग? Check which is which. So he has to pull the dissimilar ones. One sec. दोनों अलग अलग करो. हाँ. हाँ. तेरा ये छोड़ दे. One sec. Knife please. Knife. Thumb. मतलब अरे रुक ना. Artery.
So you don't use a kind of passport cannula or something?
No. Knife.
How to avoid soft tissue breach in that case actually? Soft tissue.
तेरा छोड़ दे ये. हाँ. नहीं 1 sec. Knife ने मेरे को जल्दी पुल किया. Knife दे.
We are sure that there is no soft tissue in between.
Correct. So this is how it will work. Yeah. Watch inside. Now 1 sec. Pani full. Push. So yeah. Keep watching at both ends, medial end, lateral end. What I'm doing is pushing and he's also pulling.
Can we see intra-articular, a bigger one?
Okay.
Yeah, thanks.
Slowly he will channel it.
Soft tissue लागे ना आई.
There's your graft. Welcome. Gently. It's all through. See? Simple.
Delivered.
Now please, I've got oil on my hand. So that's pull. Pull. So we've got the graft here. Not pusher now. Check which is which. So those are the anterior ones. Let's not mix them. And those are the posterior ones. Okay. So now we are going to tie the knots. Oh, knife. Now from the outside view, you can see it's not a big incision here at all. You just made it enough for the graft. If you use a cannula, then you need a 10 mm cannula. Passport cannula is not enough. So if you have a 10 mm cannula, then you're going to make a much larger incision. Liberator de mere ko. At this time, what the surgeon needs to do is to ensure, you go ahead, time knots, is to ensure that graft has not folded up on itself.
Yes.
Because if it gets folded up, then it can create a mess. Okay. So I'm giving you a better view now. So that's the anterior knot coming into play.
Okay.
So now this graft is going to get locked on the glenoid side.
Yes. Which side you prefer thicker one?
Medial side.
And anteroposterior?
Anteroposterior, it doesn't matter.
Okay.
Usually the metric is anterior posterior will be similar. On the medial and lateral side will be thicker. So you put a medial side thick one because that's the side of failure. You want the thicker graft there. And there's more capacity of the shoulder to absorb the thicker graft on the medial side. And on the lateral side, if you get a thicker one and you reverse this, you will have a very good view here. But laterally, you will thus not have good view. And you must remember that laterally, you're going to put in 4 anchors. Medially, you're putting only 2 anchors, which have gone in before the graft came in. So that's like a rock solid repair. Done. Very nice. How? We can cut that. Sometimes I'll cut it later because you don't want to waste time busy cutting. Okay. Now this is our graft placement here. This is our new rotator cuff. Okay. So because we are going to do the anchors here, we need a lot of space here and we can't use that space. So I'm going to push the graft into the joint. Okay. And then we'll, intraline.
You don't go for acromioplasty or anything, correct?
No. I don't like, I'm again, I'm the leader against acromioplasty.
Okay.
Needle knife. So cleared that. Now this is where our nice. So okay. Cannula. Okay. Anchor. Yeah. So first the anchor, anterior anchor always. ठीक है. We are good.
Which anchor is going in now?
So this is the interline,
Okay.
5.5 peak, but without the needles.
Medial row. Okay. Near articular margin, correct?
Yes, correct. Correct. Again, you see, I'm going vertical. Cannula down. Anchor देना मेरे को.
बोट उलट्या बाजूने आलं. Cannula, say red cannula. Okay. First pass. Wait, don't move, don't move. Here we go. चलो. नहीं, मला आई स्ट्रॉन्ग देना पहले. फ्लॅट घाल. नम नम दे मग. फुसफुस फुसफुस. So imagine if we had kept a thick end on this side, we would have been compromised for space. So we're going to take the anterior one first in that sequence. अभी ऐसा पुल कर रहा है इधर तेरी तरफ.
Lucky 30, 42 months, 36 months.
इधर स्कोप दर, स्कोप दर, स्कोप दर.
So we are going through the anterior part of the graph, correct?
Anterior part of the graft, correct. थोड़ा मागे. Cannula. Done. पकड़ा. And then next. Correct. Scope पकड़ो. ओके, हे पकड़ो. पुढे जागा आहे. दुसरा अँकरिंग करून घे. नाइफ देना.
Dr. Ashish, have you marked on the graph for the medial row sutures? How you decide that you will be going through this part of the graft?
The first pass does that for me. The first pass has a fixed length of 16 mm.
No,
So
I am asking.
whenever I go full length,
I am
you don't
asking
need
for
to
the
mark.
placement of the suture for medial row through the
So
graph.
once I pass the first pass for the medial distance, the first pass when it goes in completely, water मत देना, अच्छे से देना. It takes 16 mm bite always. Okay. Now for the anterior posterior distance, one sec.
We have not got a good bite. There's a lot of fat here. We'll redo that. First pass देना वापस. There's too much fat here. Yes, fat. ग्राफ थोड़ा क्लीन करने का रह गया. चलो आई स्ट्रॉन्ग पीछे से डाल, इधर से डालते. यार नहीं ठीक है.
Dr. Ashish, there is a question.
Yes.
You have not fixed spots for on the graph prior to delivery for the medial anchor, correct? Medial row.
No, no, you can't have that because you won't be able to match it. You can make as many spots as you want, but you will not
But
be
then
able to find those spots.
how you will be judging that this under tension or is precise tension?
Because the measurement, the pre-op measurement decides that. So if you have measured it correctly, then we will know exactly. So if you remember, I put in the probe and then dictated how much I want. Correct? Cannula पीछे. Yeah. Yeah, I have a better bite now. Yes. So you'll see how I take the bites now. Cannula. The first green. That's why I took the green suture first. Will tell me where to put the next one. You see? Eye strong? Yeah. And then, so that I don't mix them up, cannula पीछे. I think I've got a good bite this time. दोनों चलो नहीं दोनों चलो. There's the first. This one is the second. Lock होता है. Lock होता है. One sec. One sec. All this fat is creating a mess. Looped into on. कुठला हे का? हाँ. नहीं, this is going through this, not this one. अरे थांब, ओढू नको. First pass दे. One sec. Here blue, white भी. नहीं भाई. झालं? हाँ, चल. ये रखो हाथ में. चल. Hey, focus. हा पहिला वाला आहे ना. तिथं लॉक होईल बघ. ब्लू ला अडकेल. बाइट ही नहीं दिया. नहीं डिप्लॉय नहीं हुआ. ठीक नहीं, वो बाइट ही नहीं है. ब्रदर डाल रहे खाचे में.
Yeah. चल.
High
strong दे. नहीं. चांगलं आहे ना. हाँ.
स्पीड खोल दे. सूचर वाला है क्या टेप वाला है?
Suture. Speed Iconics is the next one we'll show you. चलो. दे देना मेरे को फर्स्ट. हाथ में रखो.
ब्रदर ये डाल.
या.
ये डाल.
बीच में डाला है.
उधर दे अंदर.
So here you check where is your previous one and then accordingly put your next one. Next. Oh, आला.
ब्रदर तू तेरा हाथ फ्री रख.
एक मिनट ये टिश्यू निकाल.
हो गया चल कर.
चलेगा. चल. नहीं जाएगा. Yeah. Thank you. Where is mine? Yeah, this looks good.
High strong.
So having passed 4 sutures through the front end of the graph, it's now time to grabber them. Get the other anchor in. Grabber them. The Vicryl Rapid has not done its job, so that's why it's all coming off. ठीक है, चल. Needle knife. So this is a different anchor that we are introducing. This is a Speed Iconics. This is an all suture for the cuff. The advantage is that you don't need a pilot drill or a pilot tap. Yes. So you want to spread out the graph all over. It has a sharp end to it. And will expand to 5 mm. Okay, you need to pull so that it is deployed adequately. Eye stones, nice. So purely to add flavor to your, since you asked about it, I said we should show you this different. चलो, separate करो दो. कौन सा? Right pull करो. नहीं. Okay. हाथ सोड तुझा मध्ये येतो हात. Okay. Now. Scope पकड़. Eye stones. Correct. So that we keep the graph a little sloppy. I got it. Just realigning my graph so that we are not mixing up into. Nice. And then check where your previous suture is so that you are not overlapping that. Lovely. And next one. नहीं. We are good. Nice strongs. Here, pakad. So slowly the graph is coming back into shape. So come. Oh, we got a loop in there. I will redo that. One sec. Oh. I've managed to mix up this one. Pull that. Huh. Yeah. Okay. Yeah, that is where it is. So this one goes here. Perfect. And then these are our last two sutures, the blue ones. Okay. Check, Amit, which one? पानी. So checking where is my last one. And the final one. Okay. Nine. आपोआपच सुटणार ना. चल फर्स्ट पास. चल. And the final, hopefully. Right at the edge. We are done. So now we have to start tying them. Nine. So, we remove the cannula and start tying from back to front. Since we've already got one suture in there, we should know the order of our color. Okay. There we are. So I always do the central one first. This is where you will check the graph positioning and the length, tension. लगाओ. देखो मत मेरे पास. क्या? छोड़ो. वो गॉस्पिस लगा दो ओपन पोर्टल पे जहां से पानी निकल रहा है. वो छोड़ दो अभी, उसको करने दो क्लोज. सामने से आ जाओ ब्रदर. इधर सामने से. वो नहीं रे, किधर डाला है? इधर चाहिए गॉस्पिस. अभी पकड़ो हाथ नीचे वापस. फ्रैक्शन. हाँ. Noise. Okay. So it should not take another more than 14 minutes from here. Am I delaying, Swagat? Oh, really? Okay, so this is so I've done the third pair now. This is the fourth pair. So I go 3, 4, and then 2, 1. And of course I have to suture. If you see the length, anterior posterior length is perfect because my graft is brushing and flirting with the infraspinatus behind. Yeah. तो पास में आएंगे तो ही जोड़ी बनेगी ना. Come again? Yes, yes, yes. So the last step would be taking the stitches through infra. ये पकड़ो हाथ में. आइस दे दो. इधर हाथ में. Now here, sorry about that, you feel a little seasick. Camera was not in my hand. So I'm coming from the posterior portal to park my posterior sutures posteriorly so that that's well aligned. And now I'll grab my anterior sutures. Again, you should know your sequence. Yes, perfect. So here we go. The white ones come up here. वाइकल क्यों आ रहा है बीच में?
All medial row sutures are tightened, correct?
Always, always, yes.
Yeah. Now you'll be going for kind of a cross bridge or?
After the medial sutures are tightened. Correct. Thank you very much. Must. हाँ, चल. Again here, I'm going to try the second pair first. मनीष तेरे बिना मेरा कैसा होगा? वो ग्राफ कौन निकालेगा? तू रुक जा. Okay, so that still is the medial row. हो भेटला ना. आणलंय 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 तेच. चलो ये हाथ में हो. ओमेगा खोला है क्या? Thank you. Exactly. Why do we change? Especially in life surgery, we should replicate exactly what we used to do. So the graft is floating between the subscap and the supra. The recommendation is to tie the graft to the infra for sure and never to the subscap. So
okay, never to the subscap.
Come again?
You never tie with the subscap?
No. So Mihata says that will make them stiff and frozen. So never tie to the subscap.
If the gap is large, correct?
No, I'll show you. But that gap constitutes the rotator interval, which should be open. When Nihat has gone in the second time, he has noted in Hath ka position, he has noticed that the gap fills up with scar tissue nicely. So we've parked the sutures independently. Now, RF, please. We are coming to the absolute tail end of our procedure. So those who are sleeping can take their last nap. We'll be done. This is our...
The tea is served in the auditorium.
Acha.
Ah.
I'm lucky.
Everybody is watching you carefully.
I am also watching all. But there is one section which is very dark. So I can't see their eyes. The rest I can. Front section on the right side is very dark. But it's allowed. It's not a very fun procedure. This is a little challenging on many fronts. And that's exactly why I was very skeptical initially. Because to be honest, I have over the last 10-12 years flirted with doing arthroscopic lat dorsi transfers, and we just revised our first lat dorsi transfer after 16 years last week, which I think is a fair result. And I still have some of them doing so well that I have operated one patient with rotator cuff repair on one side and lat dorsi on the other side, and he can't tell a difference which is better. So I can, but he can't. So it used to be a good procedure till lower trapezius came in, spoiled everything. And then because I do only 3 or 5 a year, I can't be, the learning curve on each of these procedures is so steep. So I switched to the lower trapezius. And now I'm reconciled. For the next few years, we will not do lat dorsi. We will just do either lower trap or SCR. And exactly as Drumil says, my take is if it's a posterior superior cuff, massive tear, Hatsod, then I would prefer to do a lower trap for that patient. I don't think any one of them is a perfect answer. When the cuff is there, primary is a perfect answer. Okay? So, taking alternate bites, cannula ray. And I'll show you some fantastic anchor. This is our favorite one, the Omega. I would say it's a 3rd generation anchor because it has improvised on many fronts and eliminated the problem. Somebody whoever designed this has thought a lot about, from the surgeon's perspective, that what are his problems. Number one sec, something is trapped in there. I need to rescue that. Just hold this here. Ice tongs, please. Ice tongs. No, don't worry.
Is self-tapping?
Yes. Self-tapping, that's exactly. You don't want to tap and waste your time. So not only is self-tapping, ye ho gaya, chalo. So it comes with a peak piece, and this is like a barb which has a reverse wedge. So it going in here now, watch carefully. Go. So it doesn't matter. There's a hinge there that goes and locks in the cortex. You just remove it. That's it. Ye le. Ritesh, naya anchor tayar karo. And then there's a screw. And many times we can't find where is the hole. So here the sutures are all there, so they will take me to the hole and there's no way. So even if you are stuck and you can't see where you are, the sutures will let you go in there. So it's disrupted on the fact that there's no need of a punch. Number 2, your hole is never lost, so you're not searching for the insertion point. Number 3, for the price of 1, you get 2 fixation points. One is a barb type fixation, and number 2, you've got a
interference
screw inside. So you know that lateral side failures happen because that's the weakest part of the bone. And so in this manner, I guess that it's going to be so robust that lateral side failure will be a thing of the past. So from that point of view, I think Omega is really good. Time saving, ice tongs please, and sits beautifully well. Next, what we do is take the remaining 4 just like that. Pass it through like that. And then grab this directly. Ensure you go in line. And then position it just like that. And cannula upper. One sec. Old sutures old. Cannula. Yes. And just align the hole. Doesn't matter which side the barb is. You can see that the barb is here behind on the flange. Doesn't matter. The hole has to point towards. Pass it into that laser mark. Bas. Just take this out. Chalo. And
It's like speed bridge, I think. The metal owl is there on the tip.
No, I will tell you about the speed bridge later. This is not speed bridge. If I didn't tie the medial anchors, that would be speed bridge. But remember the second case I showed you during my SCR talk? That was a speed bridge which failed. The surgeon who did that told me that he wanted to do speed bridge once. The patient was a director of his hospital. They said he's affording, so let me do this because it's an expensive bargain. Pani. Idhar ka ban, idhar ka chalu. And so he did a speed bridge. But the speed bridge, what happens is, laterally, if it fails, everything fails because you're not insured medial side. Because the medial side there's no knot. समझ गया? ठीक है. चलो. So, that is our SCR. Now, let me just show you. You wanted to know the tension. Look at the tension. It is like a original rotator cuff. Okay?
Yeah, great.
No waviness. Moving isometrically. I will have to show it to you from below.
Anyway.
This is the margin between the infra. Can you see that?
Yes.
Infra and supra. I'm going to close that with two sutures. This is the margin that should be open here.
Can we see the graft as a whole?
I'll show you. This is the rotator interval. It's not a big gap.
Yeah.
It's not a big gap. I'm going to leave it open. It should be left open. And that's your entire graft now. And I can show you a different perspective.
Biceps निकाल दिया.
नहीं निकाला है.
Biceps is there ना?
Biceps अंदर रखा है.
Okay.
क्योंकि वो लास्ट में प्लान भी होता है. कभी कुछ फट गया तो जाएगा. So this is the whole length of a graft. Tension is perfect. It's sitting. The whole footprint is covered isometrically. है कि नहीं?
Yes.
And it is this edge that I need to close now. Just this one. Can you see that?
Yeah, couple of sutures.
Couple of sutures, yes. So, Swagat, if you want to continue with the program, or if you want to stay back, then
Finally, we wanted to see intraarticular picture. Means
I have to show you that. Yeah, let me finish these 2 bites.
Yeah.
It
We
will
are with you.
5 minutes.
15 minutes till.
Okay. Perfect. Good. So I am coming in between your lunch, so I will ensure you're not starving for too long.
The official 15 minutes.
We are not putting anchor for infra, correct?
No, not necessary.
Okay.
See, we don't want to over tighten them.
Yes. Oh, but
थोड़ा नीचे करो हाथ. Okay, so that's my bite through the infra, and now I will take it through the. I'll take it separately. One by one कर सकते हैं. ठीक है ग्राफ. मेरे को ये स्कोप पकड़. नहीं क्यों दूर पड़ेगा वो. अरे वाह. नहीं, we'll do it one by one. छोड़ दो. Yes. Okay. पकड़ के रखो. Yes. ते मागे काढून घे. हा इकडचा anterior part. So the anterior one will withdraw. Does that one? Yeah. हाँ ये bend हो गया. दूसरा तो yellow पे. Yellow. वर्टिकल आ रहा है वो.
What is the blood pressure just now? Systolic blood pressure? Swagat?
T/62 is the blood pressure.
Thank you.
I have to say the field has been absolutely exemplary. Bhavin's done a fantastic job. So that's her first one. Eye storm.
Today's stock exchange is closed. So full focus is on the patient.
Thanks to this man.
He is master. Bhavin Shah.
ये पहला वाइट है ना ये. ऊपर से काटता हूँ. दोनों एक इसमें लेना है. नहीं ते वेगवेगळ्या याच्यातून मिळाले असते मग दोन. हा चल.
So we are using the fiber wire, separate fiber wire for both stitches.
Yes, yes. So you can use the remaining, the ones that you have cut off from the medial anchor. काफी लंबा रहता है वो.
Not with the intact ones inside the anchors.
No, no, no.
Yeah.
So there are a lot of spare sutures anyway. But this is like the conventional mattress approximation.
Supraglenoid you tie, Dr. Ashish? Supraglenoid?
No.
Remnant cuff?
The glenoid anchors we have tied, yes.
No, no,
yes.
with the remnant cuff? No.
No. We cut off those sutures.
Okay.
Exchange
Medially,
rod
I was asking, yeah.
Yes. We cut off those sutures. That spare suture we are using. Exchange rod de mere ko. So that's our first suture. ठीक है. मेरे को वापस येलो देना. Okay. So that's not one more not done.
लंबा सूत्र निकालो.
Not happy with this angle. That's a smart idea. Right? Doing it so gently because I don't want to disturb these sutures that we've passed in before. Again, one at a time. De Maladi. Here.
आता दुसरं घ्यायचं ब्लू दे
नाही इथूनच घेऊ इथूनच घेऊ at this level. थोड़ा ऐसा रखो असं म्हणतो चलो
इधर से
आतमध्ये उलटा करेक्ट Follow me. I'm through. Last stitch. निकल ये वाला लेने का ये
डालो उसमें से
ये हाथ में पकड़ा ऐसा उल्टा ओके आई स्ट्रॉन्ग देना मेरे को दो नहीं घेना
नॉट पुशर
थोड़ा इंटरनल रोटेशन हाँ थम ये पकड़ अच्छे से दिखाना मेरे को
आटे लगाओ
स्लाइडिंग नाइसली
3 stitches.
Yes.
Do you think, Dr. Ashish, if you could have passed the suture prior through the graft and then taken with the infra?
So what happens is you don't know which level to put it in, and what happens is we already have 8 sutures inside, and you put 2 additional sutures. It will all get muddled up. In spite of doing all this, you realize that I had 2 stitches that were tangled, and I had to go back in and redo everything again. So that is a problem. The whole idea is to minimize the amount of sutures inside.
Yeah, but
and that's why instead of passing through, we put these needle anchors so that we can quickly and in a clean manner push in. This is okay. It has not taken a little bit of time. What has happened is
to push the lasso through the graft inside. It takes a lot of tension. No?
You think this was a problem today?
Yeah, what we were feeling in the auditorium that you were trying to push the lasso through the graft, which is still a risky thing, no?
Risky. Well, my life is full of risks.
Yeah.
Okay, this is done. Okay, we'll see what is happening on the glenohumeral joint. I think lasso is the most safest instrument because it has a much more smaller aperture through the cuff. Using any other device like bird beak and all is a disaster. My go-to instrument for passing sutures in cuff is lasso. So let's see, this is the real thing, the proof of the pudding. Okay.
Yes.
So glenohumeral joint, this is your subscap, and our biceps is intact in there, and this is our graft. Okay. The roof is covered completely. You see?
Yes, yes.
Completely covered.
Yeah,
Give me an exchange rod, needle knife. Needle knife, I have to cut the subscap anyhow. I have to cut the long head of biceps anyway. So I definitely need to make a portal here. But you have to make it very carefully. So that's through the rotator interval.
Disease.
So because I'm a very lazy man, my assistant is telling me don't do it. See what I'm doing? The same knife that came in to make that rotator interval, I have cut the biceps. Because you can tell I'm hungry.
It requires how much blood testosterone levels?
Till you are not dislodged. Till you are not dislodged in the joint.
Actually, I always use the rod. I always use the disposable needle for that reason. So, what the idea was to show you that I take this and take this out so that I can elevate the fat from the graft.
I've seen Dr. Anand Joshi putting ethibond on the junction of knife with the handle. Must have dislodged prior.
So, no, I'm just showing them the footprint. There's a lot of fat here. It's a abduction. Yeah. So that's our graft.
Great, yeah.
There it is. So all that was open, you could see the acromion through there. That gap you see there is the rotator interval gap, which is exactly how I want it. There's a little bit of fraying here that is obscuring your vision. And that's our suture, and that's our this thing. The GT is covered nicely. Move it continuously. Yeah, covered completely. So that's pretty much it. This is covered completely. This is on the glenoid side. You can see that this side was empty. The graft was coming. That's your graft. That's our insertion and the footprint. And it's a solid footprint. The entire footprint is covered on the middle side.
Can we see the tightness of the graft?
That you should see from the subacromial side. From here it's very difficult. I think we showed you the dynamic movement. Now, you want me to show again subacromially?
No, fat is coming. It's okay.
Yeah.
Yes.
Okay.
Perfect.
Thank you.
Thank
very
you.
much.
Thanks a lot.
We'll proceed towards the lunch in the
Great
basement.
surgery.
We are just coming there.
Yes. Thank you.
ડોક્ટર ભાવિન ઝુમકાવાલા, અમદાવાદ લીડિંગ સોનોલોજિસ્ટ, અને બધું જ મસ્ક્યુલોસ્કેલેટલ વર્ક સાહેબ જ કરતા હોય છે અમદાવાદનું બધું. So I'll give the mic to him.
Okay. Thank you, Swagat, for the nice introduction. Good afternoon. It is very difficult to take a lecture after the lunch, but let's start. Dear Dr. Ashish Bhai, Team DHS Hospital, especially Dr. Swagat sir, for choosing me to introduce all of you to the shoulder sonography. Myself, Dr. Bhavin Jumkhawala, along with my colleague Dr. Anil Patel and Dr. Hardik Desai, we are here to show you the excellent and useful modality of sonography. We have done postgraduate diploma course in musculoskeletal sonography from the UQAM University. Ultrasonography is gaining popularity day by day, and it is very much useful, and it is easily available to all corners of the India. With the advancement of the technology, minute details can be seen easily with the high resolution ultrasound machine. Sensitivity and the specificity are very high for the disease process. It's a static as well as dynamic study and scores over the MRI. When we should do the shoulder sonography, I would say it's a first line of investigation, and I will prove it. Indications for the shoulder ultrasonography is any complaint regarding the shoulder like joint pain, movement restriction, swelling around the shoulder, following trauma, normal shoulder X-ray, and the post-operative status to assess the cuff repair. Let's start with the biceps tendon. Ultrasonography of shoulders start with the identification of the long head of biceps. It has a fixed position. It lies between the greater tuberosity and the lesser tuberosity in the bicipital groove. It remains within the groove because of the transverse humeral ligament. This is right shoulder.
You need to tell them because they can't orientate.
Okay.
They are already
This is the longitudinal section of the long head of biceps. You can see the nice fibrillar pattern within the biceps tendon sheath. We cannot see the intra-articular portion of the biceps tendon on sonography because it goes inside the joint. Now about the bicipital groove. Bicipital groove in which the long head of biceps tendon lies, and it ends where the pectoralis major muscle insert over the humerus shaft. Above that is the bicipital groove, but below it the long head of biceps and the short head of biceps combine together to form a muscle belly of the biceps tendon. Now the short head of biceps muscle arises from the coracoid process and goes down, and it merges below the pectoralis muscle with the long head of biceps and forms the tendon. This is the live clip showing the origin of the short head of biceps going down and merges below the pectoralis major muscle insertion with the long head of biceps and forms the biceps belly. So you have to remember 4 things for the biceps tendon. First, the tendon should be seen within the bicipital groove. Extra articular portion of the long head of biceps should be evaluated in the long axis. Myotendinous junction at the level of the pectoralis major insertion and the short head of biceps origin at the coracoid process. Now we move to the rotator cuff muscle and tendons. It is again made up of 4 muscles: subscapularis, supraspinatus, infraspinatus and the teres minor. First we evaluate the subscapularis muscle. Subscapularis is a powerful internal rotator of the muscle. Muscle belly lies under the coracoid process in subscapularis fossa and it inserts on the lesser tuberosity by the side of the biceps tendon. Let's see how it looks when we do the internal and external rotation. When we do the external rotation, the subscapularis muscle will come out underneath the coracoid process, and when we do the internal rotation, it goes inside underneath the coracoid process. So it's a dynamic study and you can evaluate the integrity of the subscapularis muscle. In the static image, when we see the long axis, we have to also see in the short axis, and it shows multi-pennate appearance. Along with the subscapularis, at the level of the greater tuberosity and the lesser tuberosity, we encounter few ligaments. That is the coracohumeral, coracoacromial ligaments. Coracohumeral ligament is a superior ligament above the biceps tendon and sees above the biceps interval. While glenohumeral ligament seen below the biceps tendon, and they are helpful in evaluating when you suspect the adhesive capsulitis. Second thing, the coracoacromial ligament, which joins the coracoid process to the acromial ligament. They are seen very nicely during the sonographic examinations. So once again, for the subscapularis muscle and tendon, insertion of the subscapularis at lesser tuberosity with the external and internal rotation, you have to evaluate the subscapularis, which should be evaluated in the long and short axis, and you have to evaluate the coracohumeral, glenohumeral and the coracoacromial ligament. I would like to show you biceps and the subscapularis on the live demonstration now. Then we will move to the supraspinatus, and finally we will go to the posteriorly for the infra and teres minor. Can Vijay? शर्ट काढीने चिपकी એટલે એ લોકો કેમેરો છે ક્યાંથી મને મારે અંદાજ છે સાવશે પૈસા we have to evaluate the patient in either sitting or standing position. I prefer in the sitting position and preferably on the rotating table, so I can move the patient very easily. First I will ask, before starting the examination, I will evaluate the patient to clinically also. So I ask the patient to do the internal and external rotation, as well as I will ask the patient to take the arm back, and I will ask the patient to abduct the arm. दोनों हाथ यहाँ पे लगा दीजिए प्लीज़. हाँ, अब दोनों हाथ बाहर ले जाइए. हाँ, फाइन. अंदर ले आइए. दोनों हाथ ऐसे पीछे ले जाइए और लास्ट में ऊपर ले जाइए साइड में से. सो इफ आई विल डू such clinical examination, I will come to know where exactly the pathology is. I think Kalpesh bhai, you must be agree to this thing ke it should be done, right? The arm should be in the resting position. It should be relaxed. And first of all, I told you that you have to identify the long head of biceps within the groove. This is the greater tuberosity. You can see the echogenic rounded structure within the bicipital groove. You can see the greater tuberosity on laterally and the medial tuberosity or lesser tuberosity on the medial aspect. And this image tells that the biceps tendon is nice, showing a good echogenicity. The probe should be perpendicular. If your probe is tilted, it will be seen as a black or hypoechoic area, which again says okay, this is not a good biceps tendon. So the probe should be perpendicular to see the biceps tendon is bright hyperechoic. When you see the cross section nicely, you have to go down to evaluate the pectoralis major muscle insertion. This transverse horizontally situated band like structure is the pectoralis major muscle insertion. Here the bicipital groove ends, and above it is the bicipital groove, below it the myotendinous junction, and then you can see the muscle belly of the biceps muscle. So you have to go down to see the beginning of the biceps muscle belly. There is sometimes there is a trivial amount of fluid seen around the biceps. If the patient is not symptomatic, you can mention in the report that there is trivial amount of fluid seen around the biceps tendon, but it may not have any significance. When it is in the large amount, definitely it's a pathological thing. Next, when you see in the cross section, then you have to turn the probe and see in a longitudinal section. Here you can see the nice fibrillar pattern of the biceps tendon. The fluid which is seen in the cross section, now it is seen somewhere here. When you go above, the long head of biceps cannot be seen because it goes underneath the intra-articular portion. You cannot see of the long head of biceps. After evaluating the biceps, you have to evaluate the subscapularis. This is the coracoid process, and underneath the coracoid process is the subscapularis. When I do the external rotation, you can see the subscapularis muscle comes out of the subscapularis fossa and it inserts over the lesser tuberosity. So any pathology involving the subscapularis, the movement will not be that easy. After evaluation of the subscapularis, you have to go slightly above the greater and lesser tuberosity to look at the biceps interval. Here the biceps interval, the inferior part of the biceps tendon is formed by the glenohumeral joint, while the superior part is formed by the coracohumeral ligament. When there is thickening of this ligament, patient has a complaint of restricted movement. We have seen the biceps and the subscapularis. I think now we move to the lateral compartment, and that is for the supraspinatus. I think બધાને ખબર પડે છે ને કે નથી? Okay. Moving to the supraspinatus tendon. Position of arm is important, because if you want to evaluate the supraspinatus, you have to do internal rotation, and the arm should be on the back of the buttock or in the pocket position. It should be evaluated as well as in the short axis and long axis. Supraspinatus appears as a beak-like structure in a longitudinal scan. You can see the anechoic humeral cartilage, and there is a change in the angle of the bone from where the greater tuberosity starts. Overlying muscle is the supraspinatus. Above the supraspinatus, you can see a white line which is of subacromial subdeltoid bursa, which is generally collapsed. When it is distended, it is pathological, and above it is the deltoid muscle, and this is the skin and fat layer. After looking at the longitudinal axis, you have to see it in the short axis. Once again, the biceps tendon is your landmark, and from the biceps tendon you can see a nice fibrillar pattern that is of supraspinatus. The first 2 centimeter from the biceps tendon is the supraspinatus, and posterior to that is the infraspinatus, but you cannot differentiate between the supra and infraspinatus on sonography. Above that, we just mentioned that subacromial subdeltoid bursa is generally collapsed, and it's seen as a white line, but when it is distended, you can see the superior as well as inferior margin. Generally, when there is a pathology, when there is a tear, you can it is filled with the fluid or internally caused. When you evaluate the supraspinatus, you have to evaluate for the impingement. Impingement is when you ask the patient to abduct the arm. Patient can do the movement, but it is a painful movement. It is evaluated on real-time sonography. The supraspinatus muscle will glide smoothly underneath the acromion, and if it is gliding but not moving properly, then you can suspect impingement. So once again, in the supraspinatus, there are 4 things to remember: position of arm, long and short axis of supraspinatus, subacromial subdeltoid bursa, and with the abduction to evaluate the impingement. Now moving to the posterior part. Bony plate on the posterior surface of scapula is called the spine of scapula, which divides the supraspinatus fossa and the infraspinatus fossa. The infraspinatus muscle arises from the infraspinatus fossa, which is obliquely situated. The muscle below the infraspinatus is the teres minor, which is more horizontally situated. So when you evaluate the sonography, obliquely positioned muscle is the infraspinatus, more horizontally situated is the teres minor. both the muscles are useful to evaluate the echogenicity. When the echogenicity of either infraspinatus or teres minor is altered, it is because of the fatty infiltration or because of the nerve problem. The nerve innervation of infraspinatus is the suprascapular nerve, while the teres minor is the axillary nerve. So when there is a atrophic changes of either teres minor or infraspinatus, you can suspect the nerve injury and do accordingly. Again, the underneath the infraspinatus there is a posterior joint recess, and when it is distended with the fluid, there should be some pathology of the joint. Here, this is the infraspinatus, this is the head of the humerus, and between this is the posterior joint recess. This is normal. Normally it is not distended. Sometimes if you are lucky, you can see the triangular portion which is a labrum, posterior labrum. You can see injury to the posterior labrum can be seen with the high resolution sonography machine, or the patient is very thin and lean. Lastly, transaxillary. Inferior glenohumeral capsule should be evaluated in the transaxillary view. The capsule extends up to the shaft, and you can see nicely with a good machine. Normally the inferior glenohumeral capsule is less than 3 millimeter in size. In this case it is almost 5 millimeter, so suggestive of capsulitis, and you can say it's because of the inferior glenohumeral capsule thickening. Patient is suffering from the adhesive capsulitis. Once again, on the posterior aspect, you have to see the infraspinatus, teres minor, any fluid in the posterior joint recess. Let's evaluate this supraspinatus and infraspinatus on the sonography. ये हाथ जरा पीछे रख दीजिए पॉकेट में. When you ask the patient to put the hand in the pocket, it is easy because then the patient will not move his hand. So it is easy to ask the patient to put his palm into the pocket. Supraspinatus is made up of anterior as well as the posterior fibers. You can see the long head of biceps. When you go up, the supraspinatus will start, and anteriorly there is a angle formed by the greater tuberosity and the cartilage. When I go further upwards, the plate will become straight. Now you can see the head of the humerus is almost horizontal. When I come anteriorly, it is a little bit angulated, but when I go posteriorly, it shows it is a horizontal. So when I see the humerus horizontal, I can see that I am looking at the posterior fibers. When there is an angle, I can see that I am looking at the anterior fibers. Fine. So from the longitudinal section, you can evaluate whether it is the anterior fibers or the posterior fibers. Anteriorly, I told you that it is a beak-like projection of. It is seen as a beak-like muscle inserting over the greater tuberosity. Once you do the longitudinal section, then you have to turn the probe, and now you can see in the transverse section. Once again the biceps muscle you can see as a good rounded shape, and from that the laterally the supraspinatus starts. First 2 centimeter is the two supraspinatus and posteriorly the fibers of the infraspinatus. So you can't really differentiate which fibers are of supraspinatus or infraspinatus. You have to just measure the things from the biceps tendon, whether it is within the 2 centimeter or away from the 2 centimeter. So you can see the differentiate the supra and infraspinatus. Above the supraspinatus you can see the white echogenic line, that is of the subacromial subdeltoid, and above that is the deltoid muscle, and most anteriorly is the skin and fat layer. The muscle is intact, there is no cortical irregularity, there is no fluid in the subacromial subdeltoid dorsa. After looking at this, then I will evaluate for the abduction. Here I have to put the probe over the acromioclavicular joint and ask the patient to abduct the things. It will glide smoothly. When it is gliding smoothly, we have to consider that this is normal. This is the acromioclavicular joint. The joint capsule is flattened and there is no fluid collection seen within it. Once again, with the abduction, you can see the muscle is gliding smoothly. So this is the way you have to evaluate for the impingement. Lastly, on the posterior aspect, थोड़ा भैया टर्न हो जाइए ऐसे ऐसे बस. This is the spine of scapula. Above it is the supraspinatus, and the below it is the infraspinatus. So sometimes the clinicians ask whether there are atrophic changes in the supraspinatus or infraspinatus. We can compare the things of the muscle belly of the supra and infra and can give whether there is any atrophic changes or not. In a longitudinal section, you can see the infraspinatus tendon merges with the supraspinatus and insert over the greater tuberosity. Below it is the more horizontal muscle, and this is the teres minor. And when depth better. And I show you that if you want to see the posterior joint capsule, ask him to do the up and down movement of the shoulder and you can see the posterior joint capsule. ऐसा कीजिए भैया, अभी बताया था ऐसा. And if you go slightly laterally, you can see the spinoglenoid notch where the suprascapular artery and the nerve are lying. It is difficult to demonstrate on this machine, right? So lastly, we will evaluate the transaxillary view. Ideally, it should be evaluated in the supine position, but it is not possible here. So I will like to show you in a sitting position. The white is the head of the humerus and above it is the inferior glenohumeral capsule. When it is thickened, it is one of the cause for the adhesive capsulitis, right? So I think shoulder sonography needs to learn this. You require a long curve, but once you learn this thing, it will be very easy, and you can finish the exam within 10 minutes, and it will give you the result comparable to the MRI. I have shown you few cases. Let's have so the cases. Patient have female patient, history of fall before 1 week, painful movement of shoulder, no fracture seen on the plain X-ray shoulder, sent for the ultrasonography to confirm and rule out the muscle tear for the further management. Here once again the biceps tendon is seen within the groove. Longitudinal section shows nice fibrillar pattern. There is a trivial amount of fluid seen around the biceps tendon. Subscapularis appears normal, and there is some amount of fluid seen within the subacromial subdeltoid bursa. Once again, the anterior fibers of the supraspinatus are deficient. The subacromial subdeltoid bursa shows sagging, and there is an anechoic defect at the greater tuberosity. The tendon is retracted in the anteriorly. The posteriorly, the fibers are intact, and there is some amount of fluid seen in the subdeltoid bursa. On the transverse section, you can see this is the biceps tendon, and there is an anechoic defect involving the anterior fibers of the supraspinatus. Posterior fibers are intact. So the diagnosis is partial width, full thickness tear of supraspinatus. Here, if you measure the width of the supraspinatus from the biceps tendon, it is almost 1.2 centimeter. Generally, the footprint area is 2 centimeter. So 1.2 centimeter is almost 50% of the 2 centimeter. So we can say that there is a tear almost involving the 50%. Infraspinatus appears normal, and the comparison with the opposite supraspinatus, the opposite supraspinatus was almost normal. So I will report as follow. There is a partial width full thickness tear of anterior fibers of supraspinatus. Let's understand the meaning of each word. Fibers near the biceps tendon are anterior fibers, and the fibers near the infraspinatus are the posterior fibers. Anterior fibers are torn, posterior fibers are intact, so it's a partial width. Total width of supraspinatus is 20 to 25 millimeter from the biceps tendons. Now we understand the meaning of the full thickness tear. Defect is seen from the articular surface fibers to the bursal surface fibers. So it's a full thickness tear. When it involves only the articular surface fibers or only the bursal surface fibers, we can say it is a partial width, incomplete thickness, or partial width, incomplete thickness tear. Let's see one example. And this is I would report as a graphical representation where the subscapularis biceps are intact. In the supraspinatus, the anterior fibers are torn from articular surface to the bursal surface, and the retraction is almost 15 millimeter from the greater tuberosity. Yeah, please.
Actually, in our interpretation, usually we refer full thickness or partial thickness medial to lateral. Here, as you have shown correctly, you are measuring anterior, posterior as well as medial lateral. So, for all purposes, this is a full thickness tear for us. It is partial thickness in anterior posterior direction. right? But the major supraspinatus attachment is in that area, around 1 to 1.5 centimeter just behind the bicipital groove. So for all practical purpose, in our interpretation, this is a full thickness supraspinatus tendon tear.
Full thickness but partial width.
Partial in anterior posterior, but we usually complete tear actually. So for suppose somebody is not looking at the image, is just to the report, they will interpret as a partial thickness tear.
नहीं what what I mean to say, from the biceps tendon, the footprint area is of 2 to 2.5 centimeter from the biceps area, and we see in the coronal section, right? Just this is the image where here is the biceps tendon, right? This is the biceps tendon. From here to 2 centimeter is the footprint for the supraspinatus. It is okay.
We clinically or for arthroscopy, we consider this as a full thickness tear only.
Full thickness tear, yes, full thickness, partial width.
Either it is full thickness or it is not. We have only two terminologies.
Incomplete.
Yes.
Width is incomplete.
Yes. Yes.
Okay.
So, yes. Because there are
other lectures
as well.
Okay, fine.
And
So
if you can demonstrate frozen shoulder or something on sonography live, I have called 1 or 2 patients. So if you can demonstrate how cuff tear is seen live on patients or frozen shoulder is seen, then you would love to see that.
okay.
So this case is 70 or 75-year old gentleman. He was operated for greater tuberosity fracture before a year somewhere else, and he presented with restriction of movements and not able to do forward flexion, abduction or his daily routine activities. And it was like this since he was operated. So how it is seen on sonography? Oh, dada. This way. Shirt cut next one. Operate on left shoulder. So mainly purpose of this workshop was for to evaluate if most of us who are working in corporate, they have some sonography access in OR or in OPD. So we get frozen shoulder patients so commonly. So if we can see the patients, or sometimes we discussed in the morning that post-operative patients cuff intact. So we should know, or we would be able to do this under, so we can give the injections or evaluate the cuff status dynamically post-operatively. So you would like to see that.
The machine should be good enough to evaluate.
Yes.
Generally in the private setup, or because of the cost of the machine, it will be difficult.
It is sky high.
Sky high, right? It's 15 megahertz.
High frequency.
High frequency. બંને હાથ આમ રાખજો પ્લીઝ. ધીમે ધીમે હાથ બહાર લઈ જાઓ.
Yes. We have seen the reports all the time.
બધા અંદર લઈ આવો. ફરીથી બહાર લઈ જાઓ. કેટલો જાય છે તમારો? મારો હાથ આટલો જાય છે. આ નથી જતો? આટલો જ છે. ઓકે, બંને હાથ આમ પાછળ લઈ જશો. આ નથી જતો, રાઈટ? પેલો હાથ અને લાસ્ટ સાઈડમાંથી ઉપર લઈ જાઓ. So he has a restricted in the external rotation, or as well as he is not able to take his arm posteriorly. Let's see the things. And depth हो चुकी है. First of all, you have to identify the biceps tendon. It is in within the groove. Then I will go downwards, but there is a large amount of the fluid seen around the biceps tendon. This is not normal. I am going further down to see the insertion of the pectoralis major muscle, and then I will see the muscle belly. So muscle belly appears normal, but there is a large amount of fluid seen around the biceps tendon. The tendon is seen as a hyperechoic area. Surrounding hyperechoic is the fluid. When I evaluate it in the transverse section, then I will turn the probe and see in the longitudinal section. In the longitudinal section, the fibrillar pattern of the long head of biceps is seen, and around that there is a large amount of fluid seen in the biceps, around the biceps tendon. અહીંયા દુખે છે તમને?
અહીંયા દુખે છે.
આ દુખે છે?
સ્ક્રૂ અહીંયા મારે.
અચ્છા, અહીંયા આ હું જે કરું છું એ દુખે છે? દુખે છે. He has some pain over the biceps tendon also. Then I will ask the patient to do external rotation to evaluate the subscapularis. This is the coracoid process, and underneath is the subscapularis muscle. There is a large amount of fluid I can see underneath the subscapularis muscle. So there is a large amount of joint fluid is seen. You can see the fluid movement. Can you appreciate here? The subscapularis is intact, but there is a large amount of the fluid. This is the coracoacromial ligament. Now I will ask the patient to put the hand in the back pocket. પાછળ મૂકી દો દાદા. બસ. Once again, this is the biceps. Then I am going back to evaluate the supraspinatus. Supraspinatus is intact, but there is some cortical irregularity, suggest previous fracture. I am going posteriorly up to the acromion process where the supraspinatus is end. Then if I go more posteriorly, I will able to see the part of the infraspinatus. So from anterior to posterior you have to move, and then you will see able to see the supraspinatus to infraspinatus. Once I have seen in a longitudinal section, this will be the cross section. There are multiple cortical irregularities seen in the head of the humerus.
It must be osteoarthritis or post-operative GT.
X-ray should be helpful. We can say only that there is a quite cortical irregularity. So cuff is intact. Now we will see on the posterior aspect about the infraspinatus. Infraspinatus is also intact, and there is a fluid in the posterior joint recess. You can see the distended posterior joint. The fluid is echogenic. I will compare the echogenicity of the supraspinatus as well as the infraspinatus, and both are the same, so there is no atrophic changes, and the teres minor is also normal. So there is a excessive amount of the fluid within the joint and around the biceps tendon. Lastly, I would try to see the inferior glenohumeral capsule. Here also you can see the large amount of fluid within the joint. So the fluid within the joint might be one of the cause for the pain and restricted movement. The cuff is intact.
Okay.
Cuff is intact. So from the plain
Adhesive capsulitis.
because of the joint effusion, he has a lot of pain and restricted movement. X-ray would be of help to evaluate the osteoarthritic changes. Right? Thank you. No, Dada નથી પૂછ્યું. I think I have shown the advantages of the sonography. It's thank you team DHS, thank you Swagat
Thank
for
you,
allowing
Bhavin
us
sir, for
giving
such
us the good opportunity.
such a great
to
learning experience for us.
Because nowadays what happens that all the orthopedic surgeons they prefer MRI on the first instance, but I would request that evaluate, and sonography is equally good modality to arrive at diagnosis. Yes, of course the cost factor in MRI is much more, while the sonologist will be at much cheaper rate. Thank you.
And advantage of dynamic study is
Dynamic study and plus the procedures. I have few slides and the live clips where we have done the intervention in form of the introduction of the lignocaine plus steroid at various sites, PRP injections for the tear and certain things. So sonography is very much useful in intervention procedures. Thank you, Swagat.
Thank you. Thanks a lot, Bhavin sir.
Thank you. Thank you.
लाइट बंद कर. For Bhavin sir and Anil sir, there would be a few mistakes. If it is there, please correct me if wrong, because we are not master of this. So with this, I would like to start my lecture. Role of USG, or where we can have the use of sonography in our day-to-day practice. So mainly these are the two diseases, frozen shoulder and calcific tendinitis, where there are some role. So first about frozen shoulder. So the history of frozen shoulder starts with 19th century, where there are in 1872 journal they had given the name periarthritis scapulohumerale, and till date we are not able to evaluate the final treatment. Even in 1932 there are in the journal it was reported latino bursite, and in 1945 it was labeled as adhesive capsulitis. So are we using any clinically some classification or staging system practically for treatment purpose? Do we use? Are we using any classification or staging practically for treatment purpose? Kalpesh sir. Yes, for frozen shoulder. Acute phase resolving. So first is the classification, that is primary and secondary, and for practical purpose we use stagings. So acute stage or inflammatory phase, which is painful phase or inflammatory phase. This is a stiffening phase, and this is thawing phase. So generally we give a treatment in which phase, or what is the general guideline of treatment in these phases? Or in inflammatory phase, which treatment should be done? Yes, rest and anti-inflammatory is for painful phase, and in stiffening phase we go forward for, or thawing phase we go forward for further treatments. And there is also a Navier staging system. It is arthroscopic along with histological and clinical. It is very detailed. We will not go into much detail of this. So any particular criteria used for diagnosis? Mainly Campbell had described three criteria: internal rotation restriction, external rotation restriction, and abduction, less than 90 degree of abduction. But neither all three should be present, so it is neither sensitive nor specific. So we diagnose mainly clinically. So in treatment, as you said, at which stage treatment should be started, and till when we should continue the same treatment. So first treatment is conservative treatment. But as we all know that no single conservative treatment option is found to be superior to other. So at some point all conservative treatments fail. In what we used in conservative treatment, NSAIDs. There were before advancement of anything in orthopedics, they were using oral steroids, but in current modern day orthopedic practice there is no role of oral steroids. So there were papers for oral steroids. It is of 1954 paper, but we don't use that in current day practice because of well known side effects. Then after conservative treatment, next stage of treatment is physiotherapy. But again, there are reports that physiotherapy alone, I am talking about alone physiotherapy treatment. So alone physiotherapy has no benefit as compared to any control group. Then MUA, how many of us do MUA? There are papers of that they recommend the use level A evidence for to restore early range of movement and improve early function, but it is at the cost. It is at the risk of iatrogenic damage to upper limb, humeral fracture, glenohumeral dislocations, cuff tears, glenoid fracture, brachial plexus injuries, and whatnot. Hydrodilation. Do we give hydrodilation? Yes. So to be done in OT or OPD? Yes, sir. Yes, I am coming to that, sir. Yes. Yes. So alone in OPD, but it has patient does not allow generally because of pain and the procedure is not complete. There are very good reports for better treatment, but it is a mixture, not alone hydrodilation, not alone MUA, or not only a steroid. So it is silver level evidence that arthrographic distension with saline and steroid provide short-term benefits in range of motion, but it is uncertain whether it is better than alternative medication or not. Arthroscopy for frozen shoulder. All the recent papers suggest arthroscopy only rather than MUA or any other thing. But after all, it's a surgery. So patients beware of surgery, and full 360-degree capsular release is required, and excision of rotator interval is the key. And any role of superior edge of subscap release, if too much restriction of external rotation, it is still yet controversial, and there are also higher risk of injury to or iatrogenic injury to axillary nerve if inferior towards inferior glenoid. And last is steroid injection, which is not only steroid, it is the steroid lignocaine with saline hydrodilation. So, but if given blindly, then it is highly variable. And shoulder joint distension along with saline and steroid at 3 months, they have significantly improved function and pain, and which are also maintained for a longer period of time. Analgesic use was significantly lower, and it is concluded that distension with steroid can seem to help in management of frozen shoulder. We give it USG guided, and accuracy of shoulder joint injection with ultrasound guidance, and they have confirmed with MRI images as well. And can we give this treatment in first stage so that we don't go to the stiffening phase? So it can be given, and it can be done OPD based as well. I practice it in OR only, but it can be done on OPD base. So how it is seen on sonography? We have just seen everything. I think it is sir, in a rotator cuff interval, how the hypoeconic thickening or vascularity do you see routinely in Doppler by putting that Doppler window? Okay. So I just wanted to show the this video for needle. Anyway, and heading forward the next topic, which is calcific tendinitis. I would like to ask sir, what is the reason exactly behind the calcific tendinitis?
Then that will lead to calcific tendon. But there's a metabolic abnormality. Those are the patients you will see that they have recurring calcific tendinopathy, left shoulder, then right shoulder, and vitamin deficiencies they will have. So usually you have to understand physiology where if there's the hypothyroid patients are more likely to have calcific tendinopathy and they are recalcitrant, they'll keep having them back again. So if you look at sources of hypercalcemia or secondary hyperparathyroidism, so whenever there's a calcium deficiency or a vitamin D deficiency, there is a reflex activation of the parathyroid gland. So
Any role with, because patients ask with calcium tablets.
So again, evidence, nothing.
Yes.
Not a single paper that says that. Amongst which, if you are giving calcium citrates, the chances of dystrophic calcification are less. If you are using calcium carbonates, then it is high. But it's not so simple. If you look into science, then you realize that calcium carbonates don't get absorbed. They are like chalk. And so they result in hypocalcemia patients. And that's why they will have a high result. It's not a calcium that's going and creating the calcification.
So symptoms are generally very acute. Patient had nothing before 2 days and suddenly started developing and not able to lift the shoulder at all. So might be secondary to hypovascularity in the zone where there are degeneration or fibrosis. And there are many complex classification, but this is mainly sonographic classification where there is large well-defined shadow, and in most common, it is most common in 80% of patients it is seen. So diagnosis again, diagnosis is mainly clinical, and on X-ray, we just saw the X-ray in the morning, and on CT scan. On 3D CT, the calcification can be appreciated. So do we see this much thick amount of calcium deposits in acute calcific tendinitis, or it has to be long standing?
All of them are long standing.
Long standing.
All of them are long standing. It's acute and chronic usually.
Yes. Actually, this patient's X-ray was almost normal. Yes. Inflammation. Yes. 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 And this was
a little modification on what Nirbhai said. You are right. The calcification lays up layers of calcium. The body has no problem with that. The day that calcification bursts, it incites a heavy inflammatory reaction.
Yes.
So they will say, I had a jerk, और वो बोतल गिर रही थी, मैं पकड़ने गया, and उधर से चालू हो गया. So that just broke that calcification.
And this is how it is seen on sonogram because of calcium, just like a stone. There is a huge window behind. And on MRI, yes, this is where we are not able to pick up so easily on MRI because it is not that good seen on MR images. But still, lot of inflammation, bone marrow edema. So, in what should be the treatment apart from sonographic barbotage? Is there any other treatment options? So there are one needle technique, two needles techniques, but basically we go inside, and this is the needle coming up, which is perpendicular to the probe. No video has ever run properly to them. That's it. Thank you.
Whether it is compressible and then you should go for barbotage, or when it is hard, then you should take the call for arthroscopy.
Both are amenable to ultrasound, but there are many calcifications who don't have pain. The acute inflammatory, it's like labor pain. Those are the ones that need intervention. Somebody is a quite incidental calcification, there's no need to remove it. because they are compatible with rehab and they are just weak or something. When they are in the acute inflammation, they are desperate for pain relief. So our metric is anything that's between 10 and 15 mm. We'll mandate a ultrasound and successfully you can sabotage about 10-15 mm in a OPD basis. You can't do it under GA because you need them to keep moving and you want a dynamic action. Less than 10 mm, 4 mm, 5 mm, we just ignore. We just tell them take a painkiller, take a Flogam, start your exercises. When they're more than 20, then it is inconceivable that you can do it and the patient can get a syncope or it will be too much of pepper potting the skin. So those are the ones I would leave for the surgical excision.
That's it. I would like to know.
So if you do them ultrasound guided, you will never be the repair because you are just doing pepper potting and whatever damage there will self. The moment you do arthroscopy, then your whole deeper defect. So I counsel the patient that we will do this, but we don't know how much it is. If it is intramuscular, then you have to use fluid, then you have a big white defect there. If that defect is 5-6 mm, I leave it because there's great advantage if you start rehab within 8-10 days and then they get better. And start rehab and within 6 weeks they are done. The problem is you repair, then you immobilize, then you wait, then 6 weeks. The whole small treatment is now continuing for. Now there is no perfect solution there. So I clearly tell them, if I don't repair, you will recover faster, but you will take a long time to get the strength back. If I repair, then you have to wait longer, but you'll get your strength back. So when you're dealing with somebody who's an athlete, then you can't leave it be. Somebody you're looking at a pen pusher who's middle-aged, then I said I will prefer it this way. So what time is coffee, Swagat? What time is coffee? Huh? No, I was so damn sure that I'll be delayed with the surgery and with all the seniors there. I wasn't sure how much time I'll have for my case owners. No, I know. So I'm good. I have tons of stuff. I can keep you occupied. I have some very interesting cases. So just to give me a fair idea on the timeline, how much time do we have? Yeah, nothing else. So shall we do coffee 15 minutes and come back and then start, or do you want to wrap up early? I'm good on both. I have to admire Tushar's diagnostic skills. They are exemplary. But I'm not inflexible. I'm good. I can talk while having coffee. I'm good. We'll go with the... Perfect. Right. So, I'll do something not as a case scenario, but this is a patient I operated recently, and here's an interesting case. And moment I get an interesting case, I stop my OPD, call my fellows, and then start through. And he had all the signs. We were talking about subscap in the morning, or I think Prathamesh had a lecture on that. It's very on examination. But I will tell you something. Subscap doesn't get diagnosed easily, clinically. Subscap doesn't get diagnosed radiologically, both ultrasound and MRI. I will qualify that statement. And arthroscopy also is often missed. When I first went to Cape Town to work with Jody Beer, I went there to learn arthroscopic cuff repair because I thought I had sorted out my instability. And when I went there, I started seeing him doing subscap left and right. I said, "Ye to kabhi dekha hi nahi tha. This is 2005. And then I saw so many subscap. Then I got a drift. I understood, and I said, "Man, big subscap tears." And I said, "This is fantastic. I want to learn this." And I said, that time, Joe Dibier, whenever he meets me, he keeps reminding me. I called it the last frontier of the shoulder. उसके बाद तो कितना पानी बहा, कहाँ वो हाथ लटाजे और superior capsule और lower trapezius, but that was big that time. So I came back and understood subscap cheese भी है और subscap होता भी है, and we are neglecting. So some of our failures definitely, cuff patients were not doing well, was not technique related. We are just missing out subscap, which is probably the most important muscle in the shoulder. तुम्हारा सुपरा नहीं है, काम चलेगा. मैंने बोला है तुमको, कुछ कुछ पेशेंट चल जाते हैं, पर तुम्हारा सबस्कैप नहीं, गारंटीड कुछ भी नहीं चलेगा. That's why was very alarming when Swagat said the stiff shoulder में upper subscap. I was in a meeting in Mumbai when one of the England returned Mumbai surgeons was sat there, and he was speaking on arthroscopic adhesiolisis, and this is 2007 or 8, and he said, so when things are difficult, when are the bad stiff shoulder, I would release the CA ligament and I would cut the subscap. I said, hello, cut the subscap. Well, like, cut the subscap, immediate full external rotation. I know, but that's you have taken out the vital pillar out. Where is the force couple there? There's a lot of argument to and fro, and we are the only ex-England guys, and the others were like stunned ki ye kya ho raha hai base mein. But that's appalling. So subscap is unpardonable. Any idea why this happens to subscap and supra gets all the credit, and we discuss more of supra and very little subscap? Why? There are 6 tests for subscap and there are only 2 tests for supra. Why? How many? Teres major, sometimes anterior deltoid. So, and look at each of them. एक का size देखो तुम. Lat dorsi, pec major, हाँ? पूरा मोटा भाई है. उनको force couple कौन है external rotator में? Infra teres minor, chiller pillar है. समझ गया? That's why. So when the subscap goes off, the others are robust enough to compensate for that. And that's why you're testing. And don't tell me that if you do empty can, pure supra का काम होता है. ऐसा नहीं है. Your positioning is such that you eliminate some and maximize subscap, तभी वो subscap का गड़बड़ टेस्ट होता है. ऐसा कहना है. Number 1. Number 2, subscap is a schizophrenic muscle. It is said that the lower subscap and upper subscap behave differently. That's why you have a Gerber's test and you have a Napoleon test. The Napoleon tests the upper subscap and Gerber's tests the lower subscap. In addition to this, this premise is based on a paper that was published on anatomy in 1960. Everybody refers to that. So I am not sure it's valid, but it is true that upper subscap behaves differently than lower subscap. Upper subscap, what you see on arthroscopy, you are looking at only the upper 2/3. You don't see the lower 1/3 or lower 2/3, which is muscular part. तो उधर क्या चल रहा है पता ही नहीं. Number 3, 90 or 95% of the subscap repairs I do, I don't know what you do, what I do, are all type 2 tears, max type 3. So they all get done arthroscopically. You get a genuine type 4 tear which is completely torn, migrated. It's a rarity. When fellows come and see, like this patient was in theater, our fellows were thrilled. They said, ऐसा तो देखने को मिला ही नहीं हमको कभी. ना भूतो ना भविष्य. So that's why most of the tears you're seeing are partial tears. Partial tears को we discussed. It's a challenge. Addressing them, diagnosing them and treating them. That is the mystery with the subscap and has been long neglected. And also the arthroscopic subscap came in much later. So this was one of these patients that came in. And so just testing, this is his empty can test. Let me show you his range of movement first. So about 3 months history, predominantly I think right, pain, stiffness, night pain, had a fall twice, and he's about I think 62, 64 years old. Okay. Decent. 65 ER, 110 ER on the left. So Drumil, question coming out to you. I'm giving you as much information as I have. So left is about L3, right is about L4, 5. And then forward flexion. So it's very painful on the right side. Almost like a pseudo paralysis, right? I mean, this is pseudo paralysis. What else? So that's the empty can. External rotation. Decent. Horn blowers. It's not bad, huh? For somebody who has a pseudo paralysis. It's not grade 5, but not bad. That's a hint, Drumil Terli. That is my subscap test. Call it the ASB subscap. Yeah. I rely a lot more on this. Look at that. There's no resistance. It's just going off. One finger. Normally that subscap is the most powerful. Then coming up to Napoleon. Watch. On the right side, it's just dropping off. The elbow cannot be kept at the equator. It's dropping back. He's using some other compensation. What is he using? Okay, so that one is Laderman's test. Alex Laderman, this one. So I hold his forearm and I try to do an external rotation on the body like that. He holds my hand and he tries to do an internal rotation, and that's done in neutral. And he just has no resistance at all. Okay. And then the fourth test, this would be the Gerber, I think. So first we do it on the left side, which is asymptomatic, and he pushes and he has good strength. I'm finished. Go ahead, shoot. Yes. Can I ask you to come in? Yeah. This is exactly Basta Melanson and Christian Gerber had a nice tete-a-tete at Annecy, and I was with to that. Basta is coming for the conclave in Jan in Pune, and I have not seen any shoulder surgeon do a shoulder exertion as profoundly as Basta. And minute intricate details and the biomechanics of every test and all. So it's a showman. So when I'm doing a test of Gerber, don't put the arm there. It's not meant to be right. It's meant to be here. And it's a push off. So it doesn't have to be there. So when I'm going to just put my hand in the rock, keep pushing. This pure subscap, and I leave it. Keep pushing. And if it remains mid-air, that's a push. Okay. When you're your elbow and doing this, that's pressure. You cannot use that way. When I do this and he's just not able to generate any force, then it's a complete subscap here in figure. But if he comes off and I leave him and he slaps back, then it's probably a partial test. That's the difference. The whole mechanics of the Gerber test, it has to come off the back in that direction, not like this. This is different and this is different. So, any formulation of opinion on his clinical finding? Yes. Subscap always nahi. Subscap almost always. If you have a pseudo paralysis, that subscap is gone. Seriously. Yeah. Yeah. I go with you. Yeah. So, yes, he's had history of trauma twice. Once on the left, once on the right. He's had previous shoulder pain, now not pain on the left, now intense pain since last 3 months on the right side. In my clinic, I get 3 to 5 minutes with the patient. So I usually do the standard tests. I don't do subscapulae. It's not a common condition. The common one is a supraspinal tear and impingement and instability and blah blah. But there are certain patients I will certainly go and do a subscap test. The giveaway is that when you have a weak supra, which is most patients do come in for that, even if they have impingement, it might be 4, it might be 3. And that is almost always associated with a weak infra. Now that's the set norm. So you're looking at patterns. And that is what I'm looking in my clinic for. So when I get a pattern of supra, infra, it is standard stuff. If it is grade 4, go for impingement, go for rehab, blah, blah. If it's less than that, then we do sonography, MRI. And then because we have to optimize as well. We can't send all the patients down to MRI and sonography as such. But when I get a supra weak and I get a strong infra, it doesn't add up. That is the pattern which is anterior superior, and I will immediately do the subscap test. Same as here. Same as here. For somebody who has a gross, phenomenal drop arm pseudoparalysis, to maintain that Hornblower's even at grade 4 is an achievement that his posterior superior cuff is intact. His anterior has gone for a toss. So that is the first thing that should go in your mind. And so that got up. Moment I see that, I call all my fellows, this is interesting, come in here. And we did that. So that's his active range of movement. Passive range of movement, anything there, Drumil, between active passive? Exactly. So when you get an external rotation which is wider than the normal side, what does it mean? Full thickness, you're talking about subscap 4, 5, good. That's how it is. So he has all these findings there. It's a classic case in the making. So these are his MRIs. The left side we got our MRI done, so we have to relent with his images. But you can see there is nothing here. There is nothing here. The first giveaway is you don't have a biceps there. Okay? So when you don't see a biceps, and biceps is sublux, because biceps goes very closely with subscap. Do you know why? No, it's not. It's the pec major that covers it. Pec major moves across the groove. The subscap is... So the pulley is a contribution of the SGHL and CHL, not the subscap. But if you go to the subscap anatomical studies, the transverse humeral ligament, which maintains the long enough bicep in the groove, is not a ligament. It is the sleeve of the subscap muscle. समझ गया? और लफड़ा biceps और subscap का है. When the subscap elopes, the biceps runs away with it. So that's why whenever you see an absent long head of biceps, take it from me. There is nothing here. It has gone. So that's a full thickness avulsion, and sometimes you'll see it somewhere there inside there. It's gone here actually. So that. So you can see the infra coming in nicely as a sweep. Infra is most certainly intact there. Okay. Supra you can't commit here, but this subscap is not seen anywhere. And in sections 1, 2, 3, 4, 5, 6, 7, 8, almost 9. It's a full length, top to bottom. 9 is 50 mm, 45 mm, straight away. Up here, you've got a supra tear, you can see that for sure, but all the inflammation is in the anterior slices, where the subscap is supposed to be. And that biceps is tenuous, it has fallen off medially here. Totally. Yes. Disability is also more worse. Disability is also more worse. So you should read the paper by Philip Collin. He has classified 5 different sets of this thing, a very nice diagram, and how to approach which and when to do which transfer, which ones will behave differently. So there are the combinations of partial subscap with full supra isolated, full subscap with supra, or full supra with infra. Aisa. Nice paper of Philip Collin. Anything, Drumil? This is the right symptomatic side, that is the left. Left का है वो? Oh, left का है. I knew you would jump there. See, बोलता जल्दी है सोचता बाद में है. No. So if you look here, look at the T1 side. It's brilliant, right? There is something happening in the subscap here, but the supra is perfect. Look at infra and teres minor, pristine. So that's an anterior superior pattern there. Okay, but it is early. It is early. It's a true 3-month history. So nothing has happened there to wasting point of view. You can see all the inflammation is localized focal only on the subscap belly there. Purely. And is bald here as well. And the best way to diagnose, these are his MRIs, the left one. The right is our MRI. So the rotation is not correct here. We should be able to see the LT insertion sagittally in profile, for which they need to do an external rotation, but they don't do that. This one is perfect. Now what do you think about this? Same pattern. Supra, brilliant, infra and teres minor, pristine, unblemished. And what's happened to subscap? There's almost 50% wasting and infiltration. So that's dated. So that must be a year old. And he gave a history 1.5 years back. And so this, if you don't test them clinically correctly, you would never send him for an MRI on the left. We are blessed because we have a sonography in the clinic. So moment we realized that, I checked him, I found weakness on both sides. He said his left is okay. So we sent him for sonography. They said a massive subscap tear on the left as well with a supraspinal tear. So then you better do that, because what is going to happen is we are going to repair the right, which is blatantly obvious. For the next 2 to 3 months, he's going to load the left, which is incapable of supporting him. He's going to be in agony. And then he'll eat your head, and there's nothing you can do till such time that this recovers completely. So we decided to offer him both options. We said we'll do the right first and left later, or we'll do both together. They come from a village 300 kilometers off, so they decided amongst themselves, they said we'll do both in the same sitting. So we've done a bilateral simultaneous repair. We are showing you the right, because the right's the exciting one, because type 4 subscaps are very unusual to get. The first thing you do is you go in, biceps is subluxed. So that's complete. And when you look at the anterior shoulder, it looks pretty normal. It doesn't look like a tear. And that's unusual, right? That whole subscap profile is there. Normally I would expect it to go beyond the glenoid, but it's there. Biceps is off the groove completely, and that's your supra tear here. Empty, complete footprint here. So there is a big supra tear. There is, on MRI, there's a big subscap tear. Not much wasting on the T1 side. Infra is intact. See, all that is infra. The infra, I told you, sweeps ahead of the supra and sits in there. So what's going in your mind now? Pavan, Drumil, Swagat. Correct. Absolutely spot on. So it's not your typical substrate. It is a sleeve avulsion. The whole piece is intact. So वो पूरा छील गया ऐसा. जैसे scalp छील जाता है वैसा. So that's a sleeve avulsion. You can't do this to the glenohumeral joint. It has to be done through the subacromial joint. Number one. मेरे को एक पानी bottle लेना please. And so it has to be done subacromially. Thanks. It has to be done subacromially, but because it is a sleeve, when you go subacromially, everything is going to look intact. You will not know. But if you look closely here, what I am showing you here is the footprint is empty. The entire lesser tuberosity footprint is empty. It is naked. Now you have to decide how to repair it. So what I am doing here is I have to take my ice tongs and I have to find out which piece to pull out. Correct. So if you pull the correct piece, then it will pull it back into its position. समझ गए? So if you don't pull it at the correct extent, so that you have to define which is the comma. Sorry, which is the comma. So if you know where is the comma, then you will be able to pull it back into its native insertion. नहीं तो बहुत tight repair हो जाएगा. Tight repair हो गया तो to add one more, 2 points more. So we've got a plan that's pretty hodgepodge. In principle, all of you are correct. Chirag said to preserve the comma tissue, take a bite, prepare the footprint, 2 anchors, perfectly right. Okay, you told about the rotator interval release. You told about the biceps. You told about the tenodesis. All of you are correct. What sequence do you want to do it? Because if you don't do the right sequence, it's not going to work out. We have to preserve it. Because if we do a tenotomy, that bicep is going to slide down completely. I do lots of tenotomies for all my rotator cuffs. But subscap, I cannot do a tenotomy because pulley is gone. Probably not. It looks good. Good. Coracoplasty? So I never do it. And only Steve Burkhardt does it. Across the world. Across the world. We'll come to that. The first thing I would do is an interval release. Because when you put your scope, you can't see anything. You want to see the joint from outside so that you're oriented and you know your reference points. And your biceps is accessible then. So, first out of the box, then the rotator interval in that order. Firstly, for the out of the box repair. Then the let's be tenodesis. So, because the pulley is gone, you cut the biceps, it's just going to slide down. Because the subscap is gone, that sleeve that was the alleged transverse humeral ligament is not there. Whereas in rotator cuff tears, all this is intact. So you resect it there, it's going to go and snag there. It will never go into a Popeye sign. So I'm not ready for the tenodesis. I will just put the anchor, take one suture through the biceps, cut off the biceps, then it is lying there. And just, I need 7 sutures of the 2 anchors for the subscap. And so I will sacrifice 1 for the biceps. I won't use 2 for the biceps. So take it out. Moment you take it out, it opens around. What is very important is nobody said the axial nerve. It is mandatory, obligatory in a type 4, type 5 to be able to see the axial nerve, ensure that you are not taking a bite of the axial nerve because your suture, as he says, comes from all the way down. You always start bottom to top. So you take your first bite there, you are very, very close. Not only that, because it is retracted, it has moved exactly in the neighborhood of the axial nerve. Actually, along with the axial nerve, more frequent than the axial nerve, I have seen surgeons taken bite of the conjoint with the subscap. Because scope इधर है, उधर क्या चल रहा है मालूम नहीं, वो तो टिश्यू है, आउट ऑफ द बॉक्स है, तो वो नहीं होना चाहिए. वो हो गया. I have seen that we have to go release them. the patient goes into an interrotation contracture, drop arm जैसा होता है उसका. And then ensure the conjoint and subscap are not kissing each other, and then start from bottom to top in exactly the same sequence that Chirag has said. So this is the first step. We are doing a rotator interrelease, so you have to find it. It's all closed. So your biceps and your subscap fibers will tell you exactly where the rotator interrelease. So it was very easy to cut off this. We didn't. We came on the medial side of this because everything is retracted. Whenever you see a MGHL that is vertical, trust me, it is a medially migrated subscap. That is the other hint, because the MGHL has to go from bottom medial to lateral out superior. And that also tells you where the comma tissue lies. So after having done that, so that's our complete, we see the coracoid, we see the undersurface of the coracoid, and then clear up all that tissue. And then this is the separation of the subscap adhesions from outside, the superficial part of the subscap. So we've cleared up those adhesions there. It's usually stuck to the conjoint there. And then identify the axial nerve. So if you see here, all we are doing is just using the blunt end of the RF. And if you can see the three sisters, then that is your best way to locate your axial nerve. And because this is a chronic case, there is a lot of adhesions, you have to be very careful. Not using the RF as a RF. This is using RF as a blunt instrument. And now you look here, this is the location, and you won't see anything till such time that you are very close to the axial nerve. Coffee, but thoda strong, thoda additional डाल देना उसमें. नहीं. So if you have not crossed the conjoint, then you are safe. If you cross the conjoint and go further medially, then the musculocutaneous is there. So for the musculocutaneous, you have to go anterior to the conjoint to see the musculocutaneous. But here, just below the conjoint. Sometimes you put a Wissinger and lift up the conjoint and then separate this tissue. Just do a blunt dissection like what you do with your finger or your scissor. And there it is, right there. It's a big nerve. It's a big nerve. And now you see my bites are going to come right here. But now when I know where it is visually, you can just proceed ahead. So that was done as the next step. Now this is showing you how close my sutures are to this conjoint tendon. So when you are, especially I am fond of taking the indirect suture shuttle with the ideal. If you're using the first pass or the scorpion, then it's probably not. But the needle can go through the conjoint. So you have to be able to see where the relationships are. And then move on. And then do a cuff assessment. So I'm now coming into the conventional subocclusal portal like what we did. And then finding out, oh, it's quite a big tear. It's an L-shaped tear. So I'm going to pull and see that it's reparable. Because you do a subscap type 4, spend 40 minutes doing that, and then come back and find out, kya re ye supra to judne hi nahi wala hai. So it's a wasted exercise. Then you might as well have done a reverse rather than spend so much time dissecting all the tissues. So I need to confirm that yes, because it's all in tatters. There are multiple layers as well, but it looks like a good quality tissue. So once that is done, then the first thing I would do is address the biceps. So, because you see it's right in the way of my visualizing where the comma is, how to pick up the subscap. And then you, once you've taken the bite, you just resect the tenotomy. So we'll just fast forward. This is standard stuff, nothing exciting. So you do that. Now you look here. This is pre-biceps tenotomy and this is post-biceps tenotomy. Look at the difference. Your entire, on the right side, you can actually go down, see where the subscap is, pull up the exact comma tissue and bring it down. That is the hell of a difference. It's just a small tendon in your way, but just obscuring your complete vision. So any subscap, you first need to get rid of your biceps. It's right in your way, but don't cut it off. You need to take a bite and do a tenodesis for that. Then you start inferior to superior. You can use whatever floats your boat. You use a scorpion. I use a ideal suture passer or any indirect suture passer. And then pass these sutures in sequence like this. The advantage of those are that you are making very little dent in that degenerate tissue, not big holes, no risk of damage to the nerves. And that's your final repair. So that's your that's the cuff on the subacromial side. The taste of the pudding is you don't know how well your subscap has gone into home position. So you have to come back into the glenoid joint and then see for yourself, yes, that subscap is entirely seen as a thick sleeve. The entire footprint has been completely covered. Nothing is left bare open. Then you proceed. So that is the planning that I would do for outer black. It's rare, it's not very common, and you do it once in 3 months or once in 4 months. You just need to be careful. But the key point I'm still trying to make is identifying the subscap tear. This one is type 4, everything was classic, but clinically you see how deceptive it was that the left side tests were normal. So we moved to the left, and the left had a type 3 subscap tear and a large cuff tear, and his tests for subscap were all negative. The Gerber, he did very well on the left side. So there is a lot of fallacy in subscap testing because of the fact that there are other compensating internal rotators. So I miss them out. So I pick up a subscap, then it's okay. But I don't pick up a subscap, my scope goes in. It is very easy to miss a type 2, type 3 tear. Very easy. Because the subscap slides, it doesn't look like a tear, it's partial. So key thing is, you see a comma. Number 2 key thing, MGHL is not oblique, it is vertical. Then, if in doubt, just put in your eye strongs and pull that superlateral corner. If there's play there, if you can lift it off, it's a tear. Then you do a repair as such. Right. Where are we? Okay. Let's change the theme. We do an epilepsy case. So, 41-year-old lady, epileptic for God knows how long, and very skeptical, doesn't like to come to the hospital, dislocates frequently, reduces herself, has no inclination for surgery. She's a little anxious, she doesn't like coming in, she's from Goa. This time what happened, somewhere in October, she dislocated without epilepsy, and she could not reduce it, and that freaked her out. Anterior dislocation, classic anterior dislocation. That freaked her out. So she, for the first time, agreed to come to the hospital and then came to Pune. Husband told me she's very anxious. Whatever you do once because she's not coming back again. She's not coming back. So I saw, sab pura banduk laga ke. So classic, everything was positive, crank jaw was positive, no ligament laxity. On this, you had a big Hill Sachs. You had a little double cortical sign positive, and on the CT you had about, I think, 13-14% bone loss, 17% bone loss calculated. Nah, I'm good. So what? Pawan? ये इधर. So you guys picked it up, I didn't. So we planned for Atholataje. We went in. That day we had 8 cases, and usually our Atholataje is the last cases. Amit, my assistant, tells me that day everything was spooked. He said the implants are not available for the first cases, the reverses we'll do last. So there's a lot of shortage of supply. Can we do the Atholataje first? I said, ठीक है, क्या है, 1 घंटे का काम है, करेंगे. So we started with this case first. And I come in, and it's a long day, and I put the scope in, and this is, the moment I've cut the rotator interval, this is what it is. Okay. And for a change, we had done the x-rays. It was okay. So we just got caught out, and I saw this, and knowing that this is a difficult lady and anxious and won't come back again. She's a female, yeah. Yeah. अरे तू रुक जा, अभी तो कहानी शुरू हुई है. So phone, called up the husband, like ऐसा हो गया. So what are my choices? I'll take the ICBG. So he said, साहब आपने शुरू किया है, करना तो है, go ahead. With Faiz, he's already counting his chicken now. कि साला कहाँ से आए इधर? So I said, okay. So we'll change to doing a ICBG. So the technique on ICBG, don't take the graft. Drill the crest, put in your top hat, then do the osteotomy. You do the osteotomy and then put in your top hat, you will damage the graft on table. So we ticked all the check boxes. We did everything that was right, took that graft, put it in the, निकाल के split. So, Houston, there's a problem. We have a problem. बाकी second phone call. Husband is like, कहाँ से इसके पास आ गया? गोवा में रहता. I said, ऐसा हो गया है. I can't help it. This is epileptic. I can take the opposite iliac crest, but that is also likely to be this, because she's epileptic. They have these liver enzyme problems. It's extremely osteoporotic. So I said, what are my chances? I'm thinking on my head. ये पहला ही केस है. अभी दिन शुरू हुआ है. So I said, my only next chance is do an allograft. So you should consent. ऐसा ऐसा है. ठीक है. So then we got an allograft. We have it on the fridge. So we got it. We used the tibial this thing, allograft, and we executed a perfect Lataji. Fortunately, because by then the brain was on a toss, it was completely fried. But the allograft bone was of a top quality, absolute top quality. It sat in there, absolutely pristine, looks flush. It's made for there. There's a nice 2 screws, nice hold. Everything is looking good. Went back, told her everything. So here we do the X-ray, and when we see, so you can see the coracoid lying there. So because we do a true AP striker notch view, we didn't do an axial. If we should have done an axial, we would have found it out easily on that. So, पवन जितना स्मार्ट तो मैं था ही नहीं. आज पवन ने सब 10 on 10 सब पकड़ लिया अच्छे से, है ना? Right from the sleeve aversion to the coracoid fracture. Gosh. And then everything went well. We've actually done a CT scan, so I'm not sure whether I've included that here or not. 8 weeks, this baby is full range of movement. None of my arthrolaters are like that. 8 weeks, she's thrilled, she's happy, she's full range of movement, and she's so confident now. Everything is good. So, well, no strings attached, yes. So, I have till date never done a Remplissage. I have this debate, and to add conviction to my my attitude, I have spoken to Laurent twice, and Laurent Lafosse has never done a Remplissage with an arthrolatage. I have one exception. There's a Bangladeshi patient whom one of my fellows, Jahangir Hussain, did a Latage, executed to perfusion, much better than what I taught him. I later came to know he worked for Jean Kenny in Toulouse, who does a lot of open latages. He's done very well, but he was still dislocating after that. And we thought the screws were hitting the head, and there was a hill sac. So he's the only patient that we've gone in. But that was not during the procedure. That was as an afterthought, because the latage had failed. We have done a remplissage in a latage and removed the screws. So that's acceptable. No. I do remplissage. I do fair amount of remplissage. When you add a graft to that, you make any health sacs on track straight away by extending the curvature of the radius of curvature of the glenoid. Yeah. Yes, quite sure, definitely. But Europe doesn't do a latage in elderly. We have a string of patients on elderly, because India being India, they come so late. So my research fellow is now doing work on reviewing all our elderly latages, elderly above 50. So we have a big string of patients who are doing that, and we have no problem with doing arthrolateral in them. But it is dicey. It is not the same. I agree. You have to be absolutely. Firstly, our coracoid is small. You have to be absolutely spot on with your sizes, the screws, and you need 2 screws. Really. So I told you, I started as a skeptic of arthrolatase, and then I saw Laurent, and then he did 5 in a day, and I was switched, converted. एक दिन में धर्मांतर हो गया मेरा. I said, this is what I have got to do. I had gone to find faults with it because people were attempting to do arthrolatase and killing the nerves, damaging the coracoid. I saw one arthrolatase being done, coracoid half, 1 screw fixation. I said, that's not on. So then before I start commenting, I said, I need to learn that. Fortunately or unfortunately, I don't know, but we have been very good with the coracoid. And the coracoid is a very funny bone. You look at all your tibias will go into varus, the femur will go into anteversion. The coracoid is funny because it goes like this and it turns like this as well. So it's curved in 3 dimensions. If you understand the native anatomy, then you will know how to pass your screw through it. That's why when it freaks me out when some companies promote the AC joint fixation with endo buttons drilling through the coracoid, huge complication rate. The coracoid fracture is very high, the endo button will damage it now, 3 weeks later, 4 weeks later, because it's inconceivable that you can keep your scope in a gluteal joint and get a perfect central drill hole through the coracoid. I have had one case where I have had to do that in a patient, and it was a complete my error, small coracoid. I have had 2 cases where I have my osteotome violated the proximal hole, the beta hole. But the screw still, it was just one rent in that hole. 3/5 of the hole was intact. So we put in a screw, it stayed in there. So as far as possible, my aim is to get 2 screws in. एक ही patient है मेरा कि जो एक screw वाला है. That becomes a blister then after that. Still works. So several comparisons between one Philip Morer study, very interesting, Latarje versus Ilek rest bone graft transfer, and both do extremely well. Couple of other studies where they said that you can get a much larger graft from the ICBG, but most of that graft will undergo osteolysis as opposed to the coracoid. So by putting in a big graft doesn't mean that all of that is retained. So a lot of heavy osteolysis is expected in those patients. The other thing, this is a very interesting Robert William article. There are 2 actually. Somebody here was working with Toulouse. Anybody working in Toulouse in France? I met somebody. Anyway, so these 2 studies, there's a big trend now of moving from screw arthrolatase to endo button and cerclage, no button. I've had one patient who refused to do arthrolatase with me because he wanted something without screws. And what a pity. And it's moment that patient refused and went off, I was hurt and I thought, is that the future and should I contemplate? And I started vacillating, should I not, should I not? And there was a little guilt hanging there, are we pushing screws too much? But the conviction you have with putting screws and the graft, and it's so rock solid. I have no restrictions on my arthrolatase. If they want to do this, they can do this. As compared to my Bankard and cuff, I will ask them to stick to 90 and not go above 90. Arthrolatase can exceed. It is amazing the amount of recovery and the kind of robust fit they have. Robert Williams' paper, biomechanics study on cadaver, lateral loading. Because the graft is loaded laterally, it's not loaded from the front. Because the head of humerus, when it's dislocated, is going to load that graft laterally. So a fantastically designed study comparing 2 screws, single button, double button and cerclage. And the comparison was crazy. The arthrolatase 2 screws resisted 50 to 90 Newton force. The endo button Latarje resisted 5 to 7 Newtons. And single or double button, it didn't matter. There was consistent micro motion, which was measurable. Cerclage was even worse. Which means that if you have micro motion, you are going to have non-union. You cannot mobilize. The conclusion of that paper was it's a good study, it's a good technique, but go very slow. Now go to Nicolas Boniviel. And I met him in person. We did a instability group meeting in the French Alps mid-Jan, 15th of Jan. And Nicola started doing endo-button arthroscopy because he wanted to give his patients an arthroscopy. He's trained by Pascal Boileau. He worked with Pascal Boileau for a good year. And Nicola is presenting on open Latarjet screws. I said, Nicola, what are you talking about? And I have read your paper. And then he admitted, and he said that he switched to the endo-button arthro-Latarjet, did the study. It is published in JSES 2021 or 2022. At 3 months, no union. 9 months, average to union. And he said, I can't have it because all these are adventure players in the Tulu and they are all high-speed athletes, cyclists, racists, skiers, rugby players. He gave up. This is a reality nobody is reading. And then I dissected, and I have been thinking on this. What I have realized is those who are doing instability in lateral like I do, then we are going to have a big trouble converting ourselves into B-chair to do an arthro-Latarjet. But we want to do an arthro-Latarjet. So then you have to come from behind, and then you are compelled to do a 4 arthro-Latarjet, which is a endo-button arthro-Latarjet. So it is not about why we are doing endo-button. It is because we are adapting the patient to our skills. And the cerclage is even worse. We want to eliminate the implants. But you can't expect that kind of union that you have with screws with cerclage. I spoke to 2 of our colleagues who started doing cerclage. They had graft failures on table while tightening with the tensioner. Pascal recommends 60 newtons. These guys are doing 25 and 30 newtons and still the graft broke because it's an Indian bone. And when the graft breaks, it's over, game over. So we have to be, it's very easy to get excited when a new surgery is introduced, whether it be SCR, whether it be endo-button. You have to wait, mature, ensure that it is truly successful and it can be extrapolated to our requirements and then decide to proceed. So I'm still guarded on this. So that's why we have to be very careful. Yes. So this was something that we came across. Tell me, क्या करना है? Any questions? Yes, we've done a few allografts. We use the femoral head allografts to shape this thing. But I went off that very quickly. These are typically the hatchet set deep ones which are not amenable to our remplissage. But I've spoken to Youngalri and there's an Italian lady who's from Milan, Francesca. So I've discussed with her also. Youngalri did a lot of them and he didn't publish them because he said all of them underwent osteolysis of varying degrees. So they didn't get integrated, or if they got integrated, they just lost the bone as such. So now I'm worried. So I have these 3 epileptics that I have done long back. I haven't had a follow-up from them. So it is not as clear. The Americans do those metal implants, but that's not FDA approved and it's all experimental. So I don't think we have a clear-cut answer from anybody yet on that front. Yes, yes.
So what do you expect from the sonography from her on her report about particularly about the tear of the rotator cuff?
Yes, sure. So there are 2 perspectives of this. I spoke to the MSK Society, Radiology Society meeting in Thane once, and they asked me the same thing. The entire talk was, what do you expect from us? I said, because she's my wife, if you ask me what does a woman want, I have no idea. But professionally, if you want me to ask me what do I want from her, then yes, we can. Number 1, we heavily rely on that. We were just talking to our other fellow who's currently with us, Harsh, and he was telling ki madam to kabhi galat hi nahi hota. We have a thing on that. You know, sometimes there is this debate, tear hai, nahi hai. She says there's tear, I say there's no tear, or vice versa. And she's leading 5-2 with us. So I'm being very careful to take cudgels with her. But we had a elbow case the other day. Unilateral stiff elbow, young girl, 17, and nothing else to suggest rheumatoid. but X-ray was normal, and I sent it to her, and there was vague synovitis. And so she came in, walked in. You have to do arthroscopy. I said, I can't do arthroscopy. She's just come in first visit. Let me investigate. Let me find out. You do arthroscopy. She needs a biopsy. Why? Well, that's Cox. Because Ravi Kumar, her boss from KM, he's like God for her. Told me that ऐसा है, single joint है, rheumatoid नहीं है, तो वो Coxy हो सकता है. But there's nothing in there. So I said, okay, okay. So the next day I came, what have you asked her? पहले आके पूछती है. तो I said, I sent her for MRI. She goes, किससे शादी किया मैंने? ऐसा that look she gave me. I said, but you can't just X-ray पे ऐसा arthroscopy नहीं बोल सकता. You have to earn it. You have to justify it. शायद MRI में कुछ निकलेगा. MRI में कुछ नहीं निकला. Synovitis है, some cartilage loss है. So finally I said, we'll do, because the biopsy is not going to work. I was hoping she would say biopsy, we get some tissue, we get a diagnosis, you get a handle, and then do the arthroscopy. She said that biopsy with a gun is going to cost 17,000 rupees. It will give us nothing. You might as well treat her, get her released. So we actually did that, and we sent the scrapings. She had a small lesion on the radial head on the MRI. And so I said, osteomyelitis TB is extremely rare. TB joint I can understand, septic. So we sent scrapings of that and synovial tissue vague आ गया, lymphocytes, granuloma वगैरह. Scraping जो किया bone का accurate से, Cox. Yesterday the report came. So my fellow doesn't waste any time rubbing in. Madam का वापस correct है. So
it's a very false understanding that it's a Cox synovitis. The Cox always comes from the bone to the joint.
Yeah.
So we always miss that. If there is a bony erosion, it has to be Cox and nothing else.
Absolutely. And in this
even in the knee, even in the hip, it always comes from the bone into the joint.
Absolutely.
So even if there is a small erosion, you have to understand it has to be Cox. She was right.
Absolutely. You learn it the hard way, Nirbhay. I do all the time. So whenever a patient comes in fresh in my OPD, they come all over the place. There is no time to come back next day. My OPDs are alternate days. So I just send them to her. She gets an ultrasound. She tells me, maps me, 20 mm tear, 30 mm tear. We are on the same page. Everything is confirmed. The challenge is not those. Or I'm doubtful there's a pseudo paralysis. It is pain driven. Her sonography is normal. I tell them, if her sonography is normal, you don't need anything. We are going to rehab. बहुत pain है, हाथ ही नहीं ऊपर में, छोड़ दो. We will take over. My physio team is excellent to do that. The challenge, controversy, and the contribution from your side is those partial cuff tears, small cuff tears, full thickness है कि नहीं. And that is between 4 to 10 mm. 10, 12 mm, severe pain, motor deficit. I will actually do surgery for them, maybe. But less than that, even if they are partial cover that. Once we have decided that this is a massive this thing, then I will definitely get an MRI, because I am not comfortable operating a patient without a MRI. Because I need to know fatty infiltration, I need to know retractability, I need to know where is the cuff standing. From your point of view, you tell me 30, I can go in and find out that it's 35. 30 and 35 में बहुत ज़मीन आसमान का फ़र्क है. पहली बी और दूसरी बी में जो अंतर है वो वही है. Because 30 repair हो जाएगा, 35 शायद नहीं repair होगा. And in surgery not repairable, I have nothing else. I have not explained to the patient. Whatever I do, best MRI, 3T, sonography, I cannot comment on the elasticity of the cuff कि ये दुरुस्त होने वाला है कि नहीं होने वाला है. And the quality, वो तो अंदर जाके मालूम पड़ेगा. The major contribution from her side that comes is, this is neuropathy. Yeah. So early Parsonage Turner will show up on ultrasound and not show up on MRI. And same patient 3 months later comes back, on the MRI you get all those patchy signs, high signal on T1 and related to one myotome, and that's clear-cut Parsonage. But if you pick up, and clinically we pick it up because the deficit and the weakness is profound. It's not like a cuff tear. It's not type 3, grade 3. It's type 2, type 3. So those are the ones we pick up. Very commonly in our OPD, we'll find MRI is normal, patient very poor, zero cuff strength. I tell them on the face, this is calcific because that behaves like this. MRI will never find that, those small things, and she will pick it up. So that works. This is what we need as such. It's all theoretical. In my practice it is, because I don't operate them. So it doesn't matter, they are grade 1, grade 2, grade 3. They are all going to get treated with the same, I will paint them with the same brush. Okay, so whether it's type 3 almond or type 1 almond doesn't change my practice at all. For me, a full thickness tear which is 2 mm, 5 mm, 10 mm still doesn't mean anything. He deserves a trial. Suppose I give a trial and he doesn't do well, I still have the surgery as an option. Most of them will get better. And if somebody doesn't get better, then I can still offer him surgery rather than operating all those small tears and making them painful, stiff, and then it's a elaborate journey. And then I can't undo them. There is no control alter delete in the shoulder. Yes, sir. Anything here?
Usually the large tears are not stiff.
They are not stiff, yes.
Yeah.
Yes.
But if by chance some patients are having stiffness with large tears, will you
Again-
wait? Will you release and repair? What will you do?
So Chirag, that comes with a qualification. Most of them, although they appear stiff, their pain-induced stiffness, you take them into theatre, you put anesthesia, the stiffness is gone. And wait means how long wait? If they are sitting on the edge at 40 mm, then I am playing with fire. Because 40 का 45 होने में एक हफ्ता भी लगेगा और 3 महीने भी लगेंगे. उससे कम, उससे ज़्यादा तो नहीं लगेंगे. And then it becomes irreparable. So if I am dealing with a 60, 65 who's reparable, if he is 75, then I have a plan B of doing a reverse shoulder for him anyway, as such. So it's a very unusual thing. Unless there's cartilage damage and unless it's showing up as OA, then that's a different ball game. It gets a different, and then there's no urgency because I'm not going to repair them anyway. So exceptional. The worrying thing or the worst cuffs in my hand that have gone bad are the ones which have a double crush, cervical spine, C5, C6 with a cuff tear, and those don't get picked up. That's very important. And post-op they just don't do well because they just don't recruit, strength in aati, and they just drag on and on and on. Nothing we can do about it.
And last question.
Yeah.
And what about the post-traumatic large cuff tear associated with brachial plexus injury? Will you wait for brachial plexus to recover, or will you repair and then let recover the?
Is that an
remaining?
RTA? Yeah. So if it's an RTA and acute brachial plexus, and it was associated with an inferior subluxation because axial nerve, then do repair because that head hanging down is stretching the plexus even more. So there are about 2 or 3 articles to support this in literature. Otherwise, there's no support in literature on this. But if it's a chronic brachial plexopathy and that patient will come to you after 6 months, then don't even touch it because he's just not going to do well. Most of them will reverse. Usually not when there's pre-existing neuropathy, and that can be. I know there are 2 cases of Latarje with Anil Bhatia now, and the debate is between the anesthetist and the surgeon who's responsible for the post-op palsy. Oh, you missed it. I was the chairman of Society Against PRP. I don't think it works. Somebody has to really convince me, bribe me. It will work more. Bilkul. I haven't. Extremely rare, 1 in 1,000. But that too after 6 to 8 weeks, not before that. But I have seen Hiro Sugaya recklessly give steroid injections. The Japanese system is different. In his OPD, I have seen 89 and 92-year-old ladies, and their appointment is at 9:52. They come and sit out at 9:51. Seriously, consistently. It's not an exception. Consistently, and they'll walk in and they'll tell me, "I have pain. I can't do myself. I'm alone." No. He will immediately take a jab. It's all preset in a packet. Nikalega, pain karega, thak, go. Doesn't matter. 3 weeks, 2 weeks post-op, pain nahi hona chahiye. So, yeah. They don't like that. They did very disciplined society. अपना सोसाइटी वैसे ही घटिया है. ऊपर से अपना पेन टॉलरेंस तो इतना है कि साला उसका उंगली भी कट गया तो पहले काम खत्म करता है और फिर हॉस्पिटल में 2 दिन के बाद जाता है. So, I'm loath to doing that. load to them. But after 6 weeks, if they have pain, then they cannot do their rehab. Then maybe 1 in 1,000 I would give them. See, the pain comes from cuff. We think it's synovial. The pain comes from the cuff. The day you strengthen the cuff, that pain disappears. So you will have noticed, or maybe go back and find out कि patient 3 हफ्ते से exercise कर रहा है, पहला 15 दिन कुछ भी नहीं हुआ, next he tell you 16 day मेरा pain गया. वो 16 pain का कोई जादू नहीं है. That is the day they manage to bring the head in the center of the glenoid. Moment that happens, the efficiency of the cuff improves immediately. It starts firing. You need 20% recruitment of the supraspinatus to be able to keep the head down. But the head is off, then whatever rehab you are doing is not working, because the cuff has to invest so much to try and recruit, because it's off center. It's off center. That's why. तो वो बाम्बू को उधर रोप लगाएगा और उसको कंट्रोल करके खड़ा करेगा तो होगा ही नहीं. तो इधर पैर लगेगा और खट से ऊपर उठ जाएगा. इतना एफिशिएंसी होता है. That is the difference. So my physios are very good at recruiting the cuff. Moment the cuff is recruited, pain comes down. They don't need analgesics. I don't give them. Don't give them.
And any role of kind of preventive acromioplasty in symptomatic impingement?
Zero.
Minus.
Zero. I've been through the era where, as registrars and fellows, we used to do 3 and 4 acromioplasties on every list. That was the norm. Subacromial therapy karo, nahi to acromioplasty karo. And it was stupid. It was reckless. And then we went from that and why convert a smooth acromial into a rough acromial? So, cross my heart, haven't done a single one like that. I don't need to. If I do that, my OPD mein, I will be in the theatre whole day.
So with this, we would like to conclude, because we have flight to Pune. Thanks a lot for coming all the way and clearing all our doubts, like from scratch to the most advanced level.
I enjoyed it. It was great fun.
Memento, flower.
Tal vez. વિરાટ સર એક છે ને અહીંયા મૂકી દઈએ જેમ લેતું જાય
Getting 3 SCRs and whatnot.